Assalamu alaikum. Good morning. Welcome to everyone, ladies and gentlemen. This is wonderful to see everybody here. Please have a seat. I think we have few more joining us on the way, uh, and we are starting momentarily. So welcome again. Thank you for joining us for the Health System Strengthening and Systems and Reliance Conference, International Conference here in Islamabad. We are very happy to have you. We have a whole day program, and we're going to go through the program details just in a little bit. But always we start with the name of Allah, most beneficent and the most merciful. Dr. Tariq will do the recitation for us to start. Thank you.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم.
Thank you. As you know, this has been a long-term preparation for all of us to have all of you here today. We are very excited about this wonderful conversation. I just want to put a little bit of context. Before that, my name is Shakil Malik. I'm the Vice President for Manhattan Strategy Group based out of Washington, D.C. We are very happy to organize this event, get together, and really have a wonderful conversation throughout the day. I just also want to put a context that, as you know, last 2 weeks ago, there was a Summit of the Future at UNGA, and we were there. And also the conversation that were happening, that was at the global level. Now, ultimately, we have to bring everything home. So this is our little effort to come together to really see from the global and to the national level and how we go to the grassroots level for all our work. And to do that, we need this wonderful dialogue, support, and collaboration with all of us. And today we have a full day program. So we will just go through very quickly that after this opening and greetings, we'll have the welcome speech from our Honorable Dr. Malik Mr. Ahmed Bharat, and he's here. And also then we'll have a launching ceremony for Manhattan Strategy Group as we start our journey. We have long-term vision and work that we want to do with all of you in Pakistan, and we want to discuss with you the collaborative ideas. Then we have a couple of keynote speeches. Now, as we are starting just a little bit delayed from the original time, we will adjust as we go through, but I would like all of you to relax, sit back, and enjoy. There are a couple of small logistics. I think many of you may know this venue already, very easily navigating process. When you get out of the hall, on the left and right, both sides, there are restrooms and washrooms. And also there are multiple volunteers you will see around you who are here to help you, anything you need. There are tea, coffee running outside. Also, we'll try to have a real formal tea break, depending on the time. So we now welcome our Honorable Dr. Malik Mr. Ahmed Bharat to give his welcome speech. Yes, sir. Thank you.
Bismillahirrahmanirrahim. Mr. Shabab Saab, the Health, General Kram Saab, esteemed guests, ladies and gentlemen, Assalamu alaikum and good morning. It is my pleasure to be part of this important deliberation on the need of resilient health systems in context of challenges we are facing due to global health security and climate change. I would like to thank Manhattan Strategy Group for identifying and organizing this crucial dialogue. Government of Pakistan has a long-standing partnership with U.S. government in health, and we appreciate and recognize the critical support and contribution made by U.S. government to strengthen our health system and improve the health status of people of Pakistan. At global level and within Pakistan, we are witnessing increased frequency and upsurge of diseases outbreak. COVID-19 pandemic and public health emergency of international concern (MPOC) are declared by WHO in recent times. These realities have brought home a very clear message that a country needs to invest more to strengthen its core capacities under IHR DHSA framework and be prepared and able to respond in a coordinated manner for any disease outbreak or a threat. Pakistan had also bear the adverse effects and consequences of massive floods in 2022, which led to displacement of around 30 million population, incurring significant losses to health, agriculture, and livestock sector and affecting the livelihoods of many. Country incurred a loss of around $20 billion. The critical challenges which our healthcare delivery systems have been facing are resource limitations, workforce gaps and their capacities, infrastructure and medical technologies, and less attention towards strengthening our primary healthcare network, especially in hard-to-reach areas. This has led to inequities and poor health status of our people. Despite these challenges, we are optimistic. We have opportunities in front of us, since devolution provinces have now access to more funds to invest in their health sector, especially in primary healthcare networks, including the community health workers, where 60% of our population live. In addition, we are focusing and exploring digital solutions, that is mobile health initiatives and telemedicine to extend healthcare access to remote areas. Moreover, through international collaboration with bilateral global health organizations, including USAID, FCDO, CDC, UKHSA, United Nations financial institutions, to access technical and financial support for system reforms, implementation of essential packages of health services, capacity building of healthcare providers, retaining healthcare professionals through initiatives like medical education, scholarships, and rural services incentives. We are also exploring innovative financing through new models such as health insurance schemes of Safe Solo program to extend coverage and reduce out-of-pocket expenses for citizens below poverty line. PPP modes are also being in practice for bringing in efficiency and quality in healthcare service delivery. We are engaging private health sector to offer affordable healthcare services, especially in urban centers. Ladies and gentlemen, Pakistan is highly vulnerable to climate-related health challenges due to floods, heat waves, and waterborne diseases, which affect both human and animal health. The rise of zoonotic diseases due to environmental degradation, deforestation, and livestock management is growing concern. The surveillance system and public health labs of both health and veterinary sectors are not integrated, limiting the ability to monitor and respond to health risks at human-animal environmental interface. We are in the process to adopt One Health approach and implementing a One Health framework that integrates human, animal, and environmental health sectors to address cross-cutting issues such as zoonotic disease and food security. In this context, Ministry has recently developed costed National Action Plan for Health Security 2024-28 based on One Health approach and key recommendation of Joint External Evaluation Exercise 2023. We have also submitted a pandemic preparedness proposal based on One Health approach at pandemic fund. And we are very hopeful to secure these funds to strengthen our preparedness and response capacity. Ministry is also completing the climate vulnerability assessment across the country with the support of FCDO and WHO. To develop National Health Adaptation Plan as per commitment at COP28 and work towards building climate-resilient health systems, building healthcare facilities and infrastructure that can withstand climate shocks, particularly in flood-prone and high-risk areas. We are in the process of establishing climate and health surveillance systems in collaboration with meteorological and environmental agencies to detect and respond to health risks earlier. In order to strengthen evidence-based policy making, we are now focusing to strengthen our National Data Health Center at NIH, which would be the main hub for integrating all health-related data to DHIS2 platform from across the provinces and One Health sector. I would like to thank once again the organizers and our worthy guests for attending this event. We look forward to working in a more collaborative manner with international partners and national stakeholders to address One Health challenge and work towards a safer world. Thank you very much.
Thank you so much, Honorable Dr. Malik Mukhtar Ahmed. This is wonderful to hear the larger context and also the national context and the collaborative ideas with all the international partners and national partners. I would like to invite the Manhattan Strategy Group team to our stage. I will start with Adina Killing. Please join us here in the stage. I'll also have Dr. Hamad Ali, please join. Dr. Amir Ikram, please join. Dr. Furkan Irfan, please join. And Dr. Tariq Muhammad, please join. I think many of you know many of them, but this is very important to understand the team that we have gathered. We are very privileged and honored that this is the team Manhattan Strategy is now working with at the moment, globally and in Pakistan. And just to make sure that there is a very clear understanding that Dr. Amir Ikram, we are very privileged and honored. He is our country representative. So a big applause for him. We also have Dr. Mohammed Tariq, who has joined us as of October 1 as our public health director at Manhattan Strategy Group. So welcome, Dr. Tariq. And then we have wonderful Dr. Hamad Ali, who is working with the CDC in USA as a deputy branch chief, and he is also part of the team as a technical advisor. We also have Dr. Furkan Irfan, who is affiliated with Michigan State University, also our technical director in the Manhattan Strategy Group. And then finally, without Adina, I will be useless. She keeps all of us on track, right? And also we have our wonderful partner, Pat. Amy Strang, you want to come to the stage? So Pat is our partner for a lot of work globally, and we want to recognize Amy Strang, who is a senior director there in Washington, working with us for all the global programs. So again, thank you. Thank you for all your support and making sure that this is happening. And then finally, I would like to hand over to Adina to continue some presentation on Manhattan Strategy Group as we launch our organization and you get to know us more. Thank you.
Good morning, everyone. As I'm looking around, I see some familiar faces, but for those of you who don't know me, my name is Adina, and I'm a program analyst at MSG. In a moment here, I'm going to introduce the founder and president of Manhattan Strategy Group, Mr. Shahzad Habib. Mr. Habib has over 25 years of international business and strategy experience. He has led several multi-billion-dollar programs that span 30 countries. He has founded 3 separate organizations and supported over 50 small companies in launching new businesses. In Pakistan, Mr. Habib serves on the board of multiple noteworthy organizations, including the Patients Aid Foundation, Jinnah Hospital, the Eye Care Foundation, the Citizen Foundation, and the Institute of Behavioral Psychology. Through MSG, Mr. Habib has been serving Pakistan for over 20 years in the areas of health, education, and economic development. Some of MSG's key accomplishments include building multiple free schools in Karachi and establishing a new nephrology ward at the Jinnah Postgraduate Medical Center in Pakistan. MSG has an existing partner, affiliate and partner network of over 130 organizations across Pakistan. Through this network, MSG has touched the lives of over 9 million people across the country. Here to speak more about Manhattan Strategy Group, please welcome Shahzad Habib.
Good morning, everyone. Welcome to our international conference here in Islamabad at Comstech. I want to take a moment first to thank all our dear colleagues who've made this possible this morning. It's taken, as we said, several months of planning to be here this morning. Coming to Pakistan for us is really an important part of our mission. Manhattan Strategy, for all of you who are not aware of us, is a mission-driven organization. Our goal is to serve underserved and disadvantaged populations. It is to make a difference in the lives of people. That's why we exist as an organization. Our relationship with Pakistan is not one that is new. It is that of several years, as Adina has mentioned. Over the last 20 years, or the last almost 25 years, we have been working in Pakistan in several capacities. But what I'd like to do is just make sure that I can give you a little context about what Manhattan Strategy is. As an organization, Manhattan Strategy, just to give you a little background about who we are focused we're based in Washington, D.C. We've done work in about 30 countries in evaluation. Our focus is in health, education, governance, economic development, climate change, and obviously emergency responses. As an organization, our values are key to us. Any organization is based on who they are, what their principles are. Integrity, compassion, quality, entrepreneurship, and being accountable. When we are given something, we want to ensure we are accountable for that. And we're here to solve challenges, meaningful, and making a difference in social and development outcomes. As we think through a little bit background about who we are as an organization, we were founded in 2001. In the past 20 plus years, we've done about 400 projects. We have managed multi-billion-dollar IDIQs at education, health, human services. In the US, we are a domestic capacity development contractor and managed close to $450 million worth of contracts in recent past, covering 30 countries, as I mentioned. The question about why Manhattan Strategy and what makes us unique and makes us who we are. For starters, we are the only Pakistani American capacity development contractor in the world. So the reason why we're in Pakistan is from a sense of responsibility. If we are not going to help our own country, then who will? So while we were in America for the past 20 years doing good work there, at some point the US government and the State Department came and said, why are you not taking responsibility? You're doing great work in the US. So with that nudge, I guess is a good nudge. While we've been working in the private sector for several years, we've decided that we want to launch and work with donors and work on the government contracting side in the US with the local donors in Pakistan. As I said, we are very mission driven. It's about establishing relationships. We have several of those in place. And it's really about providing world-class technical capabilities. When people think about capabilities, it's about what is next. I was having a conversation with the Honorable Minister and we were talking about sustainability. How do we take a program? How do we make it sustainable? Because donors may give money for short-term projects, but to have long-term sustainability, you need to think about how do you put the systems in place in order to do that, whether they be technology, human resources, or just the concepts and innovation. Our goal is to really kind of come as a desired and a well-deserved partner to this country. What we do in terms of our services, obviously capacity building is the heart of what we do. Program management is another big area. Research and evaluation, system strengthening, which is the core of, whether it's health, whether it's education, that's what we provide, and information technology. We have a very strong backbone in these services. Our approach to working in any country, and specifically Pakistan, is really sustaining locally led solutions. And for this particular area, this really revolutionized the health system, whether it is quality, equity, resource mobilization, whether it is championing gender and social inclusion, which is very important in countries such as Pakistan, to bring those populations to the front, as well as empowering local communities. All our technical solutions consider these key elements as we build out our solutions. A little bit more context, we do have a global footprint working in about 29 countries doing evaluation with the US Trade and Development Agency. So we are not new to this international arena. As far as our relationship with Pakistan, and while we've spoken a little bit about our US background, Pakistan is not new to us. For starters, and this is more of a recent development, We are now a locally registered company in Pakistan called Manhattan Strategy Private Limited. And this is a very unique one of a kind company because this organization not only is a Pakistani organization, but takes all our American background, past performance and corporate capabilities and brings it to the ground in Pakistan. We have several MOUs in place within the health and education network of this country. And we have a large network of affiliates and local partners that are committed to this mission. We have been very careful about selecting the partners that are alike, like-minded in terms of vision and values. Because if those are not aligned, this is not just about winning dollars for us. This is not just about getting money. It is about making sure that we can make a difference and be of public service. Give you a quick sense in Pakistan, over the last 20 years, we have been part of private sector initiatives through our local partners that have impacted and brought about $40 million to this country. We have an established network of about 150 partners that have already touched the lives of 9 million people. As Adina has mentioned, I've had the benefit of serving on the board of several organizations, including the Eye Care Foundation, the Jinnah Hospital in Karachi, the Citizens Foundation, having an affiliation with them, and Manhattan Strategy has several local projects in place with them. We run 3 dialysis centers in Karachi that serves over 1,000 patients. We run multiple Manhattan schools in Karachi that serve free education. And we also, through our Eye Care network, have worked, as you can see on the slide, across the country. We have a presence through our partner network in all the districts and experience. So for us coming here and nature to us, as we said. So as we think about, and I'll take a pause over here of what is important in today. Pakistan has gone through several countries, as many countries, changes, political, economic, as well as environmental changes. We as a nation, in order for us to come together, have first and foremost have to come together as a community. We have to think from a perspective of what does it take to get us from point A to point Z. And this is not an easy journey. And this is not an overnight journey. It requires patience, which is a key aspect of our religion, Islam. We have to have sabr. We have to think about and not give up hope. Hopelessness is against our religion. So while we see despair around us, or we see turmoil, we see challenges, our reason to come here is to say, we are here to spread the hope. We are here to bring the light. We're here to bring the happiness. It cannot happen in one day. It cannot happen overnight. But inshallah ta'ala, it will happen over time. And with that, thank you very much. Hopefully, this is a great conference and you guys enjoy the several panels that have planned with some great academic and content knowledge in the health system. Thank you very much, ladies and gentlemen.
Thank you so much, Shahzad. I hope everybody is inspired and ready for action. Thank you. I think the next discussion was to really get together. I know Honorable Minister is very busy, so he spent time with us. And so we just wanted to make sure that we go into the next step, which is our panel. So we are, giving a small gift to our Honorable Minister, and we'll get some photos, we'll get some tea for everybody, and then we will start the actual keynotes, so that we can get into the technical conversation and also the content of the program. Just to make sure that everybody is very clear, we have 3 keynotes, which is short keynotes. Each of them are about 15 minutes or so, with some wonderful people. And then we also have 5 panels today. And before lunch, we want to cover at least 2 panels, and then after lunch it will be 3 panels. So thank you. So thank you for your patience. As you know, always there is protocols. We would like to take a break and everybody is welcome to the tea break. The tea and coffee is outside for you, relax. But we don't want to be too far, maybe 15 minutes max. And please make sure that we come back on time so that we can actually get into the real program. And I would request everybody, don't plan to leave. So welcome. Thank you.
Wonderful. Thank you. Good morning, everyone. My name is Erin Sorrell, and I'm an associate professor at Johns Hopkins University. It is my great honor to be with you all, and my sincere apologies for not being able to be there in person. I had plans to travel to be there with you, and unfortunately had some family issues and had to stay back in DC. But it's a fantastic opportunity to be able to interact with you all. And again, my greatest honor to be part of this process. So this morning, I'd like to talk a little bit about global health system strengthening, discussing priorities, challenges, and some opportunities for the future. And we think of health systems, it really consists of the people, actions, whose primary purpose is to improve health. And like any other system, all parts of a health system are interdependent and must work and be strengthened together to be effective in delivering core functions and collaborating with other sectors to meet the health needs of people. And I'd argue by doing so, we really can address the needs of agriculture, wildlife, and the environment for a true One Health approach. When we think about priorities, it's really getting beyond that first step of recognition that health systems strengthening and health systems resilience is key. So there's overall, I think, a broad agreement on key features and attributes of a resilient health system, the capacities of health actors, of institutions, and of its populations that can anticipate, prevent, prepare, respond, adapt, and recover to a wide variety of shocks and stressors, while also delivering at the same time quality health services. Health systems are considered resilient if they protect human life and produce good health outcomes during and after a crisis. But there is a gap in the availability of technical resources to support planning, to support the implementation, particularly at the country level for resilient health systems. So in response, WHO recently, the World Health Organization released in June of this year, Building Health Systems Resilience to Public Health Challenges. And they've outlined three major objectives in this guidance document. They provide an overview on the concepts of health systems resilience, provide a roadmap outlining foundational steps that can build health systems resilience, and then they share examples of activities, of roadmaps, of stakeholder roles and responsibilities that can be applied at the national level. And this schematic is really looking at a coordinated system-wide and multi-sectoral joint working process to prioritize resilience, to identify baselines and needs, to adopt integrated planning and resourcing, to consider and institutionalize resilience building, and monitor and evaluate programs. And the idea here is it is a cyclical process where really it starts with the prioritization of resilience. But I do want to highlight that resilience is not an inevitable byproduct of targeted investment, but it has to be intentionally operationalized with input, with investment, and with context. So some of the challenges to identifying, building, and sustaining resilient health systems is, one aspect of it is that it's actually become more prominent. The resilience has been more prominent with increasing frequency and the scale of public health emergencies. But the challenge is, how can national health systems be strengthened or sustained to prepare for, to mitigate against, and respond to emerging threats? Well, we also have to consider improving health, reducing costs, minimizing harm, having an equity-oriented approach, have respectful and culturally sensitive approaches to healthcare, and incorporate what I'd consider chronic stressors: climate, economic contractions, conflict, antimicrobial resistance, and non-communicable diseases. And one might argue that those particular stressors, those chronic stressors, have more devastating impacts on population and health systems over time than a particular epidemic. And so there has to be a balance between these. Efforts have primarily historically been siloed and fragmented in its approach, both in terms of resourcing and implementation. So what's the solution to this problem? Put people at the center. Consider the essential building blocks of a health system, the socioeconomic determinants of health, and consider people at that core. Figure out how to incorporate governance, information, financing, service delivery, human resources, and medicine technology as we build those systems around different sectors and their goals and objectives. And one can consider theories of change. Consider how complex interventions can interact with larger systems rather than just being considered only in the context of one sector. So if we take this approach with a priority for emerging infectious disease, whether that's novel, emerging, or re-emerging, and we place that stressor on health systems and theories of change, if we incorporate input from all relevant sectors, as we consider things like laboratory capacity, conflict instability, forced displacement, climate change, land use, population growth, demands for protein, incorporating practical field-tested approaches to surveillance and outbreak response, and we target those in global health security programs, we can really impact theories of change. We want to consider how complex interactions might interact with wider systems, the importance of identifying and ensuring adequate input from all relevant partners, and the fact that there aren't ready-to-go interventions, that they really need to be developed over the course of working groups, over the course of discussions between government sectors, non-government sectors, implementing partners, and relevant disciplines. And this then presents opportunities. When we think about the evolving and expanding landscape of public health challenges, climate change, aging populations, rising rates of antimicrobial resistance, political instability, and mass displacements, we have to consider how to build health systems resilience that represents worthwhile investments for healthier and safer populations as a foundation for stable and sustainable social development and economic prosperity. Global health security is really rooted in political and social sciences as much as it is in the biology and the epidemiology of disease emergence. And so it's important to think about an implementation science and partner-led approach to building, to strengthening, and or sustaining health systems capacities. Advancing policy-relevant research is key, using direct evidence and data to affect health outcomes. And ideally, we're looking to partner directly with countries to balance basic science with political and social dynamics for better applied research and stronger capacity building. So I'd like to take an opportunity to say thank you all for your time, for your attention, and again, my extreme honor to be part of this process. Thank you all so very much.
Thank you so much, Erin. We really appreciate your responses and also the presentation. I know it's very late night for you, so thank you so much again. We will be in touch if there is any specific question. We will come back to you later on, not right now. I know we want to get you go to sleep. So again, one more applause for Erin for joining us on this wonderful presentation. So thank you. With the next wonderful speaker, Dr. Hamad Ali. I invite you to the stage. He is, as you have heard before, the Associate Branch Chief of USCDC, Adjunct Associate Professor of Brown University and University of Queensland, and also he's an independent global health consultant. We welcome him for his welcome speech. Please.
Good morning, everyone. Thank you so much for that kind introduction. So today I will be talking about two topics, One Health and the decentralized health system that we have in Pakistan, like many other countries in the world. Starting with One Health is a collaborative, multi-sectoral and transdisciplinary approach, working at the local, regional, national, and global levels with the goals of achieving optimal health outcomes, recognizing the interconnection between people, animal, planets, and their shared environment. That is the USCDC definition, and it's extremely cumbersome. But in summary, One Health is an approach that recognizes that health of people is closely connected to the health of animals and our environment. The One Health approach is not new. It started in the mid-60s as One Medicine with the unified approach to human and animal medicine. The term One Health was started getting used in the 2000s, especially with the avian influenza and SARS outbreaks. In 2008, WHO, along with other UN agencies, started to promote One Health, and the US CDC established the Office of One Health in 2009. This year, we have seen several examples of why One Health is important, and I will focus on a couple in the next couple of slides. So I'm sure everybody here is aware of the MERS cases in Saudi Arabia. This year, there were 5 cases of MERS, out of which there were reported 4 deaths so far. MERS was first detected in Saudi Arabia in 2012 and likely originated from camels. Since then, there have been several outbreaks of MERS over the years. Even though the mortality from MERS is extremely high, thankfully, human-to-human transmission is uncommon. And I'm sure everybody here has also heard of the avian influenza situation in cows in the US. And this is, of course, unusual because H5N1 or avian influenza is usually associated with birds, but it impacted dairy cows this year in the US. The outbreak was first reported in Texas in March, but then spread to many other states in the country. So far, there have been around 240 confirmed cases of H5N1 in dairy cows in the US as of September. We still are unsure how H5N1 is transmitting from cows, one herd of the cows to the other, because the 2 traditional methods that we thought would be possible have not been proven to be the cause of the outbreaks, i.e. Transmission through the dairy trucks, milk trucks, and through the birds. And unfortunately, neither of them have been proven to be the main mode of transmission. Earlier this year, the US government actually announced $200 million to support the outbreak investigation and response work, and provided that to dairy farmers to increase their capacity to help them develop different systems and to respond to the outbreak. And then obviously, as was mentioned earlier today, there's Mpox, and we've had cases of Mpox in Pakistan. And then there's dengue and malaria, which have been a huge problem in the country for many, many years. So although it feels like One Health has been around, or the concept of One Health has been around for many years, we haven't really figured it out all yet. In the next few slides, I'll talk about some of the challenges and opportunities around data systems for One Health and how to integrate data systems for One Health. Firstly, we need to establish surveillance systems, systems that monitor diseases across human and animal populations and the environment, and these are vital to the One Health approach. Such systems aim to detect emerging public health threats at the interface of these sectors early on, preventing widespread outbreaks and ensuring public health security. And collaboration across multiple stakeholders is the key to the success of these systems as they require contributions from various disciplines and various sectors. Secondly, cross-sectoral data sharing is important and is essential for effective collaboration in areas such as health surveillance, environmental monitoring, and agriculture. And it enables timely access to crucial information that can help to detect, respond to, and prevent emerging public health threats. Thirdly, capacity building. Capacity building, of course, varies dramatically across the three disciplines. And it is needed, capacity building is needed across disciplines, especially in cross-sectoral context, including capacities related to data management, infrastructure, and technical knowledge. Efforts are needed to enhance abilities of individuals, organizations, and systems to effectively gather, analyze, manage, and use data. And bridging these gaps is essential for ensuring smooth and effective collaboration. Fourth is the policy and availability of policy and governance frameworks. These frameworks are essential to facilitate data sharing while ensuring that ethical data use and protecting the privacy of the data. The frameworks are also needed to establish the rules, standards, and best practices that guide how data is collected, stored, shared, and utilized across the different sectors. The frameworks also ensure that organizations can collaborate effectively without compromising individual level or human or organizational rights. And fifth is the data integration platform. Platforms that consolidate information from multiple sources are essential for creating a unified, comprehensive view of health, animal, environmental, and agricultural data. These platforms are designed to pull from various systems, such as clinical databases, environmental monitoring sensors, and agricultural tracking tools, and even genomic data, and merge them into a single, accessible interface. This allows for better cross-sectoral analysis and decision-making. And lastly, the use of AI for data integration. AI can enable efficient consolidation, analysis, and interpretation of complex data from multiple sources. And moving forward, AI will definitely play a bigger role in health system and health system strengthening, especially when it comes to One Health. So pivoting a little bit and talking about considerations for a decentralized health system. Whether we have a decentralized health system as we have in Pakistan, or the US, or Australia, or we have a centralized system as we have in many other countries, especially in Europe, the goal is effective healthcare delivery and implementation of public health initiatives. And there's obviously pros and cons of both types of systems, and I'll maybe focus on 4 of those for a decentralized system. Firstly, privacy and security. Privacy and security in data sharing and management often requires a balance between provincial level oversight and the national level resource. States or provinces or jurisdictions typically have more localized control and oversight over data collection, data use, and protocol measures, which allows them to tailor privacy and security protocols. This is especially important when dealing with sensitive data such as personal identifiers. Having said that, national level data or the national level usually has access to more significant resources, both financial and technological. And these resources can be used to implement and enforce robust security measures and privacy protocols. National governments may also have the greater capacity to ensure compliance with national level data protection laws. Secondly, going back to data sharing and interoperability. It is critical for improving coordination between healthcare providers, between public health programs, and research efforts. While the national level data systems can facilitate dissemination of data or information on a larger scale, data needs to be shared across jurisdictions in a decentralized health system to get a national picture. Lack of system interoperability can be a huge problem, and this can happen across different data platforms, different providers, and different regions, and remains a significant barrier in a decentralized health. Thirdly, accessibility and timeliness. Jurisdiction level data or provincial data often has the advantage of being more readily available for real-time use. This allows the provincial health departments to respond quickly to emerging health issues, disease outbreaks, or environmental hazards. However, on the flip side, national level data systems and repositories provide a more comprehensive national view that may be helpful for surveillance at the national level, policy making, and research. And lastly, public trust and perception is crucial. They are vital components in the management of health data. How data is managed, how it is stored, and how it is used at the provincial level versus the national level directly impacts the confidence of public in institutions and their willingness to engage with services that rely on data sharing and analysis. So in summary, there is definitely need for collaboration in a decentralized health system, especially around data systems. The collaboration is needed between jurisdictions and also between the jurisdiction and the national government to effectively, efficiently, and timely deliver public health programs. And I'll close with the fact that future success of healthcare delivery and public health programs requires better health systems and increased collaboration across different partners. Thank you.
Thank you so much, Dr. Ali. Wonderful to hear your global perspective and also connecting with the national perspective. Now I invite Dr. Amir Ikram to give his welcome speech, please.
Bismillah ar-Rahman. It's a great pleasure to be with all of you for, I think, a topic which is very close to my heart. And I'm sure what I would be talking is giving you a little bit about insight into the insight into Pakistan's perspective. We are concerned about the global health security. That's because of the emergence and re-emergence of disease, unusual pattern, threat of deliberate use again, and its impact, direct impact on health, economy, and security as well. But what we are more concerned is this globalization, because the threat anywhere is a threat everywhere. So that's the key for the infectious diseases to be controlled. We unfortunately failed in the Millennium Development Goals, and then we moved on to Sustainable Development Goals. So talking of whether the health, the food, the environment, everything moves together. You just heard a great narrative about One Health from Dr. Hamad, and earlier how we integrate. So integration is the key word, remember. You all know international health regulations launched in 2005. And followed by that, the global health security packages. And they are very key. And there are quite a number of overlapping things which I'll talk briefly. Now, before COVID, I think one of the key concerns was less than 1/3 of the world was prepared to deal any pandemic. Or even within the country, or to talk of pandemic. And you've been hearing a lot. I mean, you just heard MERS-CoV, and it's been there, whether you talk of highly resistant bug, which I call MR as a silent pandemic, of anthrax, Ebola, MERS-CoV. But I think this thing, COVID, this is the big game changer. For years and years, we have been talking of an eventuality landed in the form of a coronavirus, and we all know how much impact it created. These were the perturbing, and they still remain the perturbing dynamics, with faster means of spreading, less than 30% countries prepared, and you can see the economic challenge. COVID alone costed more than $16 trillion. So you can well imagine how devastating it is. What we need is a safer world. So for that, we need to prevent avoidable catastrophes. We need to have promptly and proper diagnostics and detection capabilities, and then the response capability. Now, this is an integrated model that I've been contemplating for some time, because there are so many bodies, and this is especially for the youngster to look which are the bodies in the world working, and how could be there some integrated model. And these are the bodies where you can, maybe one day you are working for them. You got World Health Organization, everyone knows about that. Within the country, you got ministries of health, you got Ministry of Public Health somewhere as well. But the public health institutes, the pivots, as you can see on the right side. And then academia and research, they are the key component. But what next? Yeah, now recently in Berlin, a global health hub has been established, which is more so tilted toward the pandemic and infection control. And then we have got an International Association of National Public Health Institutes, for which Dr. Mumtaz is here, they are the member, and the TEFNET, which comes under the Global Task Force. Now, these are the arms helping out in WHO. We've got INV, which strengthens the National Public Health Institute, TEFNET, providing the FETP task force, and some of you are already qualified. And then the GOVERN, which is the Outbreak Response Network. Recently launched the Global Field Epidemiology, and then the Global Health Emergency Corps, followed by Lusaka agenda coming out of the Future Global Health Initiative. We have here partners from the Global Fund as well. And the recently launched 717, and NIH is already working on that, alhamdulillah. And then vaccine-related bodies, and moving on to the diagnostic international bodies, and finally donors and partners who've got a huge role. Now, this is the international perspective which we can integrate at the national level, and fortunately, I have served with almost all of them and still with most of them. So I can give you a better perspective how the IHR and moving on to global health security, they overlap. They do overlap, and government of Pakistan is fully cognizant of all these modalities. Now, Pakistan is signatory to IHR that I just explained. NIH is the designated focal point, and we've got a good team from NIH today over here. The core capacity mission from the WHO happened in 2013 and 2016. We established FEDSD with the predominantly division at NIH in 2014, and since then Dr. Mumtaz has been there. And then the state party and annual reporting system, moving on to the joint external evaluation. So Pakistan was the first country in the region that underwent joint external JE in 2016, and third in the world at that time. And in the second round, just post-COVID, we completed that. The National Action Plan was for health security was prepared after the joint JE in 2016. And you can well imagine the average health expenditure was around $450 million for health security activities between the period 2017 and 19. And you can well imagine how well, with all the difficulties and challenges, Pakistan has responded to the COVID challenge, which is appreciated at the global level as well. So the government of Pakistan has priorities like integrated disease surveillance and response, public health lab systems, AMR containment, strengthening of point of entries, and workforce development. So that led to indigenous financing as well. Just giving you an overall horizon of the public health sector, you've got, I think, a good number of tertiary, primary, basic. And I think if you talk in perspective of IHR achievement, you talk of pandemic preparedness, primary healthcare has got a very, very important role. But certainly there are certain aspects as well. We have an increasing challenge of population burden. We do have a fragmented healthcare system. We have a double burden, where there is a transition from the infectious to the non-infectious and non-communicable diseases. We are still facing both the challenges. Climatic hazard, you are witness for time and again. We are a disaster-prone country. and definitely there are economic constraints. So I'm just giving you a narrative about tuberculosis. Where do we stand? Still fifth globally, talking of MDR tuberculosis. Fourth globally, hepatitis, key challenge for Pakistan, B and C in particular. Rabies, eliminated in so many countries, how many deaths we have on an annual basis, and moving on to extremely and extensively drug resistance like XDR typhoid, which started from one of the cities in the province of Sindh. And not only that, side by side, there are increasing challenges for CCHF, dengue, chikungunya, and malaria. I think the increasing and better diagnostic are providing us a better opportunity to learn about them. So with all that background, the key joint JE evaluation in 2016 led to multi-state sectoral coordination mechanism that was to be adopted between the federal and the provincial government and involving all the regions, and development of a mutually agreed and funded roadmap to develop relevant action plans for pre-priorities. Prioritization definitely was based on certain very important initiatives were taken, and started with the strengthening of NIH as National Public Health Institute, moving on to AMR containment, national lab systems. And this was the actual roadmap which was developed. And you can see starting from 2007, being signatory to IHR, moving on to strengthening the institute, and 2015, 2016, and 20, till the time we got stuck in COVID. And that actually National Action Plan under the command of National Command and Operation Center effectively led to a very robust response. Well, Pakistan is again reporting to the annual reporting system with WHO, and it is all based upon transparency, mutual accountability, trust building, and dialogue and sustainability. So this key part is something, again, very important for the countries at the international level. Moving on to, we have a National Action Plan for the Security, the NIH Amendment Act, which gave more authorities to NIH as well. Then moving on to different policies and strategic wisdom. Everything is now existing. I think last 6 to 7 years have been very, very important in this regard. So we have the things on there. It is the implementation that, and with youngsters, you are the implementers. We have to pass the baton to you. And remember, whether it's HSA, whether it's UBAS, or any other academic institute, you have to build. Some of the key initiatives, well, the focal hub for IDSR, One Health, AMR Biosafety remains with National Institute of Health. And we do have capacities. We established some time back the CDC, the National Reference Lab, we established a National Genomic Center, Health Research Institute came down to the NIH, Center for Vaccine Production, and the Data Health Center we just heard from the Honorable Minister this morning. So there is a national lab working group, and that is an amalgam of, again, all the key stakeholders, including the private sector, helped in building up the virus management, the quality management system. We started establishing a main reference hub at the National Institute of Health. I'm sorry if I can point it out. No. Yeah, okay. You can see this is NIH, and then we worked out 6 different regional and provincial hubs, which performed immaculately during COVID crisis. And then we have influenza sentinel sites spreading all across the country. And not only that, we have a different mechanism for AMR. We have been part of GLASS. Some of the key people are sitting over here, and Pakistan is now regularly reporting into that. Moving on, some of the sophistication, and I think with the courtesy of your government, 4 mobile biosafety level 2 labs were donated to NIH, 3 were given to the provinces, and the 4th one remained at the national central level. We started working on integrated disease surveillance and response in 16, and fortunately today where we stand, as you can well see, we started off just with 6 centers, and Dr. Mumtaz is witness in 2017. But what happened? We established a national lab public health networking system. We integrated the regional hubs into it, and finally, 157 districts. This IDSR spreads across the country. Not only that, the people have been trained, they have been integrated, and all the data being shared at National Institute of Health. Workforce, the pivotal, it's never the gun, it's the man behind the gun, which is important. I think the FETP has been immaculate, started by CDC US much earlier in 2006, and then moving on and on. Today, the government of Pakistan is running this show. So this is yet another key success where the program becomes a successful and it is run by the government. We worked up on the National Action Plan for AMR. after the World Health Assembly passed the resolution, and we came up with the strategic framework, and then we moved on with all the documentation. We have a multi-stakeholder involvement, and I think it's a little bit of more integration that we look forward now with this. And all the key documents last 6 years, they are very much talking of strategy, financial costs, what and what not. Preparedness, I think you can never prepare during an emergency. You have to be ready before it. So, and all hazard risk assessment, moving on to pandemic prevention, everything is there. The Emergency Operation Center, again, is fully functional at NIH, and then we have at the provincial levels as well. I think one of the key action packages for global health security is biosafety and safety action package in particular. So we have the national policy, we have the capacity building mechanism, we laid down the code of conduct in 2010 for Pakistan as guidelines, and then we are working with different bodies, including the Center of Excellence in European Union as well. You have heard about Nautic, they're important, not delving much into it, but I think most of the strategies are developed. It's just putting them together and bridging the gaps can make a difference. And sometime back, yet another thing, realization was upgradation of the border health services, which is again a very key area for any country to monitor the infectious diseases. Just coming towards the end, I'd say Pakistan engagement in GSLA related, we have been participating. Fortunately, we managed Pakistan into the steering group of the 7 countries where US and UK were there. And in 2023, we were fortunate enough to even chair the steering committee at the international level. And that's yet another key success for Pakistan to achieve at this level. And we are the member of INP, and we underwent peer-to-peer review. We are open for collaboration. Pakistan has got a very open policy, whether talk of WHO, whether USA, the CDC, NIH, the USI, the bodies like TEFNet, AMFNet, CDCs of different countries in the CDC China, and academic linkages. And one of the key successes that I always say was the vaccine production during COVID at NIH, and that in turn opened up doors for messenger RNA technology transfer to Pakistan as well. We still have challenges, resource mobilization, continuing liaison in the stakeholder level, provincial authorities and linkages, and human resource upgrading. So you again, I again pass on to the youngsters that you are the host. You have to fill up this challenge. You have to learn. You have to make networking very strong. And some serious thought, health system strengthening and resilience, universal health coverage, talked a lot, and you'll be hearing this later this afternoon by Dr. Kampani as well, uplifting the primary healthcare structure, which has been relied during COVID. And we need to have government-supported funds. The financial sustainability of any project should come from the government side with all the political backing. So another important area is the private sector. I think you need to loop in, which has been done globally during the COVID crisis, and the community engagement. You can't run the show. I mean, there are certain huge successes, and I think COVID vaccine, we're going beyond 90% success rate overall in the country, 12 years and beyond. I think that was community engagement, and we need it for multiple things now. Their awareness is again very, very important. What the way forward? I think we need to have continuous monitoring by IHR task force, moving on to provincial health departments, strengthening their surveillance and response system, EMA, workforce development, all as a risk communication, and moving on with enhancing collaboration. I think the key word is collaboration, collaboration, and collaboration, and that can make a true difference. So coming towards the end, that One Health you heard a lot. So that is, so what is the model at the national level? You've got huge resources. There are strengths in any system and every country. Bringing them together. And that's what we did sometime back at NIH, brought them together. And then you see the gaps and holes. Then they start flooding in. Either the government support comes in, or you have international donors, international partners, and for the academia, the research funding, join hands together and make the technical development and enhance capacity possible together. So the word is collaboration, and the second word is togetherness. And that will lead to an increased output and a better response. So the concluding remark, if you do all that, you can prevent the illness, especially in infectious diseases, improve your ability to meet the set priorities, and reduce impact to trade and travel. So you can see the blank screen. And can anyone judge now what's there on the screen? I don't think so. No one can do it. Till you have a larger horizon and a better perspective. And then you realize it's nothing but Mother Earth. Why we call it mother? We never call it father earth. It's mother earth, because mother is much more loving than the father. So let's join hands together to make it a much safer and a better and a healthier world. Thank you so much.
Thank you so much, Dr. Ikram. That was wonderful to hear the larger perspective and really making sure that the integration is very vital. We see a lot of systems. When we talk about systems, we talk about the entirety of the system. We talk about global level, we talk about national level, regional level. We also talk about our provincial or district level. End of the day, it's about us, each of us. And bringing all the linkages and missing linkages together is what makes it work. So these actually with three wonderful keynotes, that concludes our early morning session. We appreciate all the arrangements, the dignitaries, and also the keynote speakers. So one large applaud for everybody. Thank you. It's kind of interesting and funny that I have to invite myself now because I'm the moderator for the next session. These start the panels. We are starting the panel sessions now. So as I said earlier in the day, I'm also the MC for the day. So I'm doing multitasking at the moment, as you can see. If you need to take a break for your phone calls or anything else, you can go on your own timing because there is no break now, at least for two panels, till we have the lunch break. So we will start with that. I'm inviting Dr. Hamad Ali to the stage. Dr. Scott McNabb is online with us. We'll be talking about health system strengthening as a larger topic. Our NIH chief, I don't think he's here. Salman Saab is not here. So I don't know if Mukhtar Saab want to come. He's welcome if Dr. Mumtaz want to come to the stage. He's welcome to come and join us part of the conversation. Thank you so much. I'm volunteering him without permission. Thank you. So just to put a little bit of context, I think we all have been talking about health system strengthening in the larger context. But I will just put just few short remarks before we get into the larger panel discussion and the presentation and get ready for the discussion. So in the larger context, we talk about a health system consists of all people, all institutions, resources, and activities whose primary purpose is to promote, restore, and maintain health. Health system strengthening includes the strategies, responses, and activities that are designed to sustainably improve the performance of a country's health system. Strong health system can be flexible, adjust resources, pivot, and also prioritize to address emerging health needs while maintaining essential services. Everything from routine checkup, prenatal care, immunization, to referrals for more specialized or urgent medical care. When health systems are strong, they are resilient under pressure and lead to greater health security. Now, when we look at the priorities, there are many priority areas in the health system. There are a couple of priority areas, and we're going to go deeper into the discussion from the panelists. Of course, Dr. Saab, Dr. Amikam was talking about the finances. Without that, we cannot do anything. Priority of health, finance, and governance. And one thing I want to mention, if you have not been following the Summit for the Future, which happened a couple of weeks ago at the UNGA, the top topic, entirety of every country in the world was governance. Doesn't matter which sector, because if we cannot fix our governance, how to manage and govern each individual programming, it's impossible to take care of any sector. Secondly, pharmaceutical and supply chain issue. Yes, we have come a long way. The Tariq is here. Supply chain was a big work in Pakistan, but we have a long way to go. And it's interesting because I always say originally I'm an educationist. I say that we come from our content area expertise, but supply chain is procurement. How much we know about procurement? As we become experts in our own sector, we have to be very versatile. We cannot just say that I know my topic. That's not feasible anymore. Globally, we need to know multi-sectoral approach and many knowledges to be successful. Thirdly, I also want to mention about the primary healthcare and community health system. I think Dr. Shah mentioned also the community engagement issues. Ultimately, everything resides in the community. If we have the city level or urban levels, high system strength, strengthened system, but do we still have that in the rural places, the remotest places, the remotest districts? This is the core crucial area. And ultimately, resilience and sustainability, strategic communication, analytics, learning, and evidence, continuous improvement is part of the health system strengthening also. So as we get into the discussion, I really would like our honored speakers and the panelists emphasizing each of the areas. So I will start with Dr. Scott McNabb. I think he's online. I'm trying to see if I can, he's ready. Scott, can you hear us?
Yes, I can. Thank you.
Wonderful. So we want to see you. I don't know if you're, oh, look at that. Wonderful. I know.
Can you see my
Wonderful.
screen?
So Dr. Scott McNabb, yeah, we can see your screen, and I just want to do a quick intro for you. Dr. Scott McNabb is the research professor, Rollins School of Public Health at Emory University in USA. So welcome, Scott. Go ahead.
Thank you very much. Yeah, thank you very much. It's a great pleasure to be here. And I'd like to acknowledge Afan Sheikh, who's a colleague. And I understand that Afan's mother's cousin is one of the speakers in the presentation today. So I'm very proud to work with him for many years. And I'd like to thank all of you for your desire and your intention to work toward the betterment of Pakistan. I think that intention is very, very good and should be supported completely. What I'd like to do is to share with you my thoughts on what are the issues that we face in terms of developing a better public health system, especially public health surveillance, which is one of the areas that I work in, and moving toward One Health and integrated disease surveillance and response. And you've heard some really fantastic background statements about One Health, what it's about, the need for One Health, how to achieve, for example, polio eradication. Pakistan, as you have heard, remains one of only 2 countries where polio is yet to be eradicated. So we want to focus on these issues, and the timing of it is so important. In the United States, we're experiencing many One Health diseases: Western equine encephalitis, Eastern equine encephalitis, malaria, etc., Lyme disease, the types of conditions and diseases which are new to us based on climate change. And so we have to think about public health in a different way that I've been arguing about, and developing what I'm calling a public health ecosystem. Right now, as you probably know, the United States, certainly my experience around this issue has been my work in the US, my work with establishing the Africa CDC and developing an Institute for Workforce Development there, also my work with IMPANET, and recently I worked in the country of Armenia. And in Armenia, we developed what I think is the very first One Health field epi training program, where you had veterinarians and medical epidemiologists trained by veterinarians and medical epidemiologists. And, the focus of the One Health program, we experienced in Armenia, for example, an outbreak of anthrax in one of the districts. And the government was set up in such a way that the veterinarians who identified the outbreak reported it up the channel to the top of the veterinary institution, and then it was reported over to the Ministry of Health. There was no interaction or coordination, collaboration, communication, and capacity building among all of the institutional members in Armenia, which is a very common situation right now. So I think that the way forward is what WHO has put forward is collaboration, coordination, communication, and capacity building, the 4 Cs. These must be strengthened and focused and highlighted to foster this interdisciplinary cooperation that ensures that human, animal, and environmental health sectors work seamlessly to break down the silos. My experience is that public health has evolved over the last 75 years into silos. I worked at the US CDC in the Division of Tuberculosis Elimination. I worked also as we developed integrated disease surveillance and response in Africa. And of course, it became a standard in Africa, and it's now the standard in Pakistan as well. But it's not the standard in the United States. There are silos. And what happens is the epidemiologists go to Congress, they get money for their particular program. It comes down to form the money that supports a division or a component of the institutional organization of CDC. And then it goes out to the state health departments in silos as well. So we know that even at a local level, you can be doing tuberculosis surveillance and have HIV/AIDS patients in that surveillance system and not be detected by the HIV/AIDS surveillance activity, which is basically the downfall of what siloed systems are. Now, I'm not pointing fingers, I'm just pointing out that historically and evolutionary wise, health activities, public health activities have evolved. And in Armenia, in fact, the physicians were telling me that they had less respect for the veterinarians because they believed the veterinarians were just not educated enough to get into medical school. So there existed certain prejudices, if I can use that term, and the lack of leadership. So in my opinion, the reason why One Health has not moved forward as much as it should to achieve a true One Health is that we have to recognize, as was pointed out earlier, that localized global practices are critical. Pakistan's effort should focus on leveraging best practices from other nations that have successfully adopted the One Health approach to prevent zoonotic diseases. But there are not that many countries that have been successful in developing a One Health index. In the recent global assessment, very few countries have fully implemented the One Health framework, which highlights the need for Pakistan to lead and modernize in its health infrastructure to meet international standards. At the same time, we have a great opportunity. We published a book recently, and I want to thank Dr. Kram, who was one of the key section editors in the book. This was a book written with and for WHO. You'll recognize Dr. Stella Chungong, who runs the IHR implementation team at WHO, as well as Dr. Chikwe, who's leading this hub in Berlin, as was mentioned earlier. The book has what we think are some of the direct identification of the problems that existed during the COVID crisis and some of the solutions that could be possible. So I'd like to acknowledge Dr. Akram for his work, and we'll be happy to provide copies of the book for this team. So modernizing global health is very important. We're working right now in the United States to develop and design a protocol for developing what I call a public health ecosystem. Right now, public health is tied directly into the healthcare reporting system. Public health conditions are abstracted from electronic medical records, which is something that I worked when I was at CDC, designed this with the team at Hopkins and other universities. We thought it was a very exciting opportunity to leverage electronic information. But today, we have the opportunity using ethical and generative AI to develop a new model for developing a public health ecosystem. Because the workflow process is different in public health than healthcare services, that we believe that we should be thinking about using modern tools and technology to be able to capture the information needed for public health practitioners who have to take action from all sorts of different sources, including pharmacies, veterinarians, veterinary labs, and also the population base. So I want to thank you for your intention and your desire to improve Pakistan's public health system, and I want to compliment you. And this is a tough challenge, but one that faces the silos which exist, as well as this alignment and sort of pride about money, to be able to have resources that are focused on collaboration, coordination, communication, and capacity building, which is sharing of resources, also is an important challenge. So thank you very much.
Thank you so much, Scott. Wonderful to hear all the details. So I will go to the next speaker, Dr. Hamad Ali. If you'd like to start, you are welcome.
Thank you. I maybe will just, can you all hear me? Okay.
Yeah, it's all. You can bring it a bit closer.
So maybe I'll continue with where I left off earlier, and talk a little bit about the capacities at health. But this year, obviously, after the H5N1 outbreak, they have to obviously work with the human health experts to actually make sure that the health of the dairy cows actually is not affected, but also the health of the human health is also not affected by the H5N1 outbreak. Similarly, a farmer here in Punjab or a farmer in Africa, their main concern is obviously about the crop. Their main concern is about the livelihood of themselves and their families and their village and their cities. But there's a paradigm shift that needs to happen now. With so many examples, as we were talking about earlier, that show the importance of One Health. Now, in the last few years, we definitely have to think about the bigger picture. But that, once again, comes back to not just the capacities, but the infrastructure that is available to the three different sectors. And how do we not just bring up the infrastructure in human health, but also make sure that the infrastructure is established, improved, and further improved in the other two sectors as well. So I'll just wanted to start with that, and happy to answer any questions that we move forward.
Thank you so much. And finally, I would like to welcome Dr. Mumtaz Ali to his comments.
Thank you so much for inviting me, although I'm covering Dr. Salman for this talk, and he was busy in another urgent meeting at NIH. So, as we all know, that health system is not only healthcare. It's not about the doctors, the hospital, and diagnostics. Healthcare system is basically a whole cell approach. You can say that we can talk about out-of-box approach. Health system is definitely affected by other sectors like environment, disasters, climate, economy, population, definitely in Pakistan especially. Communication means political will, priorities of the governance structure, and definitely not the last, the preparedness, and especially if we talk about health system, so this includes hospitals, healthcare, labs, diagnostics, medical education, regulations, regulators, you can see, and the workforce development, the training opportunities, the access and equity of health. But side by side, the preventive health is very important beside all those sectors. Like we talked about One Health approach. This is very important, especially in today's life, that mostly the newer diseases, the novel diseases are from zoonotic origin. So One Health approach, definitely we have this challenge in Pakistan that we don't have proper coordination and collaboration with One Health sectors. The preparedness, especially this is another gap. The rapid response teams in the provinces and especially in the districts, because health is a devolved system in Pakistan, and the surveillance capacity of infectious diseases and even non-communicable diseases, and the lab capacity around in the country. As Janamir talked about the lab capacity, we have enhanced this capacity at much more extent, and recently during COVID, it was enhanced much more. So we need multi-sector approach for all those sectors, including healthcare and also the preventive area. And since we have good primary healthcare system in Pakistan, we have even dispensaries, VHUs, RHCs, teach-go hospitals, secondary and tertiary care hospital. But keeping in view the population, the access, the facilities and far-flung areas, this system is not very enough only from the government sector. Mostly the healthcare is being provided by the private sector. And we have secondary, tertiary, and specialized hospitals and healthcare in the country. And all those are working more on curative side. They are very less working on the preventive side or on the control side. So the private sector is very important in all those areas. This is very important stakeholders. And if we talk about any aspect of the healthcare and don't include private sector in this, so this will be we are missing 75% of the area where most of the population is going to private sector for healthcare. So we have much more challenges in this sector, the healthcare system. The devolved system as healthcare is basically the provincial responsibility. And at the central level, federal level, we have the coordination role, the facilitation role. So infectious disease, definitely, Dr. Ahmed said about this in his presentation that we are much more prone to infectious diseases and much more prevalence is here. And this is a big challenge. Also, the maternal and child health, because of the access, the quality of healthcare, and especially the mindset of the especially far-flung areas and some parts of our population. The non-communicable disease and access to healthcare facilities, cost, population, climate and disaster-prone country, surveillance of infectious disease, antimicrobial resistance in another big area in Pakistan because much more antibiotics and antimicrobial drugs are available without any prescription in market, and anyone can go and purchase antibiotics for their treatment. And infection prevention and control is another poor area in the hospital, especially in the government hospital and as well as in the private sector. So all those are challenges for the health sector. And as you know that we had JE 2016, and after that we developed our NAPS, National Action Plan for Health Security. And most of the areas we were having low scores, like 1 or 2 maximum. But fortunately, during last 5 to 7 years, we have developed somewhat. And with the results of JE 2023, we are just a little fortunate that we have developed some capacities in different areas, but still in many areas we are at low scores and we have to work a lot. We have to work in collaboration and coordination with other sectors, including environment, One Health stakeholders in other areas. And especially the cost of the treatment, the cost of the healthcare and allocation from the government side is really negligible, and this needs to be enhanced. So I'm available for any question, for any talk. Thank you so much.
Thank you so much, Dr. Vikas. So now we have heard from all three panelists. I have a couple of questions. Scott, I hope you still can hear me. And first question is for Scott. That, what is the biggest challenge facing countries as they move forward to achieve One Health?
Yeah, thank you very much for the question.
Hear us? Scott?
Yes, can you hear me?
Yes.
Hello?
Wonderful. Go ahead. Yes.
Okay,
Go ahead.
good. Thank you. No, I think that this is such a key question that we all should be asking ourselves. And if we come back to the communication, coordination, collaboration, and capacity building, what that means is that the evolutionary model, so to speak, of public health, as I mentioned, which is in silos, we have to think more broadly about that and overcome the silos. Also, we have to overcome even the silos of people focusing on infectious disease and not addressing the other issues. So I think that laying down some of the past approaches that we have had and looking at integration and coordination and fulfilling the 4 C's becomes a key part of that. And that means that people at the highest level, from the president or the head of a particular government and all of the governmental organizational heads have to agree that this is the way forward, rather than holding on to the past. So I think and part of that is making sure sharing of resources. So I think being selfless, in other words, thinking about how do we really work toward protecting our citizenry, rather than our own particular institution or our particular job. I think that becomes one of the key challenges. Thank you.
Thank you, Scott. Thank you so much. My next questions are actually multiple questions for Dr. Ali, if you allow me. It's quite intriguing what you mentioned. So first question for you is, you mentioned that we haven't really figured out One Health. If you can emphasize or elaborate a little bit more on that, that'd be great.
Sure, Scott had already started to answer that question. So talking about, continuing from what Scott was saying about silos, that's one of the bigger problems with One Health right now. And as I was saying earlier, the outputs, interests, as well as expectations of the three sectors are different. And that is one of the challenges, and that's what I meant by that we have a long way to go. So even though with all these different examples of outbreaks and pandemics that we've had recently that really highlight the importance of One Health and how these sectors need to come together, practically speaking, the sectors only come together when something is happening. We don't really have ongoing collaboration across the sectors in most parts of the world. There's definitely systems that are now being established that will hopefully address the concerns across the different sectors in the future. But for now, we are still sort of being reactive as opposed to being, being prepared for what's going to come in the future. So that's basically what I meant by that. We although know the concept, we know the theory, we know the importance, but we haven't really figured it out how to actually make it happen on an ongoing fashion at all levels, both national, domestic, subnational, and global. And one of the big things to note, obviously, is the level of awareness and education across the three sectors. So obviously, within the human health sector, the human health is at the forefront. We've had this conversation for a very long time, but the importance of the effect of animal health and environmental health on human health is still more focused within the human health, but not as focused in the other two sectors. So I think bringing everybody together to be prepared for what's coming up in the future is extremely important, and not just being reactive, but being proactive and making sure that we are actually engaging with all the sectors on an ongoing manner is extremely crucial.
Thank you so much for that, Dr. Ali. If I can go a little bit further with you, there was a second part of my thinking that we thought it would be interesting for the audience, and it has two parts.
Okay.
So the first one is the role of an epidemiologist. So I think this has to be clarified a little bit further because it changed over time, and we want to see how it was before and how it's for the future. So that's one part. And how is it expected to change in the future? How the younger generation can get ready to support and service the community. Thank you.
So the role of an epi has definitely evolved over the last few decades. And COVID was the silver lining of the COVID pandemic was before COVID, I had to explain to people what I did, including my parents. They probably still had no idea till COVID what my job was, and my dad, and this is actually a true story. Every time I would see my dad, he would ask me, "What do you do?" And I would have to explain every time what I do as an epidemiologist. But I think COVID has definitely changed that. People are a lot more aware of public health and epidemiology and what is the role of an epidemiologist in the bigger picture of human health. But the specific role has also evolved over time. An epidemiologist traditionally focused on surveillance, outbreak investigation and response, on programmatic data, but we've also seen that the role of an epi has evolved and included many other subject areas, including health promotion, health education, data systems, data integration, statistics, biostats, and also the use of hopefully AI moving forward as well. And I think we as EPIs need to be, with the advent of so many new things that are being thrown at us and have been thrown at us, especially recently, we need to be prepared for what's coming up next, including all the technological advances that are happening so rapidly that it's difficult to catch up even for people who are working in the field. So for us who work in public health and FEs, as FEs, we are obviously a little bit removed from all the technological advances, but we also need to make sure that we actually keep up with all the changes that are happening and make sure that we can use these changes, including advances in science, big data systems, AI, to our advantage and use them for the betterment of both disease investigation, but also integration, collaboration, and response work as well.
Wonderful. Thank you so much, Dr. Ali. Any questions I want to open up for the audience? I know you all have been very patient and listening to all of us, and I just want to open up. We have a little bit of flexibility at the moment. So anybody has any questions, thinking, or comments, would appreciate that. Anyone? Yes.
Health is a provincial subject, and as Dr. Saab has already explained, but when it comes into practical, implementation, we never, try to implement this as per se. Like I will strongly suggest that now, when there is provincial autonomy, when the provinces are fully empowered, such, we need to have a, sort of a bottom-up approach. Bottom-up approach means from the provinces to the federal level, such initiatives has to be, because when we talk about ownership, when we talk about, acceptability, then the provinces has to be taken on board for all these issues, whether it is, infectious diseases, whether it is, TB, whether it is malaria, whether it is polio, but once, we are having, all these, strategies and all these initiatives from the federal level without being, taken consultation with the provinces, and without taken on board the provincial health departments and the provincial, Department of Health and, districts on board, there is a fear that, there will be no sustainability. So a word of caution is that, this very good initiative by this MSG is that, that we have to go to the provinces and we have to see their guidances, and we have to see what are the real issues and what are the real problems faced by them. And we have to do these exercises at the provincial level, so that, the province health department, the provincial, they should take the lead without, having, a federal level, consultation, and keeping, a loop for provinces at the federal level for every province. The province should, dictate, the province should own, and the province should implement. And, the federal should have, all these, what Dr. Scott says, all these 4 C's and all the, coordination and all those resource mobilization. But actually, the end users, the implementers, the issues, the needs should come from the provinces, and we should address, their needs. And in that case, the sustainability will be there because the provinces will own those activities. Otherwise, we have been working in this, public health for years and years, and we have seen, the project comes, and then the 4 years, 5 years, it finishes, and then, the provinces, they doesn't own that initiative because they're not that properly. The districts are, selected without consultation with the provinces. Very sorry to say, because I have been part of all those, unless and until, you take the provinces on board, the provincial health department, the provincial governments, because now Now if you see in Pakistan, there are different political governments in every province. And every province wants, to take the lead and to serve their people and to do something good for their people. Is a political agenda also. So this is us, this group, that we should, sort of translate, or we should guide them, and we should take them on board, being a public health professional and being, taking care of them.
Excellent, excellent. Thank you. I think very interesting, because the way you mentioned is there is also internal advocacy. There is a lot of internal advocacy that is necessary. Sometimes this we understand very clearly globally. This is a common phenomenon in health sector in many countries, that the project cycle does not match your policy cycle, right? And also when you are implementing, as you mentioned about the connection between your central level or the federal level and the provincial level. So listening to the provincial level and really making sure it is perfectly aligned with the demand-driven programming, not supply-driven programming so much.
Yes.
Right. Yes. Yeah. Sure. Mm, mm. Right. Course. Right. Thank you. Thank you. I know we have another question, but Dr. Mumtaz wanted to respond to that, and then I'll come to you. Go ahead, please.
So thank you so much. This is really, you just represented everyone in the hall that they are feeling what we are conducting this workshop at federal level. So this should be in the provinces, but I want to just remind everyone in the hall that basically national action plan for health security is a guiding document, is a Bible for every education for next 5 years or 6 years. So this has been developed after joint external evaluation. And joint external evaluation was conducted with the support of the provinces. All the teams, including international teams, visited the provinces. They visited all the 19 areas, the experts, they met all of them in the provinces, because basic Pakistan is made of the provinces. It's not only at the federal level. So implementation unit is the province. So without having provincial stance, without having provincial priorities, we are unable to complete the national action plan for health security. So their concerned, their priorities, their goals, and the areas where they want to improve are included in this national action plan. And all such activities are part of that national action plan. So provinces are 100% included in this, and especially the as per One Health approach. Every sector of One Health has been included in the recent joint external evaluation and national action plan for health security.
Excellent. Thank you. Go ahead.
Thank you very much. I hope you can hear.
Yes.
This is Dr. Razia Fatma. So I'm currently at UNOPS, but previously I was with the Youth and Care Program for the last 16 years. And I've seen, as Dr. Hamad has said, that he's a data person. So I'm also a data person and a epidemiologist. When we look at data systems in the country, they are quite fragmented. Like looking at all disease, what we are talking about today, and just giving you examples, for example, TB. So we have been investing a lot in the past 3-4 years. And despite around 385 million USD investment from the Global Fund, out of it, majority is on the data systems. But still we are struggling with the fragmented data system, which should be a priority for us, unless we have a strong surveillance system in the country, from which we can capture all the infectious diseases of importance. We cannot, I think, make planning, or we cannot have robust interventions in the field. So what are your thoughts about it? How can we break this fragmentation and come to a robust health system, data surveillance system in the country, so that we should not miss important outbreaks in the country, and also we should plan according to the data that is available and that is missing as well.
Yeah, thank you for that question. I actually work in TB these days. So one thing that I will say that in spite of obviously some challenges, in spite of the fact that there's need for improvement, Pakistan is one of the countries that is doing actually really well with TB response compared to many other countries who are in the top 10. So that's definitely kudos to all the people that work in TB in Pakistan. There's definitely a lot of good work happening. Of course, there's need for improvement, but definitely want to highlight that in the global space, whenever we talk about countries that are the top 10 or top 5 high burden countries for TB, and the way they are responding to their respective TB outbreaks, pandemics in the country, the conversation is that Pakistan is actually doing really good job in terms of the response work. To answer your specific question, I think the collaboration piece that we've talked about pretty much all morning is what is needed to make sure that the systems, and it actually ties in very nicely with the previous conversation about the nature of the decentralized health system, the independence of the provinces in terms of healthcare delivery. So it fits in very nicely with the need for collaboration to make sure that we have systems that actually don't just work at the provincial level. For something like TB, we need collaboration at the national level as well. So the systems not only talk to each other, but also that care can be provided across the whole country in a unified manner. Patients move, and that's just the reality of life. They don't really live in just one state or one province or one jurisdiction. They do move across borders within the country. They do move from one city to another city. And we need to be able to provide ongoing support, care, and treatment, whether it's TB or HIV or any of the other diseases. And the need for collaboration is probably the most important thing, because only then when we have systems that are available at the national level, can we truly care for people who are actually moving from one place to the next. And if the systems don't talk to each other, if the data is not available at the national level, that we won't know what the patient has received previously when they lived in a different part of the country.
The country map and then to speak to that paradigm and that contrast from north to south and even to a level of a union council, where you can find a population starting from 5,000, maybe reaching to 75,000. So a country like such a diverse geography and population dynamic, ethnicity, culture. So we need to be more, our thinking should be more micro towards focus towards district, and trying to focus how we can increase the capacity of our district, not only in terms of healthcare, but also in terms of climate and culture. So that contrast need to be there when we move in our discussion.
Excellent. I think there is a lot more to kind of unpack. There is one more here. So there's one more there, and then we'll go there. Yes, please.
My question is to Dr.
Closer to your side. Yeah.
My question is to Dr. Hamad. It is regarding the integration and the One Health approach that you have mentioned. So I'm a doctoral researcher from Colorado University, and I was thinking from a researcher's perspective that for integration, we have this awareness, we have businesses and research institutes and academia, all the components that need to come together to deliver. So some of the components are still functioning or on very traditional paradigms. So how can we bring those components to a single level or to the similar level at the same frequency, so we can achieve more prolific outcomes from the integration itself. Because some of the components like bureaucracy or governance, they are following some very traditional paradigm. So what measures can be taken in this regard?
Yeah, thank you for that question. Integration is difficult. No matter what subject area you're talking about, integration is always difficult because integration brings with it change, and change is also always difficult. I think leadership is the key piece that needs to happen based on exactly what you were saying, that the different components of integration are there, but there's still lack of true integration. And I think the missing piece there is leadership, whether it comes from the provincial level, whether it's come from the national level, whether it comes from any of the vertical programs. Leadership for integration is the piece that will actually bring it all together. So I think we need to figure out for the respective subject area, who is the entity that can take that ownership of data integration or system integration. And that leadership from that entity will hopefully be the missing piece.
Who will add something here from other sectors? I think this is interesting because ultimately you need a champion. It's interesting, you can put a lot of system in place, but you always see that something happens in a particular department or particular institute because somebody is championing the topic. And they need to move forward with that. And then you collate the consensus and build a rapport within the for that integration process. So this is really crucial discussion because that really need to really be bottom up. The other piece was very interesting that I thought was relevant. You mentioned about 1 hour, 60-minute minimum travel time. Some places we see now, East Africa, also South Asia, a few places, that this concept that is being discussed, I heard it at UNGA also last week, was 30 minutes. That of course there is no specific science that when there is the emergency is emergency. It's 1 minute is too many. But how can we really bring services within 30-minute range? And there was this discussion about also like education, which school need to be within 30-minute distance. The health services also need to be 30-minute distance because this both has to be, primary support for the families and people. So it was very interesting to hear that purpose. I think couple of more, I think we have.
Just a quick comment. I am Dr. Zaida Fatma, working as animal health specialist, epidemiologist at FEO right now. Just to add, Dr. Ziad, I'm correct. To add them that we recently, it's not like that nothing is going on with the help of provinces. We are doing, like I will give you the example and I will like to tell the people. Recently, we did at FEO 3 assessments, and the most recent one is the One Health assessment tool. That was a tool that was first exercised in some African countries, and in Pakistan it was first exercised by FEO. And that was a great success as far as we can say about the multi-sectoral approach. Many of people who are still sitting here, they were part of our assessment. And that was not like that we did it on the just invite the federal people. We invited people from the provinces, from academia, and we tried to gather, fortunately, from all the sectors, not only from the health sector, animal health sector, also from the wildlife and the environment. That was really a big success because it's not easy to gather all the people in one hall and do the assessment. So we had done this assessment. We will share it very soon with the other stakeholders as well. And also for the another tool, because if you know some working of FEO has developed some tools like another tool we have just exercised. And we went to the provinces. That was for the livestock people at Progressive Pathway for Emergency Preparedness. We went there in all the provinces and 2 regionals. And we involved those people from the sector. They did their assessment. They presented, and now it will be endorsed by them. So actual work will be done in provinces. And Dr. Saab mentioned that it should be at district level, and we are planning to have some One Health units at the district level because ultimately that should have been all the things should have been done by the provinces, and because problems are coming, we cannot do everything over here sitting at Islamabad. And also another development has been done by FEO recently, surveillance evaluation of animal health surveillance system. As in public health, fortunately they have somewhat sustainable systems, but in animal health, it is mostly on the project base. But it's not like that. Nothing is, and Dr. America mentioned that we developed this One Health strategy that was back in 2017 and 2018, and it was involved all the sectors, all from the provinces and academia and the donor agencies as well. So things are going on. We need to make more collaboration, communication, and the data sharing, as Dr. Hamad is saying. Thank you very much.
Thank you so much. Thank you.
Thank you very much. My name is Mohammad Wakar Bhatti, and I'm a health journalist. I have a question, a long question, but because Amikram Saab here, former NIH executive director, and we have Mumtaz Saab here. When we talk about strengthening of health systems, one problem I see, and I discuss often with people in the ministry and in NIH, is the concealment of data. That is a major issue that is I found, and I've reported on that. And it is such a big problem that provinces are not sharing data with the federal government. Within the provinces, hospitals are not sharing data with the provincial governments. Nobody is sharing any data with anybody. Sometimes I write about something, it appears in the newspaper, and the people in the NIH, in the Ministry of Health, in the provinces, they approach me and they say that this data has not been shared with us. So in the absence of, and I have some examples. Like every month we have 1,000 cases of HIV detected in Pakistan. That data is not shared with NIH or any ministry or any other department. We have TB cases, they are not shared with the NIH. Then we have Congo crimin hemorrhagic fever cases. Then we have Naegleria fowleri cases. We had last month we had MERS, first case of MERS. It was concealed by our authorities, and when WHO reported it, it was I reported it that we had first case of MERS in Pakistan. So in the absence of data sharing, how can we speak about strengthening the health system in Pakistan? Thank you very much.
Thank you so much. Anybody want to respond to this? Yes, that's yes.
I think you have some good questions, some good comments, and some good suggestions as well. We just had one of the news reporters who reports on the medical side as well. Can you let us know about what we discussed about the USI 4,000 systems and working in silos, and how to overcome these modalities? This is not a problem in our country. It's a global problem. So over to you, Scott, for your comments. Yeah, I hope you can hear me.
Yes, I can. I think health communication is very, very important, and it is very, very important to be transparent and open. At the same time, we have to protect the individual's personal identity, meaning that if a patient or someone is being seen in a healthcare center, their personal information should not be shared. So I think this is a very, very important question, and it's one that it's not just for Pakistan. This is a global issue, really, and really should be addressed as a part of the program planning and commitment by the highest level in the ministry to be able to be transparent and to be current with the information. So I think it's a very, very important.
Just because afterwards, जब तक मैं पे शिकायत नहीं थी ये, so just coming back, I think this is common now. That sometime back we had a discussion with the CDC boss in US, and Scott presented to the team. So many how the silo, and the systems, how can take them out and bring them on the table. So this is a common general problem, and at times it is more so because
I think, I mean, you are one of the very rare reporters who report on the medical side, but they are actually who create the hype. That hype is in some way is also to be avoided under different circumstances, and the clarity, the exact diagnostics. I mean, NIH is on the forefront, and I think, I mean, it has to be, as I said, a collaborative work from all the sides. So the integration, putting the things together, making the people understand, making the community understand. These are the challenges in any case.
Thank you so much, Dr. Ikram. Any other comments? Or there is two of them. We'll take these last two comments and then we'll try to wrap up. As we have next panel is also almost ready.
Assalamualaikum. My name is Uber. I'm from University of Oslo. I've been part of lot of implementation projects in Pakistan for last couple of
A little bit louder, louder, please.
Can you hear me now?
Yes.
Right. So, my question, it's not another question, it's just my feedback and my input. We ended up in silos, but there has to be some reason for that. And moving forward, if we learn from those reasons and try to avoid them, we can also avoid the fragmentation. I can give you an example. Madam Raja is sitting here, and she has been part of TB project. We are running a national TB tracker system, surveillance system, and the Global Fund and Gate Foundation, they are complementing each other's efforts, and they have implemented one system for public and private both for TB surveillance. So that is one of the case where is complementing each other's effort rather than ending up in silos. That can be, I think, useful in moving forward. Second is we heard a lot of honestly very charming words, AI integration, machine learning from Dr. Scott, Dr. Hamad. Of course, health strengthening has an important factor of health digitization. We cannot talk about health strengthening without talking about digitization. But for digitization, like embracing these sophisticated technologies, microservices or AI or machine learning, it's a big question. Are we really ready for it or not? Because ultimately, the system is governed by the government or the program. They should be capacitated. They should know how to use the system. Because I'm personally a developer. We develop DHISQ open source system. Sometimes we do not embrace very sophisticated technology. Why? Because the domain it is going to be used in, it will be a lot of difficulty for them to handle it. So do we have like kind of plans or any strategies to address this area as well so that we embrace these technologies, but also making sure that people who are governing the system are capable of handling it as well? Thanks.
Thank you so much. Thank you. Right. And there is one more comment, last one. Yes.
Assalamu alaikum, everyone. This is Dr. Abdullah Mansoor. I'm sorry, I'll be digressing from the main scheme of discussion, but I have a question for Dr. Amir. In your presentation, there was this, you mentioned the prospect of mRNA transfer technology to Pakistan. So would you be kind enough to shed more light on it? Where are we exactly on that timeline, and what is the ultimate goal of that transfer?
Well, you see, a vaccine is a health security concern, and it's an issue. And I can briefly let you know because we don't have, but on the sidelines I can tell you a lot. Pakistan just produces 7% of the country's requirement right now, and most of the vaccine is in the public sector domain. I mean, talking of the expanded program of immunization. So I mean, we started working on a best possible production within NIH because the public sector, producing for the public sector is much more easier, and there was a huge requirement. And with all that, during the COVID, we conducted the first ever clinical trial. And based upon that, we got the transfer of technology for the adenoviral vector-based vaccine to be manufactured, and we manufactured 20 million doses. And that was yet another huge success, challenges within a challenge. But coming down, based upon that, we applied for the messenger RNA technology, and this was not an easy task because nothing less than the US president signed waiver for the transfer of technology to different countries. And first 5 countries were to be selected, and NIH underwent a long assessment, and we were very successful in to be selected among the first 5 countries for messenger RNA. It's on the card. The teams have been trained in IVI Korean Institute twice. In Germany, we have been to South Africa, which is the hub. Actually, this is the hub and spoke model. So the hub is in South Africa, and the spokes will be one of the spokes. So this is in brief, but we can talk a lot, and it goes beyond COVID now. And our suggestion at the last meeting in South Africa was, once the COVID over, we start regionalization and production according to the local requirement for them. And this goes beyond vaccination. It goes to cancer treatments and all that. So much to say. Thank you.
Korean team is right now at NIH today. So they're discussing the transfer of technology to NIH. So the progress is going on.
Thank you so much. I would like to wrap up. I know it has been a wonderful session. I'd like to thank Dr. Hamad Ali, Dr. Mumtaz, and Dr. Amerikram, also Dr. Scott McNabb online for being with us for late night in USA. Thank you so much. A big applause for all of you. We are taking a 5-minute break. This is just for stretching. And if you want to just, do anything you need to do. And we are extending the next panel in 5 minutes. Thank you. Thank you so much. Welcome, everybody. We would go into the next panel now, which is very important panel here. Universal health coverage and health system sustainability. So we have Dr. Hala Al-Masoui. She's a global health and development leader and also our senior technical advisor based out of Washington, D.C. Dr. Hala, can you hear us?
Yes, I can hear you well. Can you hear me well?
Thank you so much. And then I also have Dr. Hassan Makbul Ahmed. He's a senior technical advisor, Center for Global Public Health, Pakistan, and Institute of Global Public Health, University of Manitoba, Canada. Thank you and welcome. I'm not sure Dr. Gazna is having some difficulty. Dr. Gazna Khalid, she's supposed to join online. She's having some difficulty with the technology. As soon as she's online, so we will be also including her. So I will hand over to Dr. Hala to give a context and start the session. Thank you, Dr. Hala. And I know it's very late night, early morning in Washington. We are sorry for this, but we thank you for joining us. Thank you. Go ahead.
Thank you. Thank you, Shakil, for that kind introduction. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, good evening, good afternoon. I see we have more than 21 participants joining online. So welcome everyone to our panel discussion on universal health coverage and health system sustainability in Pakistan. I will be your moderator for this session, as Shakil introduced me and the panelists. Today, we have the privilege of hearing from two distinguished experts who will share their insights and experience on this critical topic. As you all know, universal health coverage is a fundamental goal for ensuring that all individuals and communities receive the health services they need without suffering financial hardship. Coupling that with the sustainability of health systems, this goal presents unique challenges and opportunities everywhere, including in Pakistan. So our panelists today are here to shed light on these aspects. So allow me to introduce them again. I believe we will have Professor Dr. Ganza Khalid who will be joining us online. She's the country liaison for Pakistan at the Global Financing Facility. Dr. Ihsan Makbul Ahmed, he's Senior Technical Advisor at the Center for Global Public Health, Pakistan, and the Institute of Global Public Health, University of Manitoba, Canada. He has a wealth of knowledge in public health strategies and global health initiatives. So let's dive right into our discussion. So I will start with Dr. Ahmed. And my question for you regarding access to healthcare and equity and access to healthcare is a critical component of universal health coverage. So I would like you to shed the light on key steps that being taken to ensure that marginalized and vulnerable populations in Pakistan have equal access to healthcare services. And also, if you can elaborate more on what more can be done to address disparities and ensure the sustainability of these efforts. Thank you.
Thank you, Hala, and MSG for providing me this opportunity. Equity, I guess, in terms of equitable access to services and the various dimensions related to equity, may it be being a resident of a rural area versus an urban area resident, being educated versus non-educated, let's say being wealthier as compared to being poorer in terms of wealth status or economic status. So many dimensions of equity that need to be addressed, I guess, to make coverage of health services being more universal, or maybe we as a group tend to think about it, that we label it as universal health coverage, but it's primarily coverage of health in a universal manner. Now, the word universal in itself applies in terms of its entirety of covering a given populace, a geography within a given time frame, and that pertains definitely all the populace, and that includes the privileged ones and the non-privileged ones, with the equity lens and whatever dimension or stratification of equity we are thinking of or looking at. So To address the equity part, there have been a few very promising initiatives in the country, especially for universal health coverage and enhancement of coverage of health services, as we can sort of label it. Sehat Sahulat program, which is a social protection program currently covering almost 75+% of the population of the country to some extent or completely, is a social protection program to minimize catastrophic health expenditure. Although it's a specialized program for specific number of conditions and health conditions and not really applying to all encompassing sort of a focus for disease prevention and cure, but something that has turned out to be a very useful model in providing services, and specifically those type of services like cardiovascular surgery or complicated delivery, natal services requiring cesarean section services or dialysis and renal implants sort of. So very high and sort of very high cost sort of procedures and those being covered through this program across nearly almost most of the parts of the country is one part where the poorer and the more disadvantaged to get Sehat Sahulat program card registered through their national database, which is a registration mechanism for the citizens of the country. And then, of course, they can utilize those services both from the private as well as the public sector, which are included in the landscape of the empanelment of services, empanelment of health facilities and hospitals. So that is one very big initiative. The government has really put in a lot of money. It has gone through its good launching, expansion, and then sustainability. And there have been its and buts about and the sustainability in terms of the financing, quality assurance, adaptability as well. So it's expanded well. It's covering a significant chunk of the population and definitely providing services to those who are the most marginalized, less privileged. But of course, there's room for improvement, and it can further enhance and further qualify and make its processes more efficient. Similarly, for besides specialized care related mechanisms, then for primary health care, one essential aspect that needs to be strengthened in the country to make services more equitably accessible for the populace needs to be strengthened. Recently has been quite emphasized by all provincial governments, including the development of the essential package of health services by the federal government and then by all provinces, then being costed out, and then the respective governments allocating money, plus the international donor agencies, financing institutions like the World Bank, providing a common umbrella of financing and implementation under the National Health Support Program. And my counterpart, Dr. Ghazna, is also involved in that loop of the thing as GFF representative, including the Ministry of National Health Services and all provincial governments. And the specific focus of this essential package of services that derives its concept from the Disease Control Priorities 3 and the Universal Health Coverage mechanism is to embed and strengthen a wider range of services at the primary care level, make primary care level not only primary healthcare services related, but quality primary healthcare services related, and it to titrate the system in a way where most accessible, as Shakil in the previous session also mentioned about access, geographical access, economic access, as well as social access to services gets addressed by having services near the people where people reside. So that sort of mechanism has really gone in. A lot of funding has also been made available, and gradually it's getting to be utilized by the provincial governments, as we've talked about Pakistan's healthcare system as a devolved health system. In the context of disease surveillance, what we're talking about today, and also in relation to its linkage, its marriage with universal health coverage, both part and parcel of the overall better health for the better populace related, and also markers to monitor the better health status. So equity is something that pervades across all dimensions. Now, I guess the rural areas get less attention, less financing, less state of services. Urbanized areas get more set of hospitals, more accessible to services as well, and facilities and the setups within the public sector are also pretty much aligned with having concentration of higher end facilities within the urbanized areas. So that is where a lot more work needs to be done. To improve that, the governments within the country and specifically at the provincial level have had some very useful public-private partnership related initiatives to improve the access and equitable distribution of services. Immunization is one good example, since being one primary example where digitized immunization registry is being maintained for the last few years now. Pretty accurate and has contributed markedly towards coverage of immunization, childhood immunization, as well as those for pregnant women during pregnancy. It covers every district, every union council embedded within the health department, and making vaccination accessible for the entire populace of the province is one good example where equitability has been one major undercurrent in provision of EPI services holistically. And then that is also tied up with few other functions in terms of implementation mechanisms like for distribution of vitamin A supplements during immunization activities or special immunization days as one complementarity coming into the implementation mechanism. So there are many pathways that have been tested, some on limited scale, some to a large scale, province-wide scale as well, provide a lot of promise, provide good results. Similarly, for universal health coverage and its equitable access, one key aspect was also to engage with the private sector, which accounts for almost 70+% of services utilization in the country. Dr. Radia said, in tuberculosis programs under CMU Common Management Unit has engaged private sector providers for case identification, notification, and then treatment follow-up and treatment completion sort of stages across TB identification and its treatment. So that is one part where through private sector, government-related mechanism of service provision is also going through. So a lot of examples in recent times, anecdotal as well as recent. But things need to be maybe strengthened, harmonized, coordinated, and then of course brought in a more let's say holistic, comprehensive approach that caters for not only the health side of things, but all those aspects which pertain to equity, the disadvantage related to the dimension of inequity, and then how that gets addressed within a social system in a given population, and then also linked up with the set of health services used by the country and its people. Yeah, thank you.
Thank you, Dr. Ahmed, for the really great insights. It's clear, as you mentioned, and as we read in many reports by WHO and other organizations, that Pakistan has really made strides in achieving universal health coverage. However, according to a report by WHO, about half of the population still lacks access to essential health services. So I appreciate you highlight some key social health protection initiatives, and also ensuring that while Pakistan is on the path to universal health coverage, sustaining these efforts and strategic investments are very crucial and important to fully realize this goal. I'm not sure if Dr. Ganzish joined the session, but I can move to the next question, Dr. Ahmed. If you can elaborate on specific policies and strategies that have been implemented by the government to advance universal health coverage and ensure the sustainability of health systems in Pakistan. And how effective have these measures been, and what gaps still need to be addressed?
I mean, in terms of the government taking the initiative, one main thing that pervades across country is the devolved mechanism of health services planning and strategy development, and then services provision and implementation. So provinces primarily have the mandate, but then federal government also works quite actively with them to work on newer initiatives, strengthening existing initiatives, and also for coordination purposes. So various initiatives taken. One most primary major thing done in recent times for universal health coverage is the development of the essential package of health services. So it was really translation of the disease control priorities 3 encyclopedia, keeping the country's health system in front of us, and then trying to bring all of these together to develop a universal health coverage related benefits package, and then developing a generic one, and then sitting with each province of the country, all the relevant stakeholders, including partners, UN agencies, to have province-specific universal health coverage benefits package. Something that hasn't had not been there for at least 2 decades or so. So the country and its provinces did have minimum service delivery standards, but how to adhere to those standards, what set of services to be given at the primary, the sub-primary, the secondary and tertiary care levels was something that was more, let's say, anecdotal and historical rather than more concurrent. The biggest challenge the country had was that the data related to the prevalence of these diseases made be communicable, non-communicable was quite limited. And because of the verticality of various programmatic approaches within the health system, data on few select number of diseases was amicable or appropriate, but in most of the diseases, the spectrum was not covered. So how to assess what is the burden of a certain disease and type of disease and what set of services to address it need to go into the primary level or the secondary level or the tertiary level. So that translation was then used by using the IHME global burden of disease data, from using service-based data, also employing routine information systems. There are enhancements going on in that side in relation to digitization and integration of systems, including the HIS2 enhancement as well. So bringing all these pieces of the puzzle together and then finally translating it into province-specific, district-specific, systems tier-specific set of services by and agreed by all. So it was a long process, but got adopted, approved, and all ministers of health from the provinces and the federal government signed it. The next part, the financing thing. So for financing, coordination was done, advocacy was done, international financing was brought in. PC1s were developed for specific components like hepatitis C, AMR, disease surveillance and response, as well as primary healthcare strengthening, surveillance strengthening. So there are multiple pieces that are being brought together under the umbrella of the Universal Health Coverage Benefits Package, and the federal government took the lead on that. And the most important part, which I think has been emphasized since morning, translating it, but keeping all the private sector partners together. So we were sort of involved in a mechanism where the General Practitioners Association of Pakistan was part of it, Pediatric Association was there, the Society of Obstetrician and Gynecologists, all of them, some of them working in the public sector, but also having private practices, or the people coming from the private sector, surgeons, gynecologists, physicians, medical specialists. So all were brought in to the loop, along with NGOs, CSO sectors as well. So there is one part where the government has really taken a major undertaking in the last 3 or 4 years. Although COVID was one phenomenon which sort of hampered the efficiency of this process, given the stop and go and sort of thing. But still, the pathway is there, and getting a unified pathway within a devolved health system in itself is a great achievement. So that's one example. Besides that, we have the federal government, along with the provincial governments, and provincial governments have taken lead in a few mechanisms as well, including vertical programs becoming in terms of governance, improving governance, and trying to bring them together. So Sindh government has recently worked on and trying to work on unification of various arms like the population welfare and human health, as well as nutrition components being brought together. Punjab has already done that to some extent for integrating reproductive, maternal, and child health services under IRM and CH program. KP is in a similar trajectory. So provinces are taking these initiatives to bring all these efforts together to bring them in a more efficient management and governance system as well. So that's another initiative. So a couple of examples from my side. Yeah. Thank you.
Excellent. I really appreciate that. You highlighted the primary challenges, you highlighted the key initiatives, as well as you move to the role of private sector, NGOs and CSOs. So this is great. I would like to maybe open the floor now for our participants to ask questions. And I have a few more questions, but would love to hear from the participants their questions. Then we can move to other points if needed.
Thank you very much, Dr. Hassan, for your excellent panel discussion, and Dr. Hala for chairing this. So I know, and I want to acknowledge, Dr. Hassan, your work for last many years, that bringing all the pieces together and thinking about the UHC is not an easy task, but I think Pakistan has done a lot of progress. I just want to say that recently, last week, I was in Geneva for Impact Measurement Task Force for tuberculosis. And over there, it was one of the methods that are being used. They were used in the past, the prevalence surveys and inventory studies. But recently, there's a new method they have introduced, is using UHC data from the country in the modeling estimates. So I just want to ask that, are we confident that by what time we will be able to have this data available, robust, and in a form that can be used for the estimation? Because we discussed this point, and I told them that obviously for many countries, probably it's a different benchmark we are talking about, but we have to be a little bit cautious, because we have to think that how much data we can capture, and is it available, and at what time it is in a measurable outcome form, so that we can use it in the modeling. So this is my question to you. Thank you.
Yep, pretty much it, I guess. What I related to in terms of the development of universal health coverage benefit package was using indirect estimates, because we do not have real estimates, maybe. The second challenge, of course, which you already highlighted, is having holistic data, complete data, timely data, accurate data, reliable data, and then using the data for derivations. Is all those aspects which need strengthening in the country. One good work that really has gone through into the system, and talk about the public sector side there, is, and I think Zubair has been sitting at the HISP team, has been quite engaged with all with the programs to translate the existing system, and maybe not really necessarily transform the system, but bring them together, just link them together so that we have a picture. Currently, the federal government is estimating the universal health coverage index for the provinces as well as the national level, and then the districts as well as of 2023 now, primarily through estimation, but where there is some data is better than no data sort of thing. So we are trying to move in that direction as a country, as well as we are moving the provinces to do better on that part. So that UHC index estimation is there for the districts, and that could be follow up and then could be further refined across time when we really are into the implementation and then improvement and then monitoring of those indicators as well. The second part, of course, it relates to the country's responsibility to report on SDG indicators, which includes IHR index, which includes SDG related index. So that is one part in which all provinces do share data, but on an episodic basis, and it's not really a unified or a harmonized sort of a system still. But in terms of the verticality of functions, yes, it's quite harmonized for the programs that are currently running and getting financed and implemented. Sales program is providing reasonable data, but again, it's tertiary care data, not representative of the population. Surveys are the main source for us to provide denominators in that sense. So that is where we are working. Two of our very esteemed colleagues, Talib Saab and Sitting, Green Star is partnering with the government for documenting, for provision of services, and also helping derive the denominators of the population, which is the main thing to help us understand what the prevalence is, what the proportion is, what the rate is, and has the proportion got reduced over time through intervention sort of phenomena. So yeah, that is happening, but it'll take some time for systems to be embedded across all districts of the country for disease surveillance response. We've had the setup of disease surveillance response units established at the district level now. During the recent years, COVID has given it a good push. Recognition of information has become more evident for all people as compared to it was anecdotally more popular among the scientists and the researchers, but not necessarily the managers. So that is translated well. COVID being the silver lining around COVID was that. So we're working on that. It's improving, but of course, a lot of work needs to be done. Fragmentation of information sources, the timeliness, completeness, reliability has always been a challenge for most countries. I mean, COVID set a good precedent again in terms of information sharing, getting it through the private sector, every lab reporting, every hospital reporting, but that was not a precedence in the country. So one good example which can be followed up for universal health coverage. Yeah.
Excellent question. And data quality, by the way, quality utilization reporting is a critical challenge everywhere, not only in Pakistan. And it's a critical area need to be addressed everywhere. It's very important, and I'm happy to see that many programs, whether government programs, donors funded programs, other programs, include data as one of the key objectives. Thank you. I think we have Dr. Khalid joined us.
Yeah.
Doctor, yes.
Was not online. You can request her now to say a few words. She's there finally online from UAE.
So just to confirm, Dr. Ghazna is with us. Sorry.
Yes, thank you, Dr. Hala. Thank you so much for your very kind introduction, and my sincere apologies for not being there in person to join this very august forum and important talk. We've had some technical challenges this morning, so my apologies once again. Dr. Essen has, given a very candid overview from what I have heard of the work towards universal health coverage in Pakistan, and he is a huge pioneer in the field. In the interest of time, I'll keep my comments very, very short, and I'd like to see from the panel and from the participants what they'd like to ask. But I think that universal health coverage and health system sustainability is extremely important. And these concepts are central to ensuring that everyone can access healthcare. I mean, this is the raison d'etre for the reason why we're doing this talk, in a nutshell. I think that there are areas which the donors or the partners can help in terms of alignment, coordination and alignment of donors to help to basically make this happen. So access to essential health services, preventive care, vaccines, antenatal care, they need to be combined together. And I think I'm involved. So I look after an organization in Pakistan called the Global Financing Facility, which is the biggest donor for RMNCH and nutrition. And the country basically is crying out for work on nutrition vis-a-vis our rates of stunting, malnutrition, and this cross-sectorally links to everything. So it's universal health coverage. It links to antenatal care, family planning, intrapartum care, etc. Where I feel that we can work without going on with the rhetoric is for the outsiders, which is a drop in the ocean for Pakistan. So it's not like other countries where the donors give the major areas for the financing for health programs. The government of Pakistan does the major contribution. But we can do resource mobilization and expenditure tracking, which we have done. We can also look at the alignment in terms of using data for evidence-based structuring. So interoperable data systems. We have many data systems in Pakistan, and they need to talk to each other, and they need a repository to be able to be interoperable, to use that for evidence-based medicine. Quality of care needs to improve. So for example, I'll give a simple example. If you took antenatal care, which is a cross-cutting area which will impact the first 1,000 days, it will prevent intrauterine growth retardation, small for gestational age babies. But antenatal care is a bit hit and miss. There are 4 essential components which constitute quality, which sometimes can be missing. And that is what I mean by improved quality of care. So looking not just at training, but looking at the competency of the care imparted with the healthcare providers, governance structures. How do we ensure governance? And how do we use the existing structures to prevent silos, to ensure that the execution or the implementation of what we say is being done, without creating, different parallel structures. And then public financial management, increased domestic resource mobilization, creating charter of accounts. And I mean, I know that this work is already being done. Pakistan is a complex country. It is, 5 or 6 different countries working within, but the federal government has a key role in knowledge sharing, coordination, and the use of data systems to help with the provinces and to work with the provinces. So these are the bottlenecks that we have felt working within Pakistan in terms of implementation. Not to say there are not political and economic instability, but that happens in many other countries too. But we need to improve. We have workforce shortages. We need to improve the quality of care imparted to the patients on the ground. And there is a big, there are big divides between what is available in the urban setting and the rural setting. So we need to try and bridge those gaps by having institutionalized quality of care within training systems, not looking at number of trainings, but looking at the quality coming out of those trainings. So one of the areas I'm involved in is a program for results. It's some work that the World Bank is doing to improve the quality of care and reform universal health coverage. And so what we are facing are areas of bottlenecks with quality of care and implementation difficulties. And that impinges on the universal health coverage because people are not able to access the same care that they would in the city and in some rural area elsewhere. I heard Dr. S, and I caught the end of his talk where he was talking about using private sector. Yes, we absolutely need to use private health, infrastructure, which is huge in Pakistan, and it's very innovative. So if we can utilize the private healthcare infrastructure, public services can be made more accessible for the general population. Things like diagnostics, things like neonatal care, which requires very specialized neonatal HR resources. If we were to give that to, for example, in Pakistan Institute of Medical Sciences at PIMS, the neonatal unit has been given to Lifeline organization, which is an NGO, and they manage and look after a tertiary care, special care baby unit. That can be replicated because Pakistan has one of the highest neonatal morbidity and mortalities worldwide. So that can be helped with the use of healthcare infrastructure within the private sector. I'll stop there. I don't know. I'm sorry for not being able to be visible, but it's been challenging to get on board, and I'm happy to take any questions that your audience may have. And then a pleasure to meet with you, Dr. Hala.
Thank you so much, Dr. Khalid, for that very insightful overview. Actually, you highlighted so many important and critical points, talking about governance, engagement, collaboration, data, emphasizing equality, implementation. By the end of the day, if we have all these plans, structures, policies, implementation is very important. Measurements. I also appreciate highlighting how how can the private sector and non-governmental organizations contribute to the achievement of universal health coverage in Pakistan. Also, you highlighted some successful models for partnerships. So appreciate that, and would like to hear from the audience and participants if any questions to Dr. Khalid or Dr. Ahsan.
Hello, I'm Dr. Talib Lashari. I would like to really comment Dr. Hassan and Wazna both have really briefed very comprehensively about the UHC and how we are going to inculcate into the health system in Pakistan. So one of the, I think, challenges are one of the important area that both of you can address, Dr. Hassan and Raghunath, that how to integrate the family planning into the universal health coverage so that the access of women and girls improves. This is just a comment and story.
Thank you very much. This is Aziz from Green Star Social Marketing. I think it's a very wonderful discussion, universal health coverage, and the road to universal health coverage cannot be traversed without having the primary care physicians. In Pakistan, in the private sector alone, there are 140,000 general practitioners who are trusted, who are deeply entrenched into the community. And they enjoy the trust. They are in fact a brand in the community. No infrastructure required. So I think universal health coverage discussion going forwards must involve leveraging from this resource that exists within the Pakistan society. And I would like Prasad to comment on it.
I mean, we talked about public-private partnership models. And then besides those models, the procurement of services sort of mechanisms, which might be another avenue besides the port partnership model. And then thirdly, in relation to the government partnering with the community level, let's say smaller organizations or even people like this directly. Green Star is one good example. Immunization related IRD and Indus Hospital, one another good example. TPHI, Sindh government, Balochistan government, another good example. Province-wise, both of these latter ones, I guess, and good workable model, which can get further strengthened, more transparent, more reliable over time. So the precedence is there. Similarly, exchange of data during COVID, we saw each pathology lab was reporting on COVID testing, positivity rates, those sort of things. So they can be brought under the same umbrella for sure. I mean, we did discuss briefly since morning about use of technology, harnessing technology. I think it's like we all are using technology, but probably the health sector hasn't prioritized technology enough for it to be used both for population control, welfare, birth spacing, family planning, as well as for the health and then the nutrition part. So we are using technology, but we are not prioritizing it for health and then trying to bring all those resources that are existing together through linkages, then let's say merging and then integration of data systems, sharing it to some extent. Bhatti Saab talked about sharing accessibility of data for the populace. That's not been there. COVID, again, one example, it was there as a dashboard, open access dashboard. So you could see the number of cases reported, number of tests done, positivity rates, the epi curve on a daily basis. Every Pakistani citizen could do that on their own mobile phone. So that's one example, another in recent years where we really have tried to bring together sources of information as well as sources of service provision together in a common platform, or let's say reporting mechanism or visual illustrative sort of web page. Now, bringing family planning services and health together, it's an anomaly as compared to many other countries where Pakistan has separate departments for population welfare at the provincial levels and then at the federal level as well. But then the federal government started off, so the population welfare and then the health were brought together in the same umbrella. Sindh, as I understand, is the first province that has taken that initiative. And then other provinces have taken sub-initiatives in terms of one example, which I said that in Punjab, they brought together the IRM and CH components. So the Lady Health Workers program is housed along with them. The CMW program is housed along with them, besides the family planning components related to it. The third, I think, aspect which I would definitely like to comment in is that although these are two separate departments, but when we look at the public sector side of the structure of the system, so you would find the reproductive health services centers within the premises of the Tehsil headquarter hospitals. So geographically, they are within the same premises, but the reporting mechanisms are quite separate, and that also adds to the verticality, although they're present in the same place. And the client or maybe the patient has to visit the same hospital to acquire, let's say, mother and child health related services, as well as for reproductive and family planning services. So the precedence, again, in that sense of housing them together has been there. The functional integration needs to go more comprehensively in that sense. And yes, the examples of federal government and Sindh are good precedents for other provinces to follow in that sense. Yeah.
Thank you so
Great.
much.
Sorry.
Hala,
Go
can
ahead,
I
Dr.
come
Hala.
in?
Of course. Please go ahead.
Thank you. And thank you, Dr. Essen, for your very insightful comments. And hello, Dr. Talib. Dr. Talib is one of my mentors. So very humble that he's asking me a question. I think that there are two elements that not being repetitive, but adding to what Dr. Essen has just said, I think the availability of commodities. I know that Sindh is a great success story to some extent, but I think the availability of long-acting reversible contraception is left a little bit to be desired, or a lot to be desired right now. I think that one size fits all doesn't work in all different provinces of Pakistan. What works in Sindh may not necessarily work in KP. But having said that, I do feel that we need to bring contraception and the availability right down to the lowest provider at the grassroots level. So what Dr. Essen talked about, community midwives, lady health workers. Remember, only half of the province or a given province is covered. So you have uncovered areas. What about those uncovered areas? How are we going to get to the women who may not necessarily access care? That how will we get to them? So that's where the private providers come in, and strategic purchasing of those private providers. I think that from a gynecological or a family planning clinical point of from a merely clinical aspect, women come to get checked up after they've had a baby. They mostly, or as soon as they've had a baby, they are in the facility or with a healthcare provider. In most cases, with a provider that can be utilized for both nutritional counseling and for family planning and for long-acting reversible contraception at that stage. We have a one point of contact in most cases. They will not come back and ask for help. And if we can capture women postnatally, immediately after delivery, this is a good way to increase our uptake of contraception. I'm just speaking from bearing in mind that these commodities will be available, but this, from a clinical perspective, this would be a good way of capturing more and more women for postpartum contraception. Obviously, we need to counsel for antenatal care, but we will capture these women. These women can be there and can have a IUCD inserted, can have a implant put in, and so this is an area which I think we need more work on, and we need to, in our cultural context, this is where we can leverage the community workers, but also the clientele. I'll stop there, and thank you so much for asking this question, Dr. Talib.
Thank you. Thank you so much, Dr. Hazna. So I believe we are at time. Thank you both. I'm not sure, Shakil, are there any other questions? Sorry, because I don't see the audience from this side, from this angle.
There is another question, Dr. Hala. So
sure.
unless you have
Let's take. Let's
Yeah.
take another question if it's okay with you all. But yeah, let's take another question, then we can wrap up.
No, I think we don't have any other questions here in the hall.
You don't? Okay, excellent.
So if you, unless you want to do a little bit of closing remarks, we can close it.
Sure. Sure. Thank you so much, Shakil. Thank you so much to the participant. I'm sorry. I really wish that I'm there with you in person, hopefully another opportunity. Thank you both, Dr. Hassan and Dr. Ghaznav, for your valuable insights. And as we wrap up this session, from what we heard and from what we know, it's clear that achieving universal health coverage and sustaining and ensuring the sustainability of health systems in Pakistan requires a multi-faceted approach involving policy reform, stakeholder collaboration, as well as strong commitment to equity. And I would like to leave you with a thought. Universal health coverage and sustainable and resilient health systems are both goals and journeys toward a healthier and more equitable society. And let us continue to work together. Every one of us has a role to play. Let us continue to innovate and advocate for a future where health for everyone in Pakistan is a reality. Thank you so much, everyone, for joining us today. And please join me in thanking our panelists for their valuable contributions. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you so much, Dr. Hala. Thank you, Dr. Iqbal, and also Dr. Ghazna. This was a wonderful session. So we are wrapping up this session. Right now, we will get into closing for 1 hour for prayers and also for lunch. Thank you so much. Thank you, everybody. Small announcement. One in the hall here in person. There is a photography that will happen, a group photography for the event. So you are first asked before you go to lunch. No lunch will be provided without the photo. You are captive. No, we will all go outside of the door and then take the group photo. Then we will all go to lunch. Lunch is already done. Thank you so much. Thank you. And see you all back at 2 o'clock. Please do not escape. Come back at 2. Thank you. Thank you so much. Welcome back, everyone. Hope you had a good lunch. I know after this kind of lunch, I feel sleepy. Biryani, chicken, goat, mutton. Of course, who want to talk about work? But we will continue. And I guess you all are used to this. So thank you. I hope you enjoyed the morning session. There was keynote and also the panel. We have a very interesting afternoon, and we have multiple panels, 3 panels left that we're going to be talking about many issues. This particular panel is about public-private partnership. Of course, this is easier said than done. The public-private partnership is not an easy task. We have been trying throughout the globe with partners on different sectors also, engaging private sector. And of course, there is really amazing examples of public-private partnership here. We have been also engaging with the P3 authority. We have discussed with them, Malik Ahmed Saab. There are a lot of opportunities and work that could be done and is happening. So without delay, I want to introduce Dr. Saeed Azizur Rab, who is the CEO of Green Star Social Marketing, premier organization working on public-private partnership in Pakistan in the health sector. We also have panelists, Professor Dr. Shahzad Ali Khan, the Vice Chancellor from HSA, Health Services Academy, Dr. Syed Shah Miran, Chief Executive Officer at Medical Emergency Resilience Foundation, MARC, and also we have Dr. Talib Lashari, Technical Advisor, CIP, Focal Person for STEAM, SP 2020. So I'm going to be handing over to Dr. Rob for moderating, so I can sleep.
Thank you, Sakil. Rabbi Shahli Sadri wa Yassirli Amri, Wahlul Uqdatam min Lisani Yafqahu Qawli. Rango Khushbu ke, husn khubi ke, tumse hain jitne istiare. First of all, hats off to you. Post-lunch session is usually considered to be a graveyard session. So if you stay, alive and awake, credit goes to my presenters here. Yeah. So, ladies and gentlemen, we are about 240 million now, fifth largest in Pakistan, in the world. And clearly, it is not about numbers anymore. बात तादाद की नहीं है, इस्तेदाद की है. Our ability to allocate our funds in proportion to that is far from what is really expected. Pundits prescribe a lot more from where we are. It's about 10 to 12% of our GDP, and we are nowhere near what we have been able to allocate for health. So much sought after sustainable, scalable, resilient health system, it remains a myth in Pakistan. So what are the challenges and how we can overcome is something we would like to grapple with. There's an African proverb that if you want to go quickly, go alone. But if you really want to go far, you need to bring the team together. And here we are talking about the team, public-private partnership, and what wonders that can do. Now, we know that it is an estimated 70% of the population. What is the logic behind the public-private partnership? Somebody said 75 to 75% of the population from out-of-pocket expenses, they come to for the healthcare, seeking healthcare. Private sector has been working in Pakistan as an extended arm of the government. And the ecosystem exists in the private sector, comprising of general practitioners, traditional health healers, GPs, LHVs, CMWs, retailers, and chemists. So this ecosystem exists in the private sector. Now, what are the benefits that we are seeking from the private sector? What does it bring to us? MSG is in Pakistan. They are exploring various ways to bring resilience to our system. We are really grateful, and we really welcome them in our country to be contributing and chipping in helping find that resilient sustainability factor. So this partnership, as I said earlier, brings work discipline, quality of care, technical expertise, and accountability through performance management systems. Today's aim is to have this panel would be discussing the success stories of the public-private partnership. That's number one, because we see from the public sector, private sector, and academia, very strong gurus who has been around for quite a while. So they will be sharing with you success stories of the public-private partnership. Where is the gap in the policy making, or do we have enough policies, or we have all the policies, implementation and effective strategies and implementation is the problem. Collaborative opportunities that exist and the donor support that is available on ground. So without further ado, I'll go to my participants and pose a question. I'll start with you, Shahzad. Directly, that public-private partnership is a tested module worldwide to bring efficiencies in the system, reduce the cost, and expand the level of services applicable to a wide variety of sectors, especially the healthcare. So, sir, we would like to hear from you how academia and other capacity-building agencies can help formulate evidence-based policies to expand the public-private partnership initiative in Pakistan. Make sense?
Thank you, Aziz. Am I audible? Assalamu alaikum. Thank you, Aziz. Actually, like you mentioned in your slide, public-private partnership for Pakistan, it has been researched quite well. And in academic institutes for the last decade, we are actually developing some of the modules for this public-private partnership concept. It was, first of all, it was launched by the World Bank when we developed a project by the name of People's Primary Health Initiative. And then it became the President's Primary Health Initiative, and then it becomes People's Primary Health Initiative. So the logic of public-private partnership for Pakistan is very simple. Number one, you accept it or not, the government policy or the government people, they accept or not, the private sector is there. You mentioned it's 70% people, they go to private sector. So it's a reality. So whether the government use them or not, they are there, and you don't need to create something for this public-private partnership. Like in Africa or many other countries, there is no private sector. So they can never think of public-private partnership. Pakistan is lucky to have a very huge investment by the private people, not by the government, into the private sector. So it is there. Number one. Number two, the evidence tells us not only that it is there in Pakistan, the private sector is a reality, people are using it. Again, when you said majority of the consultations in Pakistan, they are happening in the private sector, almost 80%. So it is there, people are using it. Number three, there is an evidence in Pakistan that this private sector has the capacity. Government sector, hospitals, government sector of the Pakistan has limited capacity. The private sector has unlimited capacity. You cannot enhance one bed or one medical officer position or one nurse in a government hospital without going through a hectic channel of, creation of posts. And in the private sector, you just tell them next day they will have 10 more beds, more doctors and more. So the capacity issue is not there. And the last one, the perception of quality in the private sector for the Pakistani patients is higher as compared to public sector. And the last one, it makes an economic rationale. So there's an economic rationale that the private sector will work for the profit. So they will be seeking some profits from their operations. So their businesses will be more efficient than the public sector. So they are there, people are using it, there's no capacity issue, they are giving good quality services, and there is an incentivization of expansion to them as well as the efficiency. They have much higher efficiency as compared to a government hospital. You compare the efficiency of Shifa with PIMS, you will be astonished to see how much less money is going into the private sector and how much output they are having. So this is well researched, the evidence is there. I think we should be leading forward from there.
Excellent. Thank you very much for an excellent summary of the rationale behind it. Can I put another question on the same sequence? Yes, there is evidence coming from you. It is based on a lot of observations, studies. What are some of these success stories so far, do you think? What are your recommendations for the P3 initiatives in Pakistan?
Not much as far as the impact evaluation is concerned. We did the third-party evaluation of PPHI, and we did a lot of evaluations for NTP, National TB Control Program, Public-Private Partnership, EPI, Public-Private Partnership. We also evaluate the the polio program, civil society component. So there are patchy evidences available which have shown. I think the NPPI district, the NPPI of Sindh, it was I think the first most public-private partnership initiative in Pakistan, and then they are still, Sindh is the only province which is still continuing with People's Primary Health Initiative. So the evidence of evaluation, they tell us that there are many success stories. There are success stories in EPI, TB, polio program. There are some success stories in health system strengthening. The JSI component, which USAID did here last I think a few years ago. The public-private partnership for MCHIP and others, they've shown very good results. So the impact of public-private partnership on the health outcomes, on the poor, on the women, has shown quite good results. The challenge is that we have been doing a very small level, patchy and fragmented work. It was never integrated. So we should come up with the lesson learned from the success stories from the past to make up a very compact national level public-private partnership mode for health. Otherwise, I don't think the coverage and the other things which we need, we cannot achieve that without the involvement of private sector.
Thank you. A very big round of applause. Very well put. Excellent summary of what is it. Can I have Dr. Talib's presentation, please, on the trainer?
Dr. Saleh, while we put your presentation, you have worked with the government for a very long time, and you're also considered in Pakistan as an architect of the costed implementation program. And government of Sindh has been actively working with the private sector with the development of programs. And we just heard about the PPHI, which is very well acclaimed for success, and the story to expand health services at the primary care level. So what do you think, and how do you see the role of private sector organization in implementation of the plans of the government, including CIP first? And what are the successes so far? We would really love to hear that, because that's what we really need to develop upon. Don't reinvent the wheel. Whatever has worked, we should be developing upon. So, number one, what the role of private sector organization in implementation of the plans of the government, including CIP, and the success story that we can build on.
Thank you, Dr. Ab. Thank you so much for this opportunity. And if you go to the next slide, I'll be speaking while going through the slides. So I think you have already mentioned that a big chunk of the services and consultations are being provided by the private sector. For example, in terms of family planning, 53.7% modern contraceptives are being provided through private sector, as PDHS tells us, but these are mostly short-acting methods. While in health sector, more than 70% of the services are being provided by the private sector, and we know that most of it is out of pocket. Now I come to your question. I mean, if we look at Sindh particularly, we have some success models in terms of policies. There is a public-private partnership policy at the government of Sindh level. There is a public-private partnership unit at the finance department, which looks after the public-private partnership policy. And then there are public-private nodes, PPP nodes, in different departments. For example, in Department of Health, it's successfully working. In Education Department, there is a PPP node. And in some other departments, you would find the PPP node. So there is a chain of this institutional mechanisms for public-private partnership. And there is a public-private partnership policy board, which is chaired by the Chief Minister. So every PPP agreement or PPP initiative is being discussed over there. When we look to the CIP, I'll be coming to the PPHI, but CIP is one of the policy.
That is a success story.
That is a very strong success story. Costed implementation plan on FP 2020 international commitments. And the design of the CIP was such that from day one, we included private sector into the deliberations. So the consultative process was very comprehensive, and all the development partners and not-for-profit private sector was part of the deliberations, and around 100 different workshops, seminars, and consultative meetings were held. So number one, it was a broad-based, consultative-based process. Therefore, the ownership and the confidence of the private sector was built. Number two, we developed appropriate institutional mechanisms, because for a policy, without institutional mechanisms, without its implementability, or if a policy is not implementable, it's basically useless to have a policy. Therefore, the institutional mechanisms were very, very strongly built in. For example, one institutional mechanism is FP 2030 working group. It was FP 2020 and now FP 2030 working group, and chaired by, from highest level, I mean, Minister for Health and Population, and she chairs the group. Yes. Therefore, the importance of this institutional mechanism is over there. Price tag for every policy is there. So the funding is through the government of Sindh and also the partners. But through these institutional mechanisms and working group, every quarter there is a strict accountability meeting which takes place, and each and every decision is being discussed, and the next steps are being decided. So some of the important reforms that were undertaken, for example, first of all, integration of health and population. Both the departments now work under one minister. Commodities, not only for the public sector, but for the private sector as well. So not-for-profit NGOs as well as some selected private sector entities are getting commodities free of charge. Task sharing, task shifting, which provided mid-level care providers a wider role in provision of family planning, introduction of Siana braces and other very important kind of reform, and engaging the professional organizations under public-private partnership pillars model that we developed through UNFPA support. So I think this is something which was developed and designed for implementation.
Right.
And you can see the
Could
impact.
you also comment on the political will being there? And
Yes,
impact
of
thereof?
course. Yes, of course. I've been minister being chair of the FP working group. Every quarter she sits with the entire 100+ participants of the meeting. So that political will has really done wonders. I think this sustainability of political will is also important, that how we should continue the sustainability of the political will. But this is the impact you are seeing in the slide, that we started from a CPR of 30%, around 30%, and recently the PMA, Performance Monitoring for Action, which is a Johns Hopkins University model that has conducted a study it's a primary study, and it tells us that since CPR has gone up to 41.4%.
Wow, that's really commendable, guys.
So, so this is the impact, but definitely impact has some other connotations. And if we go to the PPHI, I mean, PPHI is very, very important arm in Sindh government, or in Sindh in a broader sense, that most of the primary care facilities are being managed through the PPHI, which is Public-Private Partnership Board. And if we look at their services and their accessibility and the utilization of the services, it has gone up dramatically. And how it has gone up, I mean, one of the element which we have a short time here to discuss it, but briefly, I would say that they have autonomy, financial autonomy.
Decision making is with them.
Decision making is with them. Financial autonomy is there. So they can hire, they can fire, they can create their assets, they can create new services and develop their capacities at their own. Therefore, they have been able to perform. If you go to the another social marketing model, you can see that social marketing is something which has done very great job during 90s. When Pakistan's CPR was 12 and it came up to 28% in a decade's time due to social marketing, social franchising, and lady health workers program. So I think that is, you can see here in this slide, one of the champion of social marketing is Green Star itself, that you are heading, and you have a network of around 20,000 private sector providers across the country, and they are providing short-term and some long-acting methods. And this is the impact, whereby you have been able to generate more than 1.3 million CYPs just in 1 year. So I think this can go up with rejuvenating the social marketing across the country. So I think why I said before that how to sustain the CPR. You can't sustain CPR without uh, integrating that family planning with other sectors. That's one part. I mean, there's a lot of international evidence available that the economic development and fertility go hand in hand. So it's not important that you provide services and you become complacent, that there will be a sustained CPR, there will be sustained family planning uptake for a decade's time. It's not possible without linking that with the other sectors like education, like social welfare, like youth engagement. And the countries where we have seen the family planning has gone up, they have basically intervened into other sectors like education. If you go to the next slide, you will see here is the comparison from the World Bank data of few of the countries in South Asia and the region, which are Muslim as well as non-Muslim countries. I have seen through this data, you will see that the orange bar is female literacy. I mean, wherever female literacy is high, you will see the CPR is high. In Pakistan, female literacy is low, you will see CPR is also low. Female labor force participation is another indicator. You will see that in all countries, it's fairly up and increased as compared to Pakistan. Likely, you will see the headcount poverty rate. So these 2-3 elements are very, very important. So in Sindh, we have tried our best to link other sectors with the family planning. And this slide you are looking at is an initial work that we are doing. Mahtab Kareem, Professor Mahtab, myself, on Population and Development Index, PDI index that we have initially generated, and now we are trying to, this is just initial work, so we'll share with you in more detail. But it shows that around 8 different indicators in education and health and women empowerment and in other areas, the all indicators, when a weightage is given, these indicators have favorable impact on family planning.
Wow.
So this is what I wanted to say. Thank you.
Thank you, Dr. Abhay. A very big round of applause. I think very beautifully, multi-sectoral environment, political will, and there is nothing, no such, and there's nothing like a true story, an exercise that has been done, it has given certain results, and I think there's a great foundation to build on. Thank you, Dr. Talib. Miran, we'll come to you. You have a very vast experience of working with the private sector as well as the government. Murph, as we know, has worked with the government of Sindh, as well as KPK, for in public-private partnerships. Murph is also, as we understand, a key implementing partner of the government's project in KPK, managing Category D hospitals in difficult-to-reach areas like Pata. And in fact, Murph also has on record, to its credit, the experience of working with the primary, secondary, as well as tertiary care. So I think we can learn a lot from your experiences as MSG comes in and tries to bring some new perspective. What is your experience with PPP initiatives at the primary, secondary, tertiary level?
Thank you, Dr. Rab. This topic is quite close to my heart.
Yeah.
And this is one of the main activity that Merck do across Pakistan. So we have our PPPs programs at primary healthcare level, secondary and tertiary care level, both in Sindh and Khyber Pakhtunkhwa. In terms of our experience, I think this is one of the areas, Dr. Shahzad said that it brings you the results very quickly. It brings the result very quickly. It improves your coverage, and it's cost effective. I will give you the example of KP. They designed their PPP initiative for hospitals, secondary care hospitals in area which are far remote. That's almost if most of you must know about newly merged district, previously called FATA. So these hospitals are mainly on the border districts of Afghanistan.
Very challenging.
Very challenging environment, highly insecure. But with this initiatives, we actually started those hospitals very quickly. Within 3 months period, these hospitals started secondary care services as their MSPP. So they started actually specialized services. And some of the district, Hassam is here, he works with us. Um, some of the districts, actually, that was the first time in almost 73, 74 years that they start getting secondary care specialized services at their doorstep. So in a very limited period of time, we have around 7 hospitals that includes category D, category C, and category A hospitals. And in no time, we actually provided more than 300 skilled staff that include 50 plus specialists, more than 100 medical officer doctors, and more than 200 paramedical that include nursing staff. Um, their services improved considerably in terms of service utilization, in terms of quality of service. So the trust that the community start trusting those hospitals. I think that was in 2022 that the KP Health Department, they did an independent survey, and that show a gross change in improvement. And based on that, they decided to actually expand this project scale up to 15 more districts and 59 more hospitals. So that was the success.
Can I, very quickly, I just try to, because it is so, we are talking about public-private partnership, romantic relationship. But I mean, it comes with its challenges and the ways to circumvent. If you can quickly touch upon those as well.
Before going to the challenges, just let me give you another success story of the Sindh one. I give special credit to the Sindh government. And we have the hospital, DHQ hospital, Beta with us. We got that hospital in 2016. And at that time, their capacity was around 50, 60 bed for inpatient. And they were just doing OPDs. And last month, that hospital has been declared as a teaching hospital. And it is now become like a 500 bed hospital.
Wow.
And
Amazing.
it has been happened within the same budget, allocated budget. Government did not.
You must tell me how you did that.
Regarding the challenges, obviously with any initiative, with any new initiatives, there are challenges. And to summarize those challenges, I will make it into like what we face challenges at the governance level, at the I would say the financial model level and the monitoring level. Especially, I would give the examples of KP in governance. Like if you want to do a PPP, do it properly. So otherwise, don't do it.
Yeah.
If like for the PPPs, you have a clear authority, a clear body that actually manage the PPPs. In KP, what we have seen and that's what we are struggling, there are almost 10, 12 bodies that actually manage, oversight, monitor the PPP. So then you can imagine how many problems that as a private entity we will face. Secondly, for financial model, I always say that if you want to run the PPP model with the existing government financial process, then forget about it. So it's not going to work. Don't waste your time. So for PPP, you have to come out with a new financial model that is more efficient, more transparent, and more simple. And that's what Sindh did. So Sindh like moved drastically forward. They were doing in 2015, 16, and now to 2024. While KP government is still stuck. So there are 32 steps in a financial disbursement process in KP. Now imagine 32 steps. So that's, and lastly, regarding the monitoring, that's what I said. It's very important for the PPPs that it should be a performance-based model. And for the performance-based model, you should have a very clear key performance indicator from the start of the project.
the private entity should know for what purpose they have been brought and how will they be monitored. And for monitoring, I think again, that's very important that in monitoring, we should also bring the private party. So if it's not a third party, I think it will always be a dispute. So private entity will say one thing, the public entity will say other thing. It's very important that the third P, we always say that that's for the third party. So
Thank you.
That's
Thank you for a very candid account, very candid account. And I think we can criticize and whatever the thing is work, we should be able to very clearly outline what hasn't worked. That is more important. Dr. Shazad, I'll come to you. Could you please tell us how we can make academia, developmental partners, and the governments and the NGOs, these four pillars, work together to find solutions, as we heard in the previous week,
I think
with ground-related
that is very much needed, because like Shamiran mentioned, if there are two parties, one is government and one is private sector. So the private sector is not comfortable. The good private sector of Pakistan is not comfortable working with the government. And you can see whenever we announce outsourcing or third party contracting out services and public-private partnership tenders, there are very few companies who apply. So those private hospitals, the private organizations who are well established, they will never work with the government. So you have to listen to what Shamiran said, change your financial model, change your contract management. You have to come up with a very easy solution, one window operation, not these 32 windows in which you have to put something in to get your check forwarded. So you are doing a service, you are doing some good thing for the government, and still you are passing through such, hassle and other things. So this is one area. So the contract, development of contract is a skill which is not owned by the government officials. The government of Pakistan officials, bureaucrats, they cannot write a contract for public-private partnership. ये कल वकार भट्टी बैठा हुआ है, ये खबर लगाएगा मेरे नाम से कि ये
Right. So can I add to your problems? Do you see any gaps in the policies in our current systems, and how you've heard the challenges?
So it is a policy level question. You have to develop a sort of a department, specialized department, a technical arm like they did in the SIN, public-private partnership, group or something. Yeah. Punjab doesn't have it. KP, they have a health foundation. They have a KP Health Foundation, and there are so many. IMU is doing something else. IMU is also checking them. So there are more inspectors than facilitators. So the first thing at the policy level, academia and all can be a partner in that for development of proper contracts which is acceptable to the private sector. Then contract management is another thing. So you write the contract, you sign the contract, but the moment the bureaucrat and the officer leaves the office to some other office, the new one will immediately come and change everything. This should not be done. So why Sindh was successful? Because the same health minister is there for last maybe more than 10 years. Maybe 15 years she's there. That is what the continuity is going on. In Punjab and KP, Balochistan, it is not happening, and the federal level as well. So yes, contract development of contract, writing the contract, writing the proposal, and of course contract management. And there is another thing which is very, you should understand that in Pakistan, there is very little pure private sector. Very little pure private sector. आपने नंबर तो दिखा दिया, मैं उर्दू में बोलूंगा. कुछ सच्ची बातें उर्दू में करनी चाहिए, गोरे को समझना है. तो वो पाकिस्तान का जो प्राइवेट सेक्टर है ना, ये सुबह का गवर्नमेंट सेक्टर है, शाम को प्राइवेट सेक्टर में कन्वर्ट हो जाता है. तो द गवर्नमेंट सेक्टर ऑफ द मॉर्निंग बिकम्स प्राइवेट सेक्टर इन द इवनिंग. आप शिफा चले जाएं, किसी भी सरकारी प्राइवेट हॉस्पिटल में चले जाएं, शाम को सरकारी प्रोफेसर ही बैठा होता है शाम को. So all the majority of the government officers, government doctors, they become private providers in the evening. So that is the biggest conflict of interest in public-private partnership. They never will allow the government sector to develop because their practices in the evening will suffer. अभी आपने सुना है कि प्राइवेट सेक्टर की किसी की सीटी स्कैन मशीन खराब हुई हो, या लैब सिस्टम खराब हो गया हो, या MRI खराब हो गया हो, अस्पताल की सरकार की तो कभी ठीक ही नहीं होती. तो ये
Thank you very much. Now, my last question to Dr. Saleh, you talked about the multi-sectorality. Doctor, do you feel that for success of public-private partnership, because you spoke with the window of PWD, your greatest experience of working in family planning, do we need to engage determinants outside PWD? Is that relevant?
Yes, I think it's more relevant if we talk about the family planning. Uh, Without engaging uh, determinants out of the family planning, we won't be able to achieve sustainable family planning uptake. So CPR will increase for 10 years or so. It will go down again to the same level. And we have seen over the period Pakistan CPR. So I think very recently we have developed a working paper, uh, and we are going to have it in the uh, highest level of meeting in the sense that what role education department can play. So education department's role is very, very critical. Likewise, women development department that has a role to play, and
All stakeholders have to be on the table.
have to be on the table. Health is number one, but definitely women development department and the youth affairs department, education department, they all have to be on the board. And especially we have to delineate, or we have to devise what activities or interventions that education department will be doing in support of population dynamics. So our approach should be population dynamics approach rather than just family planning or contraception. So engaging broader stakeholders will have a lasting impact, and sustainability and resilience. Otherwise, we will be losing the continuing users in the system. We add on the new users and we forget about the continuing users. So this is one of the dilemma, and this dilemma can only be addressed when there are other factors which can have a lasting impact on fertility.
Thank you.
Decline.
Thank you very much. Big round of applause. Miran, can I come to you? If you were asked to redesign the PPP model contracting out, say category B hospital, what will you add to the model to make it more resilient and a win-win for both the parties, the health department and the implementing agency?
Well, what I said, actually, I will not add, rather subtract some of the things in the existing model.
Okay.
Like, as I said, like the governance model, it should be as what Dr. Shehzad and Lashari Saab said, that it should be a one window approach. So there should be a single body that actually manage the PPP contract. So it should not be a multiple body. I think that will be a win-win situation for health department as well as for the private part. So if you want to do the oversight on that, so there should be in all the provinces on the either PPP unit or health foundation, they have the board. So I think the other provinces should learn from Sindh. What they did, they have a single unit. On the top of that, they have the board, which is they call it a PPP policy board. And actually, they give representation to all the relevant departments into that board, and CM is chairing that. Yeah. So that's the way forward for any policy decision making. The PPP unit in health just need to go to the board. They do not need to go to the cabinet, to the other departments now and all these things. So
Thank
first,
you. Thank you, Miran.
one this.
Yeah.
Secondly, I think what Dr. Shehzad said, contract designing is extremely important. So it should be very clear from
Right from the word go.
Yeah,
Who's to do what?
exactly.
Thank you very much. Very right. Yes, Shadad.
The service delivery, it's not the sole purpose of the government. Globally, if you see the service delivery component of the health system, they are never done by the government itself. ये जो कहते हैं ना कि हर घर की तहलीस तक हम सेहत की सहूलतें खुद पहुंचाएंगे, ये कभी नहीं पहुंच सकती. हम पहुंचाएंगे लेकिन through partners, then it can happen. So the government, the problem of the government of Pakistan is in health. They want to do everything by themselves, and that is making more problems as compared to solutions. First, they have to understand that and keeping themselves busy in service delivery is actually keeping them away from their core function. which is policy making, which is, development of laws, development of standards, guidelines, quality control, assurance, disaster management. They're not doing anything except service delivery. So if they outsource this to the private sector, the core function of the government, which is governance and what Mehran mentioned, they will be doing that.
Excellent way to put it. The last comment.
Yeah, I think one thing we forgot, I fully agree with Shahzad and Miran. The important, another point is healthcare commissions. We have healthcare commissions in all the 4 provinces. And so we need to work with these commissions to bring on board the private sector so that the private sector becomes more and more ownership of that
And
private sector
incentivize.
and incentivize. And they will build their confidence that they are not being policed or it's no policing, but they are being supported and incentivized.
Right.
So this is one thing to do. And we have another CEWG, Country Engagement Working Group,
Which is doing this job.
which is doing this by coordinating with all the provinces. We forgot to mention CEWG, which is a country level mechanism.
It
And
is such a wonderful, our participants, our panelists, it is so, when you give a real life example of what has really worked, you get carried away with that. But I think you have brought a lot of wisdom. If there are any burning questions, 1 and 2 questions. Yes, 2 questions. You have been such a wonderful audience in the post-lunch session. You should all be given a medal. Give yourself a very big round of applause. 1 from there, and who's next? Yes. Yes, sir.
My name is Waqar Bhatti and I'm a health journalist. सर उर्दू में सवाल करना चाहूँगा शहजाद साहब से भी और बाकी पैनलिस्ट से
जी
पब्लिक प्राइवेट पार्टनरशिप पे बात हो रही है प्राइवेट सेक्टर तो हमें नजर आता है बहुत ईगर नजर आता है फॉर द पार्टनरशिप बिकॉज इसमें उनको प्रॉफिट भी नजर आता है एक्सपेंशन भी नजर आती है मसला तो हमारे पब्लिक सेक्टर का है जो कि सबसे बड़ी हर्डल है पार्टनरशिप की हमें यहाँ पे फेडरल गवर्नमेंट में भी नजर आता है प्रोविंसेस में भी और ये इतना ताकतवर पब्लिक सेक्टर है कि ये मिनिस्टर्स और सेक्रेटरीज चेंज करवा देता है लेकिन ये पार्टनरशिप नहीं होने देता इस सूरत हाल में क्या हल है हमारे पास थैंक
Okay, you would like Dr. Saab to answer, Dr. Shahzad? Okay, one more question we take and then we.
It's a power game. जब आप when you relinquish your charge for hiring, purchasing, transfer, posting, everything, you are actually cutting your hands, both hands. So the public sector की जो पावर है वो यही तो है कि भर्ती करने हैं बंदे, ट्रांसफर करने हैं, प्रमोशन करनी है, दवाइयाँ परचेज करनी है, एम्बुलेंसें परचेज करनी है, हेलीकॉप्टर परचेज करना है, एयर एम्बुलेंस, तो ये सारी की सारी चीजें हमारी प्रोक्योरमेंट खत्म हो जाएगी अगर प्राइवेट सेक्टर को हम दे देंगे। तो एक तो ये पावर गेम है, नंबर 1। नंबर 2, इसमें बहुत सारा दे कैन ऑब्लाइज अ लॉट ऑफ पीपल। दूसरा है इंसेंटिव्स का। When it goes to private sector, it becomes transparent. No one can use without, merit. Public sector में तो वो they are the owner of the public sector. They can use and they can ask anyone to use the services in a very VIP manner. In private sector, there will not be that VIP culture. तो ये 2 रीजन है जिसकी वजह से पब्लिक सेक्टर डिपेंड करता है। लेकिन आपने सुना ये भी गवर्नमेंट सेक्टर है, मैं भी गवर्नमेंट सेक्टर में, शामिरान भी गवर्नमेंट के साथ काम कर रहे हैं। पिछले 10 सालों में बहुत चेंज हुआ है। नाउ आई कैन टेल यू फ्रॉम द फेडरल गवर्नमेंट पर्सपेक्टिव, द करंट सुबह जो आए थे भरत साहब, ये हमारे साथ होते हैं रोजाना, सुबह हमारी मीटिंग होती है 10 बजे। हमारी रेगुलरली एवरी मीटिंग में प्राइम मिनिस्टर शहबाज शरीफ जो कि हेल्थ के इंचार्ज हैं फेडरल लेवल पे, और जो भरत साहब हैं, every meeting they are talking about contracting out, outsourcing and public private partnership.
Wow.
So अब इस वक्त ये हो गया है, ब्यूरोक्रेसी को भी ऐसा ऐसा कुछ जब ये ऊपर से प्रेशर डालेंगे तो they will start working on these things. In Pakistan there is a trend.
Stepping out of our time and that will be very inappropriate if it is a,
Just
very
one-
quickly.
थोड़ा इसमें ऐड कर लूं, जब हम ये केपी में शुरू कर रहे थे और सिंध में, व्हाट वी सजेस्टेड टू देम कि आप इसको फेजेस में जाए और आप इसको फिर पहले लिमिटेड टाइम उससे आप इसको रोल आउट करें कुछ जगहों पे जहाँ पे आपकी सर्विसेज बिल्कुल नहीं है। केपी का जो न्यूली मर्ज डिस्ट्रिक्ट है उसका ये क्लासिक एग्जांपल है। उन्होंने वहाँ पे इसको पायलट किया, वहाँ पे हमने 3 साल वहाँ पे चलाया, उसको उसके रिजल्ट्स आ गए, कम्युनिटी गॉट सेटिस्फाइड, उनको सर्विस। फिर जब नेक्स्ट गवर्नमेंट निगरान सेटअप में आए, सॉरी टू से, उन्होंने उसको खत्म करने की कोशिश, दे कांट डू इट, क्योंकि वहाँ पे कम्युनिटी होती है कि भाई हमें ये सर्विसेज चाहिए एंड दे कैन प्रोवाइड। 70 साल से नहीं हो रही थी, अब भी शुरू की, आप कहीं और जाके और अस्पतालों में अपनी सर्विसेज दे, लेट देम डू।
Right.
ये आप phase wise में अगर आप
So it should be phased, it should be phased. Last question, because it will be absolutely, very quickly.
Can you hear me? Assalamu alaikum. My name is Puratulan. I'm currently doing master's in biomedical sciences from Ahmedabad. My question is, sir, Dr. Talib actually mentioned in one of his slides that 57.3% of the modern contraceptive devices are from private sector. But that's the reported data. What about, not everyone is getting a contraceptive device from a BHU or from a good, private hospital facility. What about the data of those devices? Like, this is a policy level question. Like, what about the production, assessment of the production lines of those manufacturers whose, like, their data is not reported and their products are not approved, not biocompatible, and they are still selling it to the people. So what about that data? And secondly, we always accept the
Are you talking about the IUCDs or other pharmaceutical?
like any device which is not reported.
Contraceptive devices are not produced locally. They are produced either in India, IUCDs, and condoms are coming from Malaysia and
Yes.
Philippines.
Yeah, the difference is that the local, there are short acting methods which are being produced, mostly being produced in local market in Pakistan. However, condom is imported. It's not being manufactured here. But the long acting methods are imported items, and we have a shortage of those as well, but these are being imported. The data which says that 53% modern contraceptives are being provided through private sector, that data is reported in the PDHS Pakistan Demographic Health Survey. We have this credible survey available. So I think this data shows the issue of data quality is universal.
Maybe one of them.
Is universal issue.
Yeah.
So we need to look at, that's why we are having service data as well, and we are having some shorts and small surveys as well.
Thank you.
But this data as of now, but there are so many queries taking up, and they are doing so many things. So this is something which we need to look into the query.
So thank you. I think, thank you, Dr. Shahzad, Miran, and Dr. Talib Lashari. And ladies and gentlemen, thank you very much for being such a wonderful audience. Thank you.
Time management.
Thank you so much, Dr. Rob, for moderating the session on PPP. It was a wonderful session, a lot of ideas and thoughts to process. Our next panel, very important panel, data integration and multi-sectoral coordination. So this particular session will be moderated by Dr. Mohammed Tariq, Senior Director of MSG Health, as you all know by now. Ms. Tania Adros, former Chief Digital Officer, Government of Pakistan, she will be online. And Dr. Lindsay Shields, Deputy Director, Epidemic Preparedness and Response at TAT, in Washington, D.C. And Ms. Amy Strang, Senior Project Manager, Epidemic Preparedness and Response at TAT, she is here with us. So with that, Dr. Mohammed Tariq, I hand over to you for moderating. Thank you.
Sir, thank you so much. It's a pleasure and honor to be here and talking about data again. Um, I think just to build the context, I think we have been talking about products of different data this morning, public-private partnerships, and so on and so forth. But I'll begin my conversation with determinants of data sciences in Pakistan, vis-a-vis primary healthcare, secondary healthcare, tertiary healthcare, and then the preventive healthcare. And some of the structural issues which are very direct kind of, determinants of quality of data or even acquisition of information from different parts. We are a country of more than 250 million people. We are a country of more than 160 districts, 5 provinces, and 3 regional governments, and the devolution. I mean, most of the places that we see around the world where, if you look at the example of NHS England, you will see that, the best example that they give is from cradle to grave. They actually acquire every kind of data that comes into, health or social protection and so on and so forth, and that is used for all different kinds of purposes. But we definitely have limitations. And just talk about, looking at the structural arrangement. There are 3 main concepts that you look at data sciences when you look a country like Pakistan, where the data is being hosted, who is going to, secure the data, and who is responsible for the change management, right? These are very fundamental functions of any, regional or country perspective where you tend to see how things will be shaping up in terms of acquisition and its fundamental usage. So at the national level, we have National Telecommunication Corporation, which is actually managed by Ministry of Information Technology and Telecommunication. In Punjab, we have a very good structure. They have Punjab Information Technology Board. In Sindh, we don't have any Information Technology Board. In KP, we have a Information Technology Board. At, other, regional levels, we don't have that, connection between services, surveillance, and supply chain, which actually acquire different kind of data and actually process it at a regional level. Then we have very good examples, which Dr. Amir was saying, data center at the national level, which acquire a lot of information. We have many vertical systems operating in Pakistan, but yet we have data, we use it, and I'll talk about, with my worthy panelists. We have NADRA, we have this, we have Safe Sahoolat Program, we have border security, we have NDMA. In the context of infectious diseases that we are talking about, we have FCDO, USAID, who are investing in many assessments in many ways. We have, OPM and FAO, which are doing a lot of, work on different assessment of that multi-sectoral response and acquisition between, when we dissect data between, human and animal and agriculture. It's a lot of, effort that is coming in actually. So I'll just stop here from the perspective that agriculture, environment, human health, and animal health, they have many intersections in terms of how we play with the data and acquire with that actually. I have with me very, distinguished leaders in their own. With me is Lindsay, who is actually outbreak and, pandemic preparedness response manager with PATH. She's online. Hi, Lindsay. Are you there?
Yes, I'm here. I hope you can hear me okay.
We have Tanya. We have Tanya Aziz, who has been in charge of the digital sciences in Pakistan. She has been doing a lot of good work. She's with us as a panelist. And we have Amy from PATH. She is also responsible for outbreak and pandemic preparedness response with PATH Foundation. So with PATH. Yeah. Now, given the fact that IDSR and PHIS2 are the main examples where we tend to see to bring all data integrated on different platforms. And we can give many examples from the world where WHO and many other systems are operating, but I'll restrict my discussion to that actually. But we'll try to see how global and local context actually advise on data integration and multi-sectoral response. So I'll start with my first question from Tanya. Tanya, given the fact that Pakistan has been glorified in terms of its response to COVID, how would you construct the Pakistani response that actually ensured that we have been dealing with COVID pandemic preparedness much different as compared to many other countries? Tanya?
Thank you so much. Assalamu alaikum, everyone, and thank you so much for having me. It's a pleasure to be talking on this incredibly important topic, not just for the health sector, but actually for for the entire country when it comes to any form of service delivery. So Dr. Saab, your question is very specifically targeted to Pakistan's response during the COVID epidemic. And it's actually, I often tell people it's one of those success stories that as a country, we need to be talking about far more often than we do. I think at the very heart of the response was of course, a very, very coordinated administrative effort, but also a very coordinated approach to how various sources of data were being looked at, integrated, and then how the data was being used to, to drive very data-driven decisions, literally on an everyday basis. And I'll take you back to the kinds of problems that most countries were faced with, including Pakistan, when the epidemic first hit. So, at the very first level, there was an importance to understand where the disease was breaking out, which meant that lab data, so as labs, and of course, new labs were being put up at rapid pace. We didn't have enough lab infrastructure to be able to test the number of people that were needed. So as testing was happening, was testing happening against unique citizen ID? And was that testing data coming into a centralized view for the government to be able to see? And again, not just provincially, because viruses don't care about provincial borders. And this is a fantastic case of where provincial and federal absolutely need to be coordinated in their response. So are you able to see where disease is breaking out? Because the response then that the government needs to make, it was based on that. The second type of data was actually hospital data. And then of course the third was, when we got to further in the response to the epidemic, was the vaccine rollout. So what was really important, I think, during that time was to very quickly put a system in place where provinces, and as you mentioned, some provinces were highly enabled and were already capturing some of this, some were not. And we needed to get a central view into not consolidating data in a central place, but being able to look at that data centrally. And there was a body, many of you will remember, that got created, which is called the NCOC, where everybody came together every morning. And every morning, the meeting used to begin with looking at the data from the previous day. And I think it is probably one of the few instances I have seen in the country, at least in the few years where I've been involved, where every single decision was being made looking at real-time data. And I think that the power that ultimately that lay in the way we were doing things like shutdowns. So Pakistan was one of the few countries that actually didn't need to do blunt lockdowns, which, as you know, an economy that is as fragile as ours couldn't afford to do that. So, again, if I have to put all of those in context, I remember in the early days of COVID, we used to talk about the fact that at peak, we may be able to vaccinate 200, 300,000 people a day. Actually, at peak, we vaccinated 2.3 million people, unique individuals. Now, just that is a staggering number. I often tell people that is half the size of Singapore. Singapore's population. We vaccinated that many people in a single day. Now, if you think about the capability to be able to do that, required that you understood where vaccines needed to be, you understood who was eligible to get those vaccines, and then you were actually capturing the data as vaccines were being delivered. It's a fantastic example, again, based on numbers, that when you bring a whole of government response together, where provinces and federal are working together, and you have done a clever job, however it may be, to stitch together some important data sources, that your ability to execute and get that delivery done that is so critically needed across not just something like COVID, but across so many different aspects in health, that we are actually incredibly capable of doing, surpassing even our own expectations. But more on that later, Dr. Saab.
Yeah, thank you. Tanya, thank you so much. Thank you. Tanya, would you like to spend a little time on how this response was created from a multi-sectoral perspective, despite that this was zoonotic, this was something that we were not prepared, the world was not prepared. How that multi-sectoral response, would you throw light on that?
Yeah. So just very quickly, I can, off the top of my head, I can tell you that because there was a central decision made that every province had to take part, there was a very quick assessment done on, what the various capability of data capture was available, who had the tools and who had the systems. There was a central tool identified at the federal level, which was actually already being used for polio. Polio is one of the few national systems that is used, and that system was resurfaced and actually leveraged in some of the provinces where those central systems did not exist. Where data was already being captured, so for example, in Punjab and KP, data was already being captured through the testing centers and through the hospitals. There, it was a case of very simple, connecting via APIs, and there was an architecture that was thought through and put together in place very, very quickly, where nobody was required to give up their data. And I think that is a beauty of designing in today's day and world, that we're not talking about consolidating data in one place. We're actually talking about connecting the right data sources. The other really critical body that was involved was NADRA. Again, citizen ID and citizen data, the sort of unique citizen ID, had to be at the base of testing, of treatment, and of vaccination. So NADRA played a very, very critical role, as of course did several other bodies like the NIH, that had to provide that overall policy making and supervision on what was happening with testing. And again, if you remember those times, things were moving at the pace, that none of us can even at this stage recall or remember. So the NCOC was playing kind of an administrative umbrella role, but within that, I can't even count on two hands the number of provincial and federal bodies that were contributing to making that response happen.
Thank you so much, Tanya. Thank you. I remember the day, 26th of February 2020, and we were actually informed about, and Dr. Amir saying, Tarek, there's a lot of money coming in. Can you do an inventory management for all the personal protection equipment coming to Pakistan? So I think it was a great example between military, between executive, between the provincial governments, and all those institutions which actually come into play to make sure that acquisition of data from the district level is happening, whether it is rapid testing kits, whether it is PCR, or if it is a resource setting in a hospital, in terms of oxygen bed or not. So thank you, Tanya. I'll go to Lindsay and also, Emmy, in terms of how you think this response has been constructed at the global level, where we see that, leveraging the existing platforms and diagnostic tools for rapid diagnostics, understanding, the impact of COVID. Lindsay, how would you, contextualize this from a global perspective?
Yeah, thank you so much. And thank you again for having me at this really wonderful event. I'm sorry that I can't be there with you in person, but really honored to be here virtually. I think you're absolutely right. And to Tanya's point, thinking back on just how fast everything was moving, one of the key takeaways from the COVID-19 pandemic was really ensuring that multi-sectoral coordination was in place so that you were able to actually coordinate across different groups, different disease platforms, different diagnostic tools very quickly. I think one of the greatest success stories globally was having countries, and I think Pakistan is a great example of one, where there was quickly discussion on how to best leverage those existing networks and platforms, and realizing that we are in a position now where we have diagnostic tools that can test for multiple types of pathogens and can be rapidly adjusted to look for new pathogens as we went. I think, many countries started leveraging the Gene Expert network that they had in country for TB to also start testing for COVID. And that rapidly allowed for scale up of that really critical testing capacity so that patients could know very quickly if they were positive and then take action to prevent spreading it from themselves to their family or their community. And I think that really helped us shorten the window of time between you are sick and you don't know what you have to you are sick and you have COVID, and here are the things that you can do to help protect your community, help protect your family. I think one of the downsides of this approach that I think we still have to think through when we think about how we're going to manage and mitigate the next pandemic is how do we ensure that we can leverage those existing platforms, but not at the cost of the diseases that they are meant to be capturing already? How do we make sure that we are not losing the opportunity to identify, test, and treat those other diseases that are going to continue, whether you're in the phase of a pandemic outbreak or not, such as TB, HIV? How do you ensure maternal, pregnant women are still able to access the prenatal care that they need if the facilities are having challenges in managing the influx of COVID-19 patients? And so I think there's definitely a lot of lessons learned in that regard of how we can better prepare ourselves to look at how do we create surge capacity in our health institutions and locations so that we can respond to those COVID-19 outbreaks or any other pandemic while not at the risk of the existing disease diagnostics that are needed.
Thank you so much, Nancy, for those scientific developments. Amy, would you like to add something?
Yes, well, first I just want to say Assalamu alaikum. Very nice to be here with all of you. I don't want to spoil my next panel too much. That's actually the panel that I was selected to be on. I'm, for this one, all intents and purposes, the physical manifestation of Lindsay as she's online. So maybe I'll pause on that question, but I'll field the next one.
All right. Well, okay, let's go from human to animal side. And I know, Tanya, that you are contributing towards, you have a love for agriculture and, animal health. How is your perspective about, the surveillance from the animal and genetic perspective? I know that you have Kisan experience and traceability.
Yeah, Dr. Thank you. Thank you so much for asking that. So just, for the benefit of the audience, in my, I work in the private sector now as a tech entrepreneur, and I'm, I work on an effort called Kisan, and we are currently operating in about 4 districts in central Punjab. And, just very quickly, sort of double clicking on what is more, just tying the example of what we just discussed on COVID in terms of treatment to now animals and livestock. The reality is until you understand the baseline of, the same way we were talking about people, who a person is and their unique ID, it becomes very difficult to track, disease, track their treatment, and really do anything with them from a health standpoint. The same applies to animals, literally exactly in the same manner. Unless you understand a unique ID of an animal, which of course now globally is being done in all kinds of ways. If you go to very advanced markets, there's all kinds of animal tagging, which has gotten very advanced over a period of time. That allows you to track pedigree information, which then allows you to make your supply chains for things like dairy, meat, completely traceable. Just to give some numbers, which are staggering, we are in the top 5 countries globally in terms of number of livestock. Yet, in terms of value creation, we don't even fall in the top 50 countries for the economy. So if you actually look at something that is indigenous to us as a country, and you look at the number of animals we have and the amount of milk we actually produce, despite not following the quality of treatment, et cetera, that we need to, the fact that, the impact on the economy that this could have is absolutely not realized today. So when it comes down to, and, just going back down to what is critical today is the equivalent of the role that NADRA plays for citizens. You need that kind of centralized data collection to be happening for animals as well. And of course, I'm talking about it more specifically for, cows, buffaloes, but this is actually true for all our animals. It's really, we don't need to restrict it to that. I mean, a lot of the work that we are doing currently is focused on livestock, largely because we are in the business of trying to make supply chains traceable for agriculture, both for crop and for animals. But, one of the things that we are needing to do, which technically we shouldn't need to do as a private sector company, is actually go out and create that record, that data record per animal. So when we register an animal, we're air tagging an animal, but of course that's not as high tech as it needs to be, but we're bearing the cost ourselves so that you have a record, a patient record.
only then can you start to understand, has this animal been vaccinated? Is this animal disease free? Can the milk from this animal become export grade, export quality? If you don't have this level of data and this level of tracking at the animal level, there's no way you can talk about building traceable supply chains, which actually, frankly, from a national importance level is something we should really be thinking about very, very strongly right now.
Thank you, Tanya, for your, indigenous experience in Pakistan. I know when we were attending the Sydney Global Health Conference, in Australia, we had those, avian influenza outbreak. We were hearing it from USA and others. And just to set the records, for your information, the Punjab government says, there are 34 million cattle, 325 million poultry, 60 million goats, 28 million sheep, and 352,000 horses, and so many more. You can't count the birds, actually, right? So I think it's an enormous challenge in terms of how we look at it. And I'll go to Lindsay to tell us about her experience of animal surveillance from Uganda. Lindsay.
Yeah, we have had a lot of really interesting projects where we've been able to work directly with ministries of agriculture with the idea of eventually being able to set up systems in these countries so that they can actually integrate better with the human health system as well, especially for zoonotic diseases. And there are several ways that we've done this, either through specific strengthening of the digital tools, setting up and rolling out event-based surveillance that incorporates animal health specific signals, and several others. And actually, I'm going to kick it over to Amy, who is directly involved with the Uganda work that we did, to talk a little bit about the approach that we used for the Uganda animal health surveillance system strengthening. Amy, over to you.
Yeah, absolutely. And please fill in if I miss anything. But at the end of, or I should say, towards the beginning of 2024, PATH finished up implementation of the Infectious Disease Detection and Surveillance Project funded by USAID. We were a key sub-partner, particularly for surveillance. And one of our lead countries was Uganda, where zoonotic spillover is especially prevalent due to the presence of wildlife and other climate factors for the acceleration of zoonoses. So one of the strategies we took was to model some of our animal health surveillance by using the human health sector as a model. And towards the end of the project, I believe it was right at the end in May, we actually received national accreditation, the first of its kind for 2 animal health laboratories in country. So very exciting. And from there, that'll improve the the ability and strength and the quality of data that's being used across the animal health sector and country. Let me know if I missed anything.
No, I think that's great. I think the one thing to add also was moving from paper-based tools, which is extremely common across all of the countries where we work with our animal health sector, to electronic-based reporting, and building that into roadmaps that are achievable for these country programs. It's challenging for an animal health sector that's very comfortable using paper-based tools, that has veterinarians going out to farms with paper tools, to suddenly start reporting electronically. And so making sure that the plan for that transition is in place and that it is a process and not a sudden approach was really, really critical, especially in Uganda, where we looked at moving from an Access database to an Excel database with the idea to eventually moving to a fully online electronic database. And so I think those processes are really critical, and I think are really good examples of how the animal health sector can and is, even in Pakistan, already moving towards improved electronic reporting.
Thank you so
And
much,
Dr. Saab, if I could just build on one thing that Lindsay mentioned, which just struck a thought. What's really important is to understand the people who are capturing the data, understanding their context. And I think in today's day and age, with the advent of AI, there is no reason why we can't be leveraging voice far more heavily, realizing and understanding that in 45-degree heat in the middle of a farm, to expect that a vet is going to fill out cumbersome forms on a phone or a tablet is actually very, very difficult, keeping literacy levels in mind, et cetera, et cetera. Now, this is, however, a problem of the past. In today's day and age, if we can't leverage things like voice AI to really be able to understand, determine how to localize even data capture, because ultimately it's a garbage in, garbage out problem, right? You can build out the best systems and the best databases, but if the people who are entering the data into the system are not monitored and evaluated, and that check and gate is not clear, the output is going to be as compromised as so really ensuring that we're focusing on localized data capture, understanding the context of who the people are is really critical when it comes to language, when it comes to accessibility, connectivity, offline, online. Most of these, we're talking about rural areas, large parts are still not as connected with the level of internet that we require. So a lot, these are all things that actually we are learning as we're doing some of this data capture on the field right now. And some of these systems have to be developed accordingly.
Absolutely. Thank you so much for giving that good people's perspective. Now, coming back to the fact that, I mean, we have like many labs for the human perspective, and we are able to acquire information from both public and private sector. There are about, 8,000 or 9,000 laboratories operating in the two sectors. And we're talking about standardization of data, where we see that, people have the difficulty in terms of how to acquire that information. From the basic principles of data acquisition, linked to this question to you, how you see the standardization in terms of data dictionary from an animal perspective or a zoonotic perspective to be, introduced in Pakistan from the states that we are not that mature in terms of that journey that we have made so far in Pakistan. Lindsay?
Yeah, sure. Happy to jump in here. I think you raised such a critical point of thinking through interoperability and data sharing. And in Pakistan, especially, I have to commend FAO. Maybe they're in the room there today, but they did a surveillance evaluation tool assessment a couple of years ago, back in 2023, that really highlighted some of the key challenges that are facing the animal health sector related to these types of data questions, and highlighted just how important the province is and how much of a role the province will play. And when you think about the complexity of these different data systems, not only do you have different data tools that might be used across the human and animal health sector, but you may even have different variables or different subsets of variables that are used. What is called a town in one system might be called a village in another. And so you have to create that really strong interoperability layer that allows for those two systems to communicate with one another. In a human health data system, you're probably never going to have a species category, but you're always going to have that in your animal health system. And so when you're looking at integrating, you do have to think through how to do this in a way that the data is still going to be useful to you on the back end, and that it makes sense both for the stakeholders that are looking at it from the animal health perspective, as well as those that are looking on the human health perspective. And we've definitely seen challenges here just in getting to, even when you have geographic distributions perhaps, or geographic delineations that are different between the human health sector and the animal health sector. Generally speaking, hopefully a district in the animal health sector is the same name, same location, same size as what you see a district in the human health sector. But depending on the country, that's not always the case, really making for some challenges when you're looking at data integration.
Thank you so much, Lindsay. I think that says a lot in terms of where to begin, but I'll take this question to Tania, knowing the fact that you have been working in Pakistan with a multi-sectoral generation of response for COVID and many other aspects in agriculture and a zoonotic perspective. Tania, how do you see where Pakistan has not defined that data dictionary in terms of standardization, but we do realize that DHIS2 or DHIS or the administrative definition of maybe 16,000 establishments of Pakistan do have a code actually. Where would you like Pakistan to begin from an animal perspective, where we don't get a lot of information from zoonotic data that is being acquired at a veterinary level or those labs which are operating for animal perspective? Tania?
Dr. Saab, my fundamental view on this is actually very similar when it comes to animals and people. I don't think it's conceptually very, very different. The reality is the government and the public sector has to play the role of doing a certain set of things. And in the past, historically, we've used terms like policy making, etc. The reality is in the world that we are all now living in and moving towards, there's a concept called digital public infrastructure. Right? Digital public infrastructure is the building blocks upon which you can do all of this data generation that is happening for the private sector to then be able to build up and offer service delivery and do innovation. You need to ensure that the public sector has built. So like in the physical world, the government is responsible for building roads, and making sure they're connected through highways and providing electricity, etc. That's infrastructure to ensure that the physical economy runs. The economy of data and the digital economy runs on making sure that those building blocks are there. And those come down to ensuring that you have things like unique identity, whether it's for person or for animals. You have the ability for various data sources against that human or animal to be able to connect together through a data exchange layer. And that's these are what are this. There is a global phenomena now, and there are countries that have done an amazing job at building that infrastructure. And today you are seeing that the private sector is now building on top of those building blocks. So I mean, if you were to ask me, my sort of dream for us as a nation is that the public sector understands and starts to play the role that they're supposed to play, and starts to invest heavily in building those building blocks that unfortunately they have to be the ones building. You can't have private sector be going and doing those things, and then build a set of open-minded policies that allow the private sector to help with service delivery. This was a topic that was being discussed in the previous panel as well. This is a very large country with a lot of people and a lot of animals. There is no way without the private sector's involvement that you can actually get to the last mile. And to be able to get to the last mile, but to be able to keep a view centrally, which both provinces and federal need to be able to do the effective policy making, you need those building blocks. So if you, I mean, that is my dream for us, is that we understand the role that each side needs to play, and then play the role and stop coming in each other's way. That's what I would say.
I think that's a dream that will, inshallah, Pakistan will make through. And now looking at, end-to-end data for humans, when we know that, we have applied it in terms of NADRA, and I think what Tanya is alluding to is NADRA for animals, NADRA for zoonotics, where you have a unique number for every animal that you can actually tag, geotag, or whatever those, nonsense could be from a digital perspective. I'll leave that question, I think, knowing the fact that only 10 minutes left, and we would like to have those question answer sessions. My last question to Lindsay is, Lindsay, what are those motivation factors from a multi-sectoral response generation where you see the majority of a country where you do not have enough in terms of zoonotic acquisition of data? What are those motivating factors where you can begin the journey where human acquisition of data is great, but zoonotic has to start from somewhere? I know that you alluded to FAO and other interventions going on in terms of assessment and set tools and instruments, but how would you like Pakistan to begin from? Lindsay?
Yeah, thanks. It's a great question. I think the most important thing is understanding the motivations of the different stakeholders. What is the ultimate vision and goal for the Ministry of Agriculture may be very different than what you see in the Ministry of Health, right? The mandate for the Ministry of Health is all about ensuring human health safety, whereas the Ministry of Agriculture must balance animal health as well as agricultural economics and productivity and ensuring access to safe foods. And so if you try to bring everyone together just under the guise of everyone needs to stay healthy in the human health sector, you're going to miss out on getting that strong, robust buy-in from other sectors that have to also look at other mandates that they have, other really critical roles that they must play. And so I think thinking through how to operationalize this multi-sectoral coordination really requires high-level buy-in from the government ministries themselves, but also open discussion and dialogue about how to balance some of the key things that are needed from both sides. For example, HPAI outbreaks, right? They can be very devastating to a farmer if the standard policy is to cull the entire flock. That has dramatic economic devastation for that individual farmer, and it may actually create incentives for them to hide that disease. And so thinking through how you can set up systems that would capture these zoonotic diseases in a way that is helpful both for the Ministry of Agriculture to mitigate the threat of the economic threat of that particular disease, as well as the animal health threat, but also thinking through how to best safeguard the human health in the country as well. So I would really come back to the engagement of stakeholders and understanding where their motivations are and how to best align.
Thank you so much, Nancy. I think One Health approach and bringing all stakeholders on a table that has not been done in Pakistan, maybe the starting point where government should be leading that effort with the private sector. Thank you.
I think one great example of acquisition of biological material when we get flu shot in our arms, that is a great example as to how biological material is acquired from different parts of the country through CDC or through national influenza centers, and that get to a level where genomic studies happen and we identify what mutation means what in terms of are you going to have a bivalent shot, tetravalent shot, or a pentavalent shot? I think that I leave that thought with you that there's a whole bioscientific development in terms of acquisition of different biological material that constructs the development of vaccine. Now, with this interest that we are actually on a journey where human, lab data or human infectious data, disease data is very much mature relatively in terms of, if not absolute, we are going to start something solid for animal side or environmental climatic perspective. I'm sure you will be having something in your mind to ask questions from Lindsay and Tanya. Please, floor is open. Dr. Razia, sir, I'll come back to you. Dr. Razia, can somebody give mic? Thank you. No, I think they will not hear without a mic actually, Tanya and Lindsay and I mean, good.
I got it. But
Thank you very much. It's Dr. Razi again. So thank you very much for the interesting session, Dr. Tariq and Vijay and everyone. So I'm very pleased that in the morning we were discussing about the data fragmentation, and now we are discussing data integration and the multi-sectoral response. So being a data person, I'm pleased and also I'm worried as well because you know that there are multiple challenges still there for the human data side. Like when we talk about integration and interoperability, so probably there are some challenges where, for example, within the province and linking it to the national level. And then taking the example of using data at the district level. So we are still not having the robust surveillance system. So this is one thing that we have to improve our surveillance system in a way that then we can integrate it properly with the human, with the animal side as well. So I have just a comment or what you call it's not a question, but a suggestion that I think it's a very good approach, but we can, the way forward could be in the form of a pilot somewhere based on need assessment and interest of the stakeholders. So we can have a pilot and then we see that what goes right and what goes wrong. Because obviously the concept is very nice, it is thrilling, but it is challenging as well. So I think we have to start from somewhere. So I think having a pilot at some provincial level and keeping all the stakeholders involved within that, it's a province or it's the national level. And then we have a way forward for analyzing it because as everybody is saying that we have to generate unique IDs. So even unique IDs are not there fully for the human system. So we have to keep this in mind for bringing this to the element. Thank you very much.
Dr. Rathe, thank you so much for your nice comment. Actually, I think it has no argument not to have it, but I'll go to Fayasa. Fayasa, anything? Your question, please.
Thank you. My name is Dr. Fayaz. My question is whether we talk about data from a department or a sector or multi-sectors. But our default approach to data integration is a technical one, where we identify data streams, streamline them, take them, and we assume that decision makers will use it for decision making. But looking at what COIC taught us, I think we should put the decision makers at the center, and then data systems will improve and integrate by themselves. So my question to you will be, which of the two approaches you will take? A technician approach or a decision maker approach, which ultimately will improve data systems and integration?
Dr. Sania, I'll start with this and then Lindsay. Which approach you would like to have? People's approach or technical approach?
So, I think it's a fantastic question. Technology and data is always an enabler. It's never the solution or the end all to anything. In fact, in practically everything we're talking about, what ideally good quality, high quality data should be doing is enabling the decision makers and the people at the center to be able to make better decisions. And then they should be the ones driving the questions around, what other kinds of data are needed to be able to make better decisions. So it has to be right people who understand what needs to be done in the right. And again, this is true for anything, not just for health. When you have the right people, so in the case of COVID or any infectious disease, when you have the right person at the center asking the right questions, the systems need to adapt accordingly to be able to go out and capture data in that manner to then be able to enable the decision makers. And again, this is true of anything, right? Successful businesses will be built with technology and data being the enabler to be able to allow them to, and same is true of public sector delivery.
Thank you so much, Tanya. I think the right people at the right place is a political question itself. So I think you're so right. It has to be. Lindsay, would you like to add something?
Yeah, I think the only thing that I would add is, you have technical decision makers and you have the policy and political decision makers. And oftentimes the data that is generated is not presented in a way that is digestible to someone that may not have that technical background. And so I would just flag that if you are centering on the decision makers, you also need to make sure that there is that translation step between the technical team that maybe understands what the data is saying and the policymaker who really needs it to be shared with them in a way that is interpretable and then actionable. And so I think having both of those aspects in your decision making is really critical.
Well, thank you so much, Lindsay. I would like to, thank you so much, Lindsay and Tanya, for joining, online, and of course, Emmy. Big applause for them. And I'll just end, this panel by saying that, we're not there. Pakistan is not on absolute grounds in terms of having data for animal or zoonotic perspective. But I think it's a good journey that we have started, and multilaterals, bilaterals, the government of Pakistan leading this together, we'll get there someday, inshallah, very soon. Thank you.
Thank you so much.
I see that some of you are still not bored yet, so we will continue. This seems to be exciting. So that's great. That's great news. In the meantime, we lost few people, but we also have some new guests coming in. I would like to welcome our colleagues from USAID, Ms. Judy Chang, and colleague from Economic Section. Welcome. I think few other colleagues have joined us. We really appreciate you coming on afternoon to listen to all this amazing information and discussion. So we have changed a little bit of format. I know multiple panels have been going on. So we would like to invite a keynote speaker just to change the modality, and also an amazing speaker here, Mr. Mohammad Arshad Khaini. He is the Chief Executive Officer of the Federal Sehat Sahulat Program, Prime Minister's Health Program, Ministry of Health, Government of Pakistan. Sir, welcome.
Thank you, Shakil Malik sir. So I think it's almost the last episode of this 2 days long session. You guys must be having. So just the last session, the discussion going on with regard to the data. Data-driven decisions, decision support system, data-driven governance, people-centric governance. We always hear such nice words, but mostly in such kind of event, not on the real ground. We make the decision on whim, on vested interests, on some unknown mysterious priorities, which are not so mysterious and so not so unknown to the general public, honestly speaking. So being head of this National Universal Health Insurance Program, which is popularly known in Pakistan as Prime Minister's Sehat Card Program or the Qaumi Sehat Card Program. This is one of the world's largest National Universal Health Program, covering over 200 million Pakistanis, except the province of Sindh. Over there, we have only one district covered under this program, and we are still in conversation with the Sindh government to join the program. But I understand in a federation, it's a lengthy process. You need to bring in all your federating units gradually and convincingly. But let me tell you, how this miracle happened in this country with all our limitations. Everybody talks about resilience, transforming the health system. Believe me, ask us. It's not easy. Saying transforming is very, very easy. Even transforming so much, cost you so much, you cannot believe. When we had started back in 2015-16 with this small social health protection program with only 2.3 million Pakistanis covered under the below poverty line, most of the stakeholders and vested interest groups thought this will be another program, another health initiative, another development project, which will be going to the shelf in few months, if not few months, in few years. But starting with a small program and gradually expanding it towards the largest state-funded national universal health insurance program. It was a real journey. And we came to know what transformation is. Converting gradually a typical supply-side health system into the demand-side system. It's really not easy. In a fragile economy, with a weaker health system, with multiple fragmentation, it was not really easy. We made such a design where the governmental bureaucracy should not be running the service delivery portion of the program. We came up with a third-party model where independently procured health insurance company should be delivering the services to the people. And government working as a purchaser of the services from the insurance company. But on the ground is the responsibility of this professional insurance company to buy the services from the hospital. And government is working as a monitoring agency as well to see whether the service delivery at the ground root level happening or not. And if so, how effective it is. Tanya and Lindsay were talking about animal data, and I will try to refocus back to the social animals only, which you and me are. So today, every day, we are receiving around 18 to 20,000 admissions real-time data in our system. Every single day. Real-time means if somebody is getting admitted right at 3:45 p.m. in Lorelei, we are getting the real data of the diagnosis, the services, the prescriptions, the diagnostics, and the discharge till he gets discharged and discharged now. It was not possible before. So during this long journey, I would just like to quote one small story that in the previous government of PMIK, there was a tourism minister, overseas minister, Zulfi Bukhari. He approached us and he given the idea why we cannot include the overseas families and their families in the health card. At that point of time, our system was only restricted to the below poverty population. So we were having a conversation with the multiple stakeholders, and in this case, State Bank was one of the key stakeholders getting the remittance all around the world. I was having a session with him in Karachi, and during the coffee break, the governor asked me, Arshad, have you any idea what kind of income inequality is prevailing in Pakistan? I said, yes. During my business school or the governmental standardized reports I do receive, I have some idea, but I would like to hear from horse's mouth. Why you don't tell me? And he said, Arshad, in Pakistan, 99% people earn less than 100,000 rupees a month. And 92% people earn less than 30,000 rupees a month. And another 62% earn less than 10,000 rupees a month. And this is 2-3 years old story. And during this last 2 years, what happened in the inflationary trend, especially not only the CPI, but the cost inflationary trends in health are as 2x or double of the CPI. So whoever was earning 100,000 rupees a month 3 years ago, now the purchasing power remains only 54,000. 46% purchasing power has been erased. So with this kind of income curve, if tomorrow morning somebody needs 200,000 rupees for typical surgical intervention, forget about the cardiac intervention, forget about the lifetime dialysis, forget about the lifetime chemotherapies for oncology care, typical RTI, typical medium-sized appendectomy, normal delivery or a C-section. From where we get the money? Even people like us who are the highest grade in the government hierarchy in terms of the government officers, we don't have such a disposable income where we can put out 200,000 rupees for an emergency. Either we need to use our savings, borrow from a friend or a brother, sell some valuable asset. And if this is the case, the people like us, can you imagine who is getting 30,000 or 10,000 rupees a month? How he will be handling the situation? Selling the home, car, cattle, jewelries, or whatever. Because it's the son of a prime minister or son of a farmer. Both have equal importance for their respective families. They put every damn thing on stake. But still there's a 50% chance that your beloved patient will recover and come back to the family. But whether he or she will come back or not, that particular family will fall below the poverty line for the next 4 generations. So again, this kind of meanness, this kind of situation, this Qawmi Sehat card or universal health insurance emerged as a protection for a common man. Today, at least 200 million Pakistanis can pull out anytime their national ID card from their wallet and can go to 1,000+ hospitals, 70% private, 30% public, for any treatment. For any treatment which requires hospitalization, which is a lifetime chemotherapy, cardiac surgery, angioplasties, neuro issues, lifetime dialysis. One can imagine this kind of luxury in many of the G7 countries is not available. Forget about this. Let me talk about this Manhattan or a black lawyer like Barack Obama won twice election on this Obamacare issue for covering those people who are not being covered otherwise, not having the affordability. In whole of the Eastern Europe, in whole of the Africa, the national health insurance is the prime agenda point for any political party or political leader. And what are the implications? We used to do a blind decision making before, or not that transparent decision making, let me say, to be more specific. If some epidemic happens in the Dera Mukti, in my largest province of the Balochistan, it takes 6 months to come to the news to the capital city of Quetta. Another 6 months to the nice heated and green rooms of the Islamabad. But now, today, as I speak, we have the real-time data, what came at the highest trend in Gujranwala last week or yesterday, what in Loralai, what in Gavadar, what in other provinces, Tharparkar. This luxury was not available. So if I get data today, immediately my public health team can rush to the Dera Mukti, to the Chek Baba, to any particular area, and they can limit the whole epidemic situation. Another implication is like Corona, COVID-19. I was part of the NCOC. It was not easy. It was a very difficult situation. Now we claim very proudly we are the second best performer in the COVID war after the New Zealand. It was not easy. Dr. General Ikram was part of it. But because of the universal health program, God forbid something comes again of similar or twice magnitude tomorrow morning, we can make just one meeting in the Ministry of Health, allocate funds with one email to our insurance company, and in the next 1 hour, the same email go to 1,000+ hospitals, and they can accept the patient for this new issue from next hour. Situation was not available previously. Tomorrow something happens, we can face, we can manage. This. Another implication I would like to share with you, those of you are well aware about the situation like Pata, like Tharparkar, like Gavadar, Turbat. For example, in Pata, we did 2 years ago, third year for the universal health insurance program. Previously, it was below poverty. In area, backward area like Pata, nobody was willing to open a single pan dhaba. But there's no business-like environment there. Something like dish was a routine there. So just because of this universal health insurance program, more than 25% new hospitalization facility emerged. Why? Because we know, we hear always this music, entrepreneurship. We open a new business, whether it's a college, a hospital, or any other business. What do you need? Only two things. One, you target customer in that particular area. And second, purchasing power in his or her pocket. For health, you and me all are target customers. And by virtue of this health card, everybody has a purchasing power. So this is why the entrepreneurs went there and they come up with a new facility. KP, our next door neighbor, previously before this health insurance system, only one Peshawar and half Abbottabad. There were the cardiac interventions were available. Now 14 facilities till the border of the Afghanistan, DI Khan, with the cardiac angioplasty and angiography facilities are available. This miracle can only happen because of the universal health insurance program. Otherwise, who is going to invest there and why? I'm a strong believer. I'm a strong believer that service delivery can only be done through the private sector. Public sector can only supplement. Public sector can only support. Public sector can only be a fallback option. If I can buy this jacket, if I can buy this remote from a private sector, why cannot buy health services, education services? Why cannot provide a universal health, which I'm doing it, we are doing it now, and universal education and some other similar services. Last week, I met a young officer, a government officer. He was pissed off with the Pakistan's current governance situation. And he says, Mr. Arshad, can you tell me why our government always focus on two things? Or what are the two things, gentlemen? He said only one, maintaining the law and order. Whoever is the prime minister, whoever the government, that says, we need to maintain the law and order. And second is revenue collection. You always listen to these two words, buzzwords. In the colonial regime, anywhere in Africa, India, Latin America, we used to hear the same two words. Law and order, management. Previously, we used to call it money extraction for the past masters. Now we say revenue collection, more sophisticated words. And I smiled back and said, so what we should do, gentlemen, would you like to share with me your thoughts? Because what every civilized nation is doing. Okay, would you like to share with me what are these two things? Civilized nations, civilized leadership are. It's only two things. One is service delivery. Service delivery. The other one is nation building. Any nation, the civilized nation, growing nation, they have two responsibilities. Service delivery to the citizens and nation building. Nothing third item is required on the agenda, believe me. This menu is good enough if you want to build your nation. I was talking to one of my colleague secretary this afternoon on the same issue. And he was a both background, a civilian and a Fauji bhai, like Amir bhai. So he said, yes, Arshad, why do you think we don't believe in service delivery? It only matters to whom. Being a government servant or being a political leadership representative as a part of the government, our responsibility is to deliver the service to the common man. That's the only responsibility. I strongly believe as Pakistani nation, if we can make this miracle happen, it's not perfect, believe me. I always tell my friends, my people, my team, but we are perfectly imperfect. It's just the beginning of the journey. We are taking baby steps, moving forward. And this gives us a confidence as a nation. If we can make things happen in one walk of life, why cannot another walk of life? We will do. We will transform the system. But it's not easy unless we work as a team. Thank you.
Thank you so much, Dr. Kankani. This is wonderful. Nation building. We started, interestingly, you missed the morning session, but we were talking about UNGA last week. And a couple of us were there at UN. And exactly the governance discussion came up. Every single nation and the political leadership, every single prime minister, president, they were talking about governance change. And governance change of the system from the top to bottom. And only thing we need is young people to get involved, make them confident, and really make it work for them. It's not complicated, actually. We make it more complicated than it is in reality. So really appreciate your comments and your keynote. Thank you so much. One more round of applause. So I know you all are almost tired to go home or make other plans, but we are here for the last session, and there is a last panel, which is going to be a very important panel for us. I'm inviting Dr. Furqan Irfan to come and join us as a moderator. And Amy Stan, please come join.
Thank you, Bye.
We also have Dr. Julfikar Gupta, Robert Harding Chair in Global Child Health and Policy at Center for Global Child Health Hospital of Sick Children, and he's online. Dr. Erin Sorrell, she is also most probably joining us. As you all know, it's very early morning. She was with us in the night, and now she's waking up at 6:30 in the morning in Washington. She's a senior scholar, Center for Health Security, Associate Professor of Johns Hopkins University, Global School of Public Health. Dr. Abdul Rahman, Associate Professor of University of Veterinary and Animal Sciences, U.S. Fulbright Fellow at the University of California, Davis, and Ms. Amy Strang, Senior Project Manager, Epidemic Preparedness and Response of CAP. Welcome, and Dr. Furqan.
Thank you. I have a PowerPoint and a short talk. Hi, good afternoon, good evening, everyone. I have the honor of moderating the last panel. Thank you, Shakil Bhai and Adina. I'll be talking about climate-sensitive diseases and emerging technologies for One Health approach. Climate and how it affects across countries worldwide, globally, is of immense importance with the Pakistan floods happening recently, and still Pakistan is dealing with the aftermath of those floods. And so it's not just particular to Pakistan, and it's not something that I'd be talking about on a north-south kind of lessons learned. I'll be focusing more on some lessons that are learned from a south-south perspective. At Michigan State, where I wear my other hat, I've had the pleasure of being part of this climate and health group that works extensively across Africa, Latin America, and Asia. We've got research projects running over 3 continents, in Brazil, Peru, South Africa, Botswana, and Africa, and then in Laos, Vietnam, and Thailand across Far East Asia. So I'll be briefly going through some of my projects on climate and emerging technologies. So briefly, arboviral diseases, including dengue, chikungunya, and Zika virus transmitted by Aedes mosquito, are a growing endemic. Dengue is an epidemic in many countries. And among these vector-transmitted diseases, dengue fever is the world's fastest growing disease. Pakistan is greatly inflicted by dengue. Now chikungunya and Zika is on its way. There has been Zika that has already been sequenced, I think, by Aga Khan University, and Dr. Ahmad is here, maybe by Indus as well. So this trend will keep on increasing. We've seen Horukushe recently rising from Latin America. And so this trend of arboviral diseases and other emerging and re-emerging diseases making their way from Africa and Latin America to Asia, and from Asia, vice versa, to the rest of the world is a trend that's going to continue to increase. And so we saw that during the Pakistan floods, dengue cases were at a total cumulative number of nearly 26,000 and 62 deaths. And now chikungunya is reported to be endemic in some parts of the country. The NIH recently issued an advisory for prevention and control of chikungunya. And we still have to see how Zika does in Pakistan. Recently, there was a huge call for proposals by the Wellcome Trust on Zika and how immunology interacts with Zika, particularly for proposals outside of Latin America. So they were very specific. And the expectation is that we understand a lot about Zika in Latin America and Brazil, where it first gained importance, but we know very little about Zika in Africa and Asia. And so that is the expectation. Zika will emerge as a disease of as an infectious disease of importance in Africa and Asia. And there are several efforts underway to understand those mechanisms. Briefly, how climate and environment impact arboviral diseases are some of the following. Deforestation in itself leads to a change in mosquito species, making Aedes mosquito, which replaces the natural mosquito species in the wild. As deforestation and urbanization happens, Aedes likes to live in an urban mosquito. And so this change and transition of species happens as a result of deforestation. Climate change, rising temperatures in itself provide favorable conditions for mosquitoes to breed and multiply. Human mobility, migratory bird patterns, land use and land cover, changes in vector ecology, all of these combined lead to rise in mosquito-transmitted diseases. Briefly, this is the average monthly temperature and precipitation in Pakistan. As you can see, the spikes happen in the month of July and August, and that gives a very nice proportional effect of the highest cases of dengue in September with this lag effect of a month. I'll quickly wrap up. Briefly, there are 2 projects that I'm going to be talking about. One of these is environmental justice and public health, climate, land, and health outcome of dengue fever in Peru. This was a $1.5 million award that was awarded to us last year by NASA. We're trying to address 4 hypotheses by this project. What are the spatiotemporal changes of dengue outbreaks in Peru, and how have these outbreaks been more severe in marginalized communities compared to others? How have dengue fever outbreaks been impacted by this joint impact of climate, land, and human activities, which lead to environmental injustice? And then how do marginalized communities have to bear the brunt of this, this combination of events leading to increased dengue fever outbreaks? And then can we predict dengue fever outbreaks using machine learning modeling by using data from various sources? You would have seen that when a dengue outbreak really happens, what is seen is that in the news, there are like rush of people presenting to the emergency department with dengue. The hospitals announce specialized dengue wards. There are people dying of dengue, and that's how you get to learn, okay, there's a dengue outbreak again. What we are trying to propose is to create an early warning system in Brazil using data sources from various data sources, including NASA satellite imaging data, remote sensing data, patient data, dengue patient data. We are mapping the patients who get admitted due to dengue fever, and we are geolocalizing their neighborhoods and where they reside, and then using land system, land use, and publicly available weather and climatic data, and then feeding all of this in a machine learning model to predict that a dengue outbreak is going to happen in a month, so that the public health officials can then use to spray, people can take preventive measures themselves, and so on and so forth. Following this is this Gates Foundation Global Grand Challenges Award in Brazil that we got this year, 2 months ago. Again, we are using modeling data to create an early warning system for arboviral diseases outbreak in Brazil. And this was particularly hard to get, not only because it's Gates Global Challenges Award, but because we're implementing it in Brazil, which has been the epicenter of such modeling efforts globally. There are a number of databases that we are using for remote sensing and climate data. We're using entomological and vector data, and then you're using their notifiable disease information system, SINAN, which gives us the public health data for mandatory reporting of these 3 diseases. I will conclude here, and thank you. I'm happy to take any questions. Sure.
The environmental justice in Peru. So what were the outcomes, main outcomes of that project?
That's a great question. Unfortunately, we just started collecting data. So we are, it's a project in progress. We are at this point in time collecting data of dengue patients that are being admitted in 4 regions in Peru, Lima, the Iquitos region, and 2 others. And we're doing it in a mix of like urban, rural, and Amazonian jungle areas. So we hope to be able to collect historical patient data. The climate and the weather data is publicly available. The mosquito vector data is publicly available. It is the patient data that is hardest to get, so that is the stage where we are at. We hope to get through the retrospective patient data first, and then prospectively we are creating a data collection mechanism. So I should be able to report the outcomes in 1 or 2 years' time. Sure.
Tell me, what are variables? What are the variables you are thinking that you will consider for measuring the environmental justice in this project?
So one of the things that we really want to explore are the indigenous communities that are living in the Amazon rainforest. but also the fishermen communities living not in the rainforest, but along the waterways, urban, rural types of waterways communities. And we want to see what has been the burden of dengue outbreaks in these communities relative to the urban communities, and how has been the spatio-temporal effect of dengue's impact and spread in urban versus indigenous Amazonian versus the waterway communities. And so that's how we hope to answer the incidents. And what we are also seeing is some very interesting kind of natural defense mechanisms in that we can't confirm yet, but we have seen evidence of the indigenous people having some natural immunity to dengue that is not seen in the urban population. So there is some evidence of evolutionary mechanisms of defense, and we are hoping to involve our translation research colleagues to explore more.
Thank you very much. Your both projects are very amazing. Thank you very much.
Thank you. Any other questions before I pass on to my colleague? All right, fantastic. I would like to invite my colleague, Dr. Abdul Rahman, to give a talk on his work. Dr. Abdul Rahman.
Assalamu alaikum to everyone and good evening. So you have been listening a lot about One Health, infectious diseases, emerging pathogens, zoonotic infection. So I'm talking a little bit on a different topic, that is aflatoxins, which is an important One Health challenge, and this is related to food safety and food security. So what are basically aflatoxins? Aflatoxins are chemical substances that are produced by a fungi, and those toxins basically affects human health, animal health, plant health. If we see, particularly during this era of climate change, with the climate change, there is an increased temperature, there is increased humidity, particularly during a concentrated period of time. And with the increased temperature and humidity, the fungal growth increases. With the increase in fungal growth, the toxin increases and the food gets contaminated. And that food basically affects human health, animal health. Particularly, it causes liver cancer, poor growth, and immune suppression. And there are many other problems that these toxins cause. If we see the National Nutritional Survey of Pakistan, it reported around 40% of the children population in Pakistan is growth impaired, particularly more than 40% of the children, they are stunted, around 18% are wasted, around 30% are underweight. So there is the huge issue of poor growth in children in Pakistan. And if we see the map of Pakistan, we can clearly see that except Punjab, AJK, and Federal Territory, in all the other provinces and regions of Pakistan, the prevalence of stunting is more than 40%. And in Punjab and other AJK and Capital Territory, it is around 35%. So as I mentioned that a fungus produces toxin, that toxin basically gets into the feed, and then feed goes to animals and the food goes to human. So human, when the toxin goes to the to humans, either through food directly or through feed, so that toxin basically causes different problems like liver cancer, immune suppression. People are doing vaccination, but the vaccines are getting failed and they are not producing appropriate titer, and that could be one of the reasons. We reviewed the literature and we published one study where we comprehensively reviewed all the published literature on aflatoxin in Pakistan. And we found that almost all the food items and feed items in Pakistan, from those people have reported the presence of aflatoxins in Pakistan. And one particular study I would like to mention was conducted by NARC, where they have detected aflatoxin contamination in milk. It was a big study where they collected milk samples from all the provinces and two regions, and there was a high prevalence of aflatoxin in almost all the regions, particularly in milk samples that were collected from peri-urban farms. So when we saw that there is a high prevalence of poor growth in children, and also there is a high percentage of aflatoxins in food and feed items, then we hypothesized that why not to investigate this, whether it is associated, this poor growth is associated with aflatoxin presence in food items in Pakistan. So for one of my PhD students, we conducted this study. We tested 238 children from Lahore, and we found that around 65% of the children were positive for urinary aflatoxin M1, and 100% child population, that was the study population, was aflatoxin B1 positive. We also observed that the prevalence was higher in hot and humid months compared to the winter months, and also the prevalence was higher in urban areas compared to the rural areas, which is very much similar, as I mentioned about the previous study where they reported that the prevalence of aflatoxin was much higher in milk samples collected from urban areas compared to the rural areas. And the population had around 50% of growth impairment that we studied. So aflatoxins are very much important because we can kill the pathogens, foodborne pathogens, when we cook the food. But if the aflatoxin is present in the food, then it is very hard to get rid of those aflatoxins. We have to just discard the food, or there are some research going on where people have tried to develop some methods. They have used radiations, ultraviolet radiations, to destroy this chemical, but still that research is limited to the laboratory and is not commercialized. So what is the way forward? How can we control this important One Health issue? So I think there is a strong need for the implementation of integrated surveillance programs, so we can control aflatoxins. We can detect aflatoxins in feed. We can detect aflatoxins in food items. We can monitor human population, animal population, and with that we can prevent the entry of aflatoxins in a food system and also to the human body. Then also there is a strong need for the awareness and education programs, because our farmers and consumers both, they don't know, even very well educated people, they don't know about this aflatoxin issue. And farmers, they feed animals is sometimes highly contaminated with fungi and aflatoxins, and that basically aflatoxin goes to the animal body. Then that aflatoxin comes through meat and milk to the food supply chain, and then goes to the human body, and it affects the animal as well as humans both. Also, we need to produce climate resilient crops and better agriculture and storage practices. Storage practices are also very important because we don't have very good storage practices, and when there is not enough good or appropriate storage practices, then there is a high chance of humidity or a water content in the feed items that basically help the fungus growth, and that fungus then produce the aflatoxin. So there is a need to develop a good storage facilities. Also, there is a need to develop global partnerships to tackle the rising threat of aflatoxins in a changing climate. And lastly, I think this all we can achieve through a One Health approach, where we can involve agriculture, health, and environmental sectors, which are the key sectors in One Health approach, and we can control aflatoxins through entering this food supply and then to the human body. Thank you very much.
Thank you, Dr. Rahman. Do we have any questions for Dr. Rahman?
That's a very good question, and I think we all have the same question. But because Pakistan is like in the start of particularly this digesting or you can say adopting One Health concept, and I will give you just a small example. Like we have recently started a One Health degree program in our university, and we try to get that program approved in 3 years because the reviewer of the program, which should and which is of course highly qualified person, he was not even convinced with this One Health terminology or approach, and he was asking to change the nomenclature of this degree because One Health is okay, it's not very important. Something like vast and public health, which we already have. So I totally agree with that. It's really difficult to develop collaboration and to put all the sectors together. But I think with the passage of time, we will move forward, and with some baby steps, slowly, we will be able to have One Health approach, and we will have some good surveillance plans for using One Health approach for animal disease and human disease control.
You suggested that there should be a surveillance program in early detection. So do we have any one-step test to detect the aflatoxins that the consumer end, like in the product or the animal health or feed or plant material, anything? Do we have any test for the detection of the aflatoxins?
Yeah, there are several. There is ELISA. You can perform different ELISA to detect aflatoxins. The best method is to perform HPLC, which is very much reliable, and it quantifies basically the quantity of aflatoxins. So the two studies which I showed you, from the urine samples, we performed ELISA, which sometimes like overestimate the result, but HPLC is very much reliable, and we can perform HPLC and detect aflatoxins in feed, food, even human samples. These were basically the metabolites. So normally when fungi contaminates the food item, it produces aflatoxin B1. And that aflatoxin B1 goes, if it goes to the animal body, then that aflatoxin B1 is converted into aflatoxin M1. So in one of the studies, we detected aflatoxin M1, which comes in meat and milk. And also, there is another product that is aflatoxin B1 lysine adduct. In the other study, we detected that aflatoxin B1 lysine adduct, which is more consistent. And if you want to have a better picture of the quantification of aflatoxin, then detection of aflatoxin B1 lysine adduct, that is product of aflatoxin B1, is more reliable.
Much better. You can hear me okay? Yeah. I see the crowd thinning out. I know. It's getting late. I'm going to be very quick, I promise. Yeah, there we go. Just to reintroduce myself briefly, I'm Amy Chang. I'm a senior One Health specialist and program analyst for PATH, specifically our epidemic preparedness and response program. And so through our implementation experience, I thought the best topic to speak on today briefly was our activities that are utilizing a One Health approach, namely how we've supported the integration of climate and weather data into emergency operations centers across various country contexts. So one of the benefits of presenting last is that I don't think I have to convince anyone in this room that climate change poses a huge challenge to global health progress towards the SDGs and beyond. This is obviously felt very acutely here in Pakistan. I had here on my notes at the end of 2022, 8.2 million people were internally displaced due to natural disasters. I believe it is actually quite a bit higher. As of today, I believe it's closer to 30 million. looking across natural disasters, including floods, earthquakes, drought, extreme temperatures, and beyond. And as mentioned in various presentations today, the secondary impacts are just as devastating. Standing floodwater and other flood effects create vector-borne diseases, waterborne diseases, among other health issues. So just a little bit of framing for those of you who don't know, emergency operation centers or public health emergency operation centers, EOCs, POCs, it kind of depends on the country context specifically, how they're utilized. But at their core, they're units that use data to detect and manage disease outbreaks and other public health threats. Past work on EOCs has focused on context-specific efforts that have helped countries to better identify risks and assess available resources, develop emergency procedures, and create training programs. We've worked across a number of countries, Vietnam and Laos. I'll speak on briefly here, a couple concrete examples, but Cambodia, Senegal, and in DRC, we helped create the country's first mobile EOC, and those units have been used to address emerging and re-emerging polio and Ebola outbreaks. EOCs differ quite a bit from administrative health institutions as they are based on command and control approaches. They must cut across the regular hierarchies and procedures when necessary since they are emergency-based on a case-by-case basis. So, blending the two. Outside of the traditional or oftentimes siloed usage of EOCs, there has been a growing shift to operationalize them to address climate change issues that thereafter impact health. Risk mapping can be accomplished via a variety of methods. Machine learning is an increasing area of focus. An example in Vietnam, I may be getting ahead of myself here, but shortly uses climate data and more specifically actually weather data. We often speak of climate as kind of this writ large umbrella area, but weather such as precipitation and heat indices can be overlaid with malaria cases, divided by geography to configure learning models to recognize consistencies and correlations between the two. The knowledge of preparedness can help pre-position vital health resources, so pre-procure things for outbreaks and other health emergencies. On the slide here, there's a brief example in Ghana. Specifically, they've used GIS mapping tools to create climate dashboards to predict changes in transit routes, vector habitats, and so forth. So getting on to a few very quick examples from the past. Right here, this is in Vietnam. Our team is harnessing the potential of machine learning-based tools to enhance predictive capabilities. This is achieved through identifying areas of high risk, future outbreaks based on climate and environmental factors. An important component of this work is that we use non-traditional data feeds, such as the European Space Agency climate data, the Normalized Difference Vegetation Index, NDVI, that was a new one to me. And among others, these outcomes can be disseminated through open source tools in order to replicate these activities for other climate affected countries and diseases in country context. So just briefly here, you can see that the precipitation index for Vietnam overlaid with malaria cases. And I believe on the next slide, we have the dashboard for an example in Laos. These are on the Tupaya dashboard. It is just their integrated dashboard of choice. There's a variety of ways to do climate dashboards, but typically utilizing data systems like DHIS2 or other relevant data sources you can input and analyze across the different overlays. So here you can see the two different examples, I believe. I'm squinting here to see. We have total rainfall and observed temperature, climate in the first, and then in the second, there's malaria deaths by district all the way down to the facility level. So you can go all the way up to provincial level and then get down to facility and then overlay with that climate data. So I'll stop there because I know we're all tired, but let me know if you have any questions.
Thank you. Do we have any questions?
Otherwise, I know Aaron is.
There's a question about.
Hello. So my question is, are we only concerned about the infectious diseases related to climate, or are we also concerned about the non-communicable diseases?
This is a very good question. The work that we've actively done in these countries through our project implementation is primarily focused on zoonotic and infectious diseases. But that to say, emergency operations centers are used for a variety of purposes, right? From what I've heard and learned over the past week here in Pakistan is polio is the primary focus of the emergency operations centers in the country. It's very much context specific and driven by the community need for whatever is the ongoing crises or whatever the focus of the government or the entity that is running the EOC is. So certainly I think it can be adapted to diseases outside of infectious diseases, but because of the unique and One Health qualities, right, of the climate data, infectious diseases, vector-specific diseases like arboviruses, that's why that's our initial pilot focus, right, and from there it can be expanded. Okay,
Thank
Aaron,
you.
I believe you're online.
Do we have any other questions?
Yes, yes. Yes.
Relating the weather data as well as the environment related data along with the health threatening data, right? That's how it would be.
Exactly right. And the weather data is predicted as well. So I believe this is projected rainfall, right? So the machine learning takes the input data and through the correlation, seeing the trends between vector-borne diseases like malaria and potential precipitation, past precipitation, it can do modeling into the future as well as modeling just between the two, between the disease burden and climate.
Thank you, Amy.
Okay, I would now like to invite my colleague, Erin Sorrell, faculty and a senior scholar at the Center for Health Security at Johns Hopkins. Erin, good to see you.
Good to see you. Wonderful. Thank you all and good afternoon. I know it's been a long day and I think as Amy mentioned, the pleasure of going after so many fantastic talks where there's been discussion on One Health, on disease preparedness and response, but I also know that I am in between you and the closing ceremonies. So I will be sure to be succinct and to capture some of the conversations through a climate-driven risk assessment for One Health preparedness and response. And really what I want to talk about briefly today is the importance of considering climate change and environmental drivers when we look at mapping One Health preparedness and response plans. What and who do we consider? And so when we look at environmental degradation, loss of biodiversity, those amplify risks of future pathogen spillover from animals and environmental sources. Those risks fall into human hosts and the human population and can impact both local and regional livelihoods and well-being. And so this type of risk really requires a variety of what we would consider non-traditional partners across government, non-governmental organizations to identify, assess, and evaluate the risks to both environmental, agriculture, aquaculture, wildlife, plant, and human health. And then when we consider this One Health approach, it's deeply interdisciplinary, it's cross-sectoral, and it provides a great framework that a variety of professionals and communities and social groups can adhere to. So it's not just for zoonotic disease interfaces. So the complex interactions that impact human health require this integrative health risk assessment approach. And that really acknowledges the interconnection of human, animal, and environmental health. And so we think about trends and drivers for disease emergence. We can kind of capture those into three major categories: environmental, geopolitical, and socioeconomic. But when we consider climate change and environmental drivers in a One Health approach, we can think about preliminary risks like rising temperature, droughts, rising sea levels, increased flooding events, ocean acidification, and extreme weather events. And all of these can drive food insecurity, water scarcity, access to clean water and sanitation, vector presence, vector density, vector range in terms of geographical range, risk factors for disease emergence and even reemergence, and ecosystem degradation. We've talked about secondary impacts of drivers, environmental and infectious disease. All of these issues can impact larger health systems, can impact the way people and animals move, both by choice and by force, can impact the way we govern at the national, subnational, and even regional, local levels, and can impact security, both in terms of physical security of our borders when we're looking at disease preparedness and response, but also in terms of global health security writ large. Risk is a function of probability and consequence. So we have to think about how likely a particular event is, and then how severe are the expected outcomes. Or expected consequences? What are the impacts? So really critical here when we think about these compounding risks, what are these hazards? Who might be harmed and how? And then figure out what are the necessary precautions to take. And those might evolve as threats evolve, as the environmental changes and particular outbreaks occur. And this is just, I think, a really helpful schematic that was put out by the Council on Foreign Relations, looking at how climate change is increasing the threat of disease emergence. And this addresses a number of factors, considering a number of items that I had previously mentioned in the earlier slide. But one of the key questions here is, how do we mitigate some of these risks? We can think about options for improved surveillance, multidisciplinary research, improved and accessible medical countermeasures, health equity, global cooperation, and reduced emissions. And I apologize for my son in the background. He is about to go to school. And then finally, looking at different multi-sectoral approaches to analyzing data, identifying gaps, and developing recommendations for action towards One Health system strengthening. And this is a tool that our team developed, the One Health Systems Assessment for Priority Zoonosis. It's in its 3rd edition. It's publicly available, and happy to share the link to the tool and the template. It essentially goes through a 3-phased approach to disease prioritization, to stakeholder mapping, analysis, and then recommendations. Bennett, you've got to stop. So when we look at disease prioritization and stakeholder engagement, the key here is really making sure that we engage the right sectors from the beginning, include environmental sectors, include individuals that might handle wildlife or aquaculture, to be able to discuss and identify selection criteria for key diseases that go beyond just the animal and human health interface. So thank you so much for your time and your attention, and I apologize for the background noise. Thank you so much.
Thanks, Erin. Do we have any questions, or shall we move? Well, I would now like to invite Dr. Bhutta to give his talk. Thank you, Dr. Bhutta, for joining us.
Thank you very much for asking me to join. Let me try and share my screen. So I was asked to speak to you, and I realize this is probably the last presentation of the day, to talk a little bit about what we need to do in the context of climate change, maternal child health in Pakistan. I'll be very brief. I'm going to cover 2 things. One is the context and relevance to maternal child health in low and middle income countries, especially Pakistan. What are the conceptual frameworks that guide our current thinking around how climate impacts health and health-related outcomes? And then I'm going to talk a little bit about the work that we are doing in Pakistan and the few projects that are focused on developing resilience and adaptation. So to this particular audience at this time of your particular conference, you very well realize that climate change is a threat multiplier, and it exacerbates pre-existing social, political, economic tensions. And we have seen this in the context of low and middle income countries affected by climate change. None so starkly as in Pakistan, where in 2022, as many of you well recognize and has been mentioned, climate-related floods impacted over 30 million people. Half of those were children, and 1/3 of the 1,800 or so deaths that were recorded in that time period were amongst children. So children, and especially women, are impacted disproportionately as a consequence of climate disasters. And we also recognize that the consequences of this have long-term implications, as I recently shared in terms of some of our estimates as to how much has that climate disaster impacted Pakistan's economy. Not only has Pakistan not been able to recoup much of the extensive economic loss that took place, and there are variable estimates as to how much it cost our economy, between $20 to $40 billion, but only a fraction of the promised external assistance actually materialized. And there are questions in terms of whatever materialized, did it actually get to the stakeholders in the way it should have? So how does climate change impact nutrition and health, particularly amongst women and children? We have conceptual frameworks. You've seen several one of those, and they relate to both the direct effects of climate, particularly heat, and indirect effects, which impact health and health-related outcomes through water quality, air pollution, and impact on the ecology of the living environment where people are in. But few people talk about what modulates this response, and this represents to a large extent conditions of social determinants of health that already impact health outcomes for the most vulnerable. And these are the modulators which multiply some of the negative consequences of climate, particularly for women and children. Pre-existing gender inequities, socioeconomic disparities, public health infrastructure and its functionality, and as many of you have talked about, surveillance systems and response systems, mobility. And as has been pointed out, the impact of climate, particularly in conflict and displaced populations, is disproportionately greater. These gender dimensions of climate change and heat-related risks are very well documented for South Asia. And they are related to, as I said, pre-existing conditions, and also the fact that women have relatively less opportunity than men to adapt and to change their work conditions, their living conditions, ranging from dress codes to timings. Women disproportionately are affected because they fetch water in most rural areas, and they also perform many tasks in the field, which increase their level of exposure. This has been highlighted in our recent report from WHO and the PMNCH on how we need to focus on some of these aspects in the context of maternal, newborn, and child health globally, and I would urge many of you to see it. I would also point out a very Pakistan-specific but excellent report, a qualitative report on what happens with extreme heat and ensuing crisis to women and children. And this is a qualitative report from the White Ribbon Alliance in rural Pakistan. More specifically, if you look at physiological mechanisms, and particularly the direction of effect and the quantification of effects, particularly heat is now recognized to impact intrauterine period growth and also lead to short and long-term impacts that can result in growth retardation, being born small, born prematurely, perhaps with increased risk of maternal morbidities like preeclampsia or hypertension, and be associated with significantly increased risk of stillbirths, which are babies being born dead or in utero or during the process of childbirth, and else also pointed out early neonatal mortality. We now have attribution data from low and middle income countries ascribing almost 4% of neonatal mortality to extreme heat events. So what can be done? And to address some of this, we have a body of work in Pakistan funded by a range of agencies that is specifically focused on understanding both the biology mechanisms and providing opportunities for building resilience and adaptation. This is not to take away from mitigation strategies. Those are important, they need to take place, but people can't wait for global agreements on reducing carbon emissions. Their lives are impacted here and now and today. And what I'm going to share with you are 3 projects which are currently underway in Pakistan. This one funded by the Wellcome Trust is trying to understand some of the biological pathways, vulnerability, and impacts of extreme heat on maternal and fetal outcomes. This is in several districts in Sindh, as you can see, and it uses existing data and biorepositories of information from longitudinal cohorts to analyze some of the risk factors related to adverse pregnancy outcomes. It also provides us an opportunity to assess inflection points or interventions that can impact both early pregnancy, pre-childbirth, and in the early postnatal period. And this prospective study is also trying to quantify some of the risk factors for adverse outcomes related to work during pregnancy, and also the interface of climate with indoor air pollution. The second project or series of projects that we have is trying to see if we can capitalize on our large Lady Health Workers program, which is our largest community program that interacts with primary care and women and children in rural populations, to see what they can do to promote climate resilience and adaptation in the most vulnerable populations. And here I would highlight two projects. One is this body of work underway in Sangar, a extremely flood-affected district in Sindh, where we're working to train lady health workers and their supervisors in screening and providing some first-level support for mental health disorders as a consequence of climate-related emergencies and consequences thereof. And this is a body of work funded by Grant Challenges Canada, which looks at objectively quantifying the impact of these interventions at scale. And the last project I want to talk about is a complex project, again, in several districts of Pakistan, funded also by the Wellcome Trust as well as IDRC, on looking at what can be done at community level, taking communities, increasing awareness and adaptation, and in terms of preparing and responding to early warning systems, both existing within our NEOC and also those that can be identified by local resources. Personal cooling interventions, particularly in extreme heat, as well as participatory processes to improve the environment and living conditions, which also includes provision of shade, building facilities for hydration during extreme heat periods, and protecting the most vulnerable sections of the population. And this looks at also objective measures to look at community resilience and adaptation. So thank you very much for the opportunity to share some of this with you. And if there is stamina and interest, I'll be happy to answer questions.
Thank you, Dr. Butta. Do we have any questions for Dr. Butta?
I can't hear the question, just so that you know.
Dr. Butta, I had a question. So the work that you've been doing, funded by the Wellcome Trust, that looks at adverse outcomes, birthing outcomes, as well as maternal outcomes on heat stress. How does that correlate with similar studies in other parts of Latin America or Africa, or do you expect similar outcomes in Pakistan as well?
We probably expect outcomes in the same direction. And as you know, the Wellcome Trust has this large body of work taking place in Africa and South Asia concurrently. So there are 3 or 4 large consortia working on this issue. I don't anticipate this would be extremely different in terms of direction of effect, but the severity varies. So as you know, extreme heat is very unusual of this nature in Latin America. And even in Africa, extreme heat that we are talking about of the kind that we see in Pakistan and parts of India, average temperatures exceeding 45 degrees centigrade, high rates of humidity, are extremely unusual in Africa. And so there is a concept that perhaps some of the effects of heat are also dependent upon prior exposures and community resilience. The other big difference between various regions is we have very little information on the interface of undernutrition and adverse outcomes in certain periods of pregnancy and childbirth. And that relates to things like maternal undernutrition. Rates of maternal undernutrition in South Asia are very different from Africa. So to cut a long story short, I think while the broad directions of effect, the biological mechanisms may be similar in various populations, some of the impacts and severity are modulated by pre-existing conditions, and also some of the physiological milieu in which people live. And I think that is what this whole body of discovery work and focusing on mechanisms and understanding the biology will help identify.
Thank you. Thank you, Dr. Butta. If there are no further questions, we would like to thank Dr. Butta, our other fellow panelists, for joining us today. Thank you. Thank you to the audience.
Thank you.
Thank you, everybody, and I promise this is all. So without any further delay, I would like Edina Killing, our program analyst, she will do a vote of thanks. And then we conclude our session today. Thank you for coming.
Good evening, everyone. This has been such an incredibly productive day. And as we draw to a close, I just want to take a moment to thank everyone that made this possible. First and foremost, thank you to our chief guest, Honorable Dr. Malik Mukhtar Ahmed Barra, for his wonderful welcome speech. Next, I'd like to thank all of our distinguished keynote speakers, starting with Aaron Sorrell, Dr. Hamad Ali, Dr. Amir Khan, of course, and Mr. Mohammed Arshad Kaim Khan. Thank you to all of our amazing panelists. Your discussions are actually the reason that we all came here today. Keep doing all the amazing work that you've been doing. And a special thanks to our partners, PATH, Johns Hopkins University, MERF, UVass, HSA, and Green Star. Your guidance has been so valuable in the preparation of this conference. And of course, we're really thankful to Comstech for this beautiful venue and for the staff that have just been incredible. We have been staying at Comstech for the last week and they've been so amazing. And lastly, I want to thank all of you. I know for our in-person folks, it was not easy to travel here and some of you have traveled across the country and across the globe. So we really appreciate that. And with that, I would like to close the conference. There is some tea outside if you would like some, stay and mingle. But have a great rest of your evening. Safe travels.
Thank you, everyone. I'm only speaking to the partners here that, there is a separate event from 7 p.m. onwards for the partners. And please stay if you are staying or you are going home and coming back, depends. But if you are invited, there was an invitation that went out. And especially the partners, we request that you come back, by 7. The program is on the 6th floor and we will be escorting you. So thank you so much again. Safe travels home.